Good morning everyone. My name is Dr. Chandini. I'm a faculty at the Medico and I'm a consultant pediatrician working in Thrissur. I did my post-graduation from Government Medical College, Kozhikode. So today we are going to have a comprehensive revision series on the subject of pediatrics. As you all know, pediatrics is one of the core subjects which are frequently asked in the NEET-PG examination. But the unique feature of pediatrics is that the questions are repeatedly asked from the same areas. So today in this discussion, I have tried to highlight those high-yielding areas or the so-called hot topics so that the most of the MCQs which are very frequently asked will be covered in this session. And the general pediatrics, this is the topic list here which I have taken. So first, topics include growth and development, neonatology, IEM, genetic and syndromic disorders, immunology, etc. All these comes under the heading of general pediatrics. And in the pediatric point of view, this is the most important, the core pediatric subjects. So we're dealing with questions from these areas first, and after that we'll move on to the systems. So let's begin our discussion. Okay, moving on to the first question, which comes under the heading of nutrition. The question is, kwashiorkor is due to the deficiency of A. Proteins, B. Minerals, C. Vitamins, and D. Zinc. This is a very straightforward question. All of you might be already knowing the answer. Yes, kwashiorkor, it occurs due to the deficiency of proteins. So, what is the topic that is being covered here? The topic we are going to address here is protein energy malnutrition. PEM. So protein energy malnutrition is not just malnutrition, it's actually a spectrum of diseases varying from undernutrition to overnutrition or obesity. So just mentioning a few points about obesity. What is obesity? In children, the cutoffs for obesity is different from what you study in adults. So we are calculating the BMI percentiles here. And the BMI percentile, if it is more than 85, the 85th percentile, we call it as overweight. And if it is more than 95th, you call it as obesity. Okay, so this is the definition of obesity in pediatrics, just mentioning it here. Now moving on to the topic in particular, that is protein energy malnutrition. So protein energy malnutrition here, kwashiorkor, that is a question, right? So what is kwashiorkor? It comes under the specific heading of severe acute malnutrition. Okay, severe acute malnutrition. Now, what is the definition of SAM? This is a very important question. What is the WHO definition of severe acute malnutrition? This has been frequently asked. The WHO definition of severe acute malnutrition mainly includes 3 limbs. The first one is the weight for height. It should be less than -3 standard deviation. Second one is mid-upper arm circumference. MUAC, as you all know, is an age-independent anthropometric index, which is always measured in the left upper limb. And if the mid-upper arm circumference, if it is less than 11.5 centimeter, it is diagnosed as SAM. And the third one is presence of edema. The more important point that you have to note here, this is all OR. The presence of any of the 3, if it is present, we can call the definition as severe acute malnutrition. So I hope the definition of SAM is clear for you. Weight for height, please don't confuse. It is weight for height less than -3 standard deviation, MUAC less than 11.5, and presence of edema. So that is SAM. Now SAM again can be divided into 2 types. It can either be marasmus or it can be kwashiorkor. So how is it different? What happens in marasmus and what happens in kwashiorkor? Marasmus and kwashiorkor. So what happens when the child is deprived of proteins and the nutritional substances? Initially the baby or the child goes into a state of adaptation. That is, the baby tries to cope up with the stressful situation. That is known as adaptation. So marasmus is a state where the body is adapting itself to the stressful process. When this adaptation is lost, that is when there is disadaptation, then it is known as kwashiorkor. So it's the compensated state is marasmus and the uncompensated state is kwashiorkor. So obviously the most severe form of malnutrition is kwashiorkor. Okay, and now we'll just have a look at the table comparing marasmus and kwashiorkor. So the age group, marasmus is usually seen in infants less than 1 year of age. Kwashiorkor is generally seen in a little bit older children, that is 6 months to 3 years of age. And marasmus, it occurs because of calorie deficit. The question here was, what was the deficiency in kwashiorkor? Kwashiorkor, the deficiency is protein deficiency. Marasmus, the deficiency is calorie. So whenever there is protein deficiency, it means that there is hypoalbuminemia. Hypoalbuminemia means albumin is the one which contributes to oncotic pressure. So when oncotic pressure falls, obviously there will be edema. So kwashiorkor, the edema, the presence of edema is the most important characteristic of kwashiorkor. So if in a question the term edema is present, then the answer will obviously be kwashiorkor and never be marasmus. So please, this is a very important point. Presence of edema, it always means that kwashiorkor. And about nutritional edema, this type of edema is also referred to as nutritional edema. And where does nutritional edema happen? It usually happens over the dependent parts of the body. In case of children, what the most common site where you look for this nutritional edema in the dorsum of the feet. That is also known as pedal edema. How will you look for pedal edema? The pedal edema, you look for pedal edema like this. That you press on the dorsum of the feet simultaneously. And for how long you will press? You will press for a time period of 3 seconds. And then you release it. And if this indentation is present, then it is said to have edema positive. And the diagnosis will be kwashiorkor. Okay, I hope that is clear. Now, what will be happen to the mental status of the patient in the case of marasmus and kwashiorkor? In the case of marasmus, the child will be more alert and the appetite will be okay. There will be appetite to be present and there is no apathy, or the child is more or less alert. But kwashiorkor, what is happening? There is loss of appetite and the child become apathic. And here comes another important question. What is the triad of kwashiorkor? The triad of kwashiorkor is apathy, mental retardation and edema. That is the triad of kwashiorkor. So the presence of apathy, it stands for kwashiorkor. Now, severe muscle wasting is seen in marasmus, whereas in the case of kwashiorkor, muscle wasting is mild or absent. Prominent ribs, because of the severe muscle wasting, the ribs are seen prominently. Prominent ribs are seen in marasmus, whereas in kwashiorkor, you see more or less of a protuberant abdomen. Why the abdomen becomes protuberant? It is because of the excessive fat accumulation in the liver, and sometimes there can also be ascites because of the severe hypoalbuminemia. And the special features are, in the case of marasmus, the child will be alert and there will be loose wrinkled skin because of the loss of subcutaneous fat. The baby will be having a loose wrinkled skin, also known as old man appearance or monkey facies. These 2 points comes under marasmus, and there will be baggy pant appearance. There will be loose skin folds can be seen over the buttocks areas. That is known as baggy pant appearance. Whereas in the case of kwashiorkor, you can see moon face. Moon face is also known as a cushingoid facies. See, why does this cushingoid facies occurs? Because in the case of marasmus, there is increase in the level of steroids. The corticosteroid level will be increased in the child, and because of that, the child will be having the moon facies. And there are 2 important dermatological findings, that is flaky paint dermatosis, also known as crazy pavement dermatosis. It is a peculiar nutritional dermatosis that you see in kwashiorkor. And in the hair, you can see flag sign. What is flag sign? Flag sign, you can see that if you look at the hair shaft, there will be alternative areas of hyperpigmentation and hypopigmentation. This is known as flag sign. So these are the important signs that you see in kwashiorkor. Now we look at some of the images here. This is a child with marasmus. See, you can see all the features here. The old man appearance. The child is having a loose wrinkled skin with severe prominent muscle wasting is there, and the ribs are very prominent. And also, this is what is known as the baggy pant appearance because of the loose skin folds that are seen in the buttocks and the thigh. Now, these are the most important points, and if you want to go a little bit extra edge, there is one thing known as how do you grade marasmus. So the grading of marasmus is done depending on where you see the wasting. Okay, so it is divided into grade 1, 2, 3 and 4. So you can remember it like A, B, C and B. It's not A, B, C, D, it's A, B, C and B. So it is, if the grade 1, if the wasting is seen in the axilla and the groin. Grade 2, if it is seen in the buttocks, B for buttocks and the thigh. Grade 3, if it is seen on the chest, C for chest and abdomen. And grade 4, if there is the loss of buccal pad of fat. So this can be asked as a question, which is the last structure to be affected, which is the last site for wasting occurs in marasmus. It is always the buccal pad of fat. So it is axilla and groin, grade 1. Grade 2 is buttocks and the thigh. Grade 3 is chest and abdomen. And grade 4 is loss of buccal pad of fat. This is the grading of marasmus. Now moving on to kwashiorkor. So this is this can be asked as a picture question for you. Here you can see the child, the protuberant abdomen is there. There is severe edema is there. And you can also see the dermatosis. The skin is showing the nutritional dermatosis changes. This is the picture of nutritional edema, and this is your crazy payment dermatosis. Okay, now kwashiorkor also have this grading, but the kwashiorkor, the grading is depending on where you see the edema. So it is again divided into 4 grades. If the grade 1, if the edema is seen over the feet. Facial edema means grade 2. Chest and paraspinal grade 3. And presence of ascites means it is the most severe form. That is grade 4 if there is ascites is present. So these are the important points pertaining to marasmus and kwashiorkor. What are the other important things that we have to learn about this? We have to also learn about the management of protein energy malnutrition. It is very important, the 10 steps in management. Please go back to your notes and read about this because it's a very vast topic. I don't have time to explain everything in detail. But the key points I'll discuss, that is what is the important, the vicious triad of kwashiorkor, of severe acute malnutrition is present. It is associated with high mortality. It is hypoglycemia, hypothermia, and infection. And what is the criteria for diagnosing hypoglycemia? If the GRBS is less than 54, again an important MCQ. The cutoff for GRBS, to call it as hypoglycemia in a child with severe acute malnutrition, if it is less than 54. And what is the cutoff for calling hypothermia? If the axillary temperature, it is less than 35 degree. So that is the definition for hypothermia. So the triad is hypoglycemia, hypothermia, and infection. And another common question that is being asked from this area is, when do you start iron? So the management of SAM has been divided into a stabilization phase and a rehabilitation phase. So iron is always started in the rehabilitation phase. That is after the first week. That is the 2 to 3 weeks time period, iron is started, because iron is a substance which can cause increased generation of free radicals. So in order to decrease the free radical injury in the initial period, we do not give iron in the initial first week, and we start iron always after the stabilization phase, that is always in the rehabilitation phase. And then you can just go through the steps of management of SAM. Sometimes a question can be asked from that area also. Okay, so that finishes off SAM. Now we look at some of the important classification systems with respect to protein energy malnutrition. So we have different classification systems for weight, height, and weight for height. So what is the classification system which is being used for weight? It is IAP classification. So here you can remember it as everything is done under divisions of 10, and it starts from 80. So if it is more than 80, it is normal. 71 to 80, it is grade 1 underweight. 61 to 70, it is grade 2. 51 to 60, grade 3. And if it is less than 50, it is grade 4 underweight. And what does the terminology K stands for? If there is presence of edema, then the denotation that is being used there is K. Okay, that can also be asked as a question for you. Then, how is height for age classified? This is known as Waterloo's classification. So, Waterloo's classification is a classification that is being used for height for age as well as for weight for height. For height for age and weight for height, the name of the classification system is Waterloo's classification. And in the case of height for age, the divisions are in 5. And it starts with 95. So more than 95 is normal, 90 to 95 it is grade first degree standing, 85 to 90 second degree, and less than 85 is third degree standing. And similarly, weight for height. What is weight for height? That mainly stands for wasting. So weight for height, again the classification system name is Waterloo classification. Here the divisions are in 10. More than 90 normal, 80 to 90 first degree, 70 to 80 second degree, and less than 70 third degree. So very easy. For height and weight for height, it is Waterloo classification. For weight, it is IAP classification. Weight, the divisions are in 10. Height, the divisions are in 5. And for weight for height, the divisions are in 10. Very easy to remember. And then there is another classification system known as Wellcome Trust classification. What does this Wellcome Trust classification mean? This Wellcome Trust classification is made to make the classification between marasmus and kwashiorkor. So here the parameters that we use is weight for age and presence or absence of edema. So here it's just simple logic, that is 60 to 80%. The weight for age comes between 60 to 80% and the child has edema. It means that the child has got, if the presence of edema, it is kwashiorkor. That's the key. So then it is kwashiorkor. If the weight for age is 60 to 80% but there is no edema, then it means that it is not SAM. It is merely a case of underweight. If the weight is less than 60% and there is no edema, then it is marasmus. If the weight is less than 60% with edema, then it is a combination of the two known as marasmic kwashiorkor. So that is Wellcome Trust classification. So these are the important points with regard to severe acute malnutrition or protein energy malnutrition. Most of the important MCQ points have been covered. The management of SAM, please go back and refer to your notes and read again. Okay, now we'll go on to the second question. Yeah, before going to the second question, one important spotter question which has been asked previously. What is this tape? What is the name of this tape? Yes, this tape is known as Shakir's tape. Why is it used? It is used in community settings in order to identify children with severe acute malnutrition. What is it measuring? The Shakir's tape is done for checking the mid-upper arm circumference. So here, this is an image where the Shakir's tape is being used for measuring the mid-upper arm circumference. So it can be divided, color coding is done. It's red, yellow and green. That is 0 to 11.5 centimeter means red, 11.5 to 12.5 is yellow and 12.5 to 26.5 is green. So this means less than 11.5. 11.5 to 12.5 is yellow and more than 12.5 is green. So if the child, if you measure and if this square shaped area is falling in the red zone, it means that the child is having severe acute malnutrition. So it is predominantly being used by peripheral healthcare workers to find out the children who are having severe acute malnutrition from the community. So that is known as Shakir's tape. Okay, now moving on to the second question. Which of the following rules out protein energy malnutrition? So we have already discussed the definition of SAM, so we'll try answering this question. BMI more than 17. BMI is not under it does not come under the definition of severe acute malnutrition, and it cannot be used for the definition of SAM because edema might be contributing to the weight. So we cannot rule out SAM simply by looking at the BMI. Second one is normal lean body mass. What do you mean by normal lean body mass? It means that the weight for height is normal. But under the definition of SAM, the important criteria is the presence of weight, the weight for height will always be less than -3 standard deviation in SAM. So normal lean body mass will never be consistent with the diagnosis of a protein energy malnutrition. Normal skin fold thickness can occur in patients with SAM, and normal ECF volume can also occur in children with SAM. So presence of normal lean body mass rules out protein energy malnutrition. Wasting is always seen in SAM. Okay. Next question. The best indicator of some dehydration in SAM is. Why is this question important? Because to assess dehydration is very difficult in a child with SAM because they already have wrinkled skin, they already have loss of subcutaneous tissue, the eyes will already be sunken. So sunken eyes, can it be used as a marker of some dehydration? No. Lethargy, no. Already the child might be having apathy because of the protein energy malnutrition, and skin pinch may be already prolonged because of the loose skin fold. So the only measure that can be used as, or the best indicator of some dehydration in SAM is thirst. So another MCQ point, any child who is presenting to you with SAM and with history of loose stools, treat it as dehydration. Okay, treat it as some dehydration. If there is history of loose stools and the child is fitting into the diagnosis of SAM, even if there is some amount of loose stools also, you treat it as some dehydration. Okay, this is the question that is being given here. And next question is, an Anganawadi worker takes weight and height of a 4-year-old and finds out that the height for age is less than -2 standard deviation. What is the likely cause? So here we need to understand a bit of the concept. So we have three parameters: weight, height, and weight for height. So what happens to the weight of the child if they develop an acute illness? For example, even for a normal child, if the child catches a fever or a loose stool, what will happen to the weight? The weight will come down. Does the height come down with that acute illness? No, the height will remain normal. So the weight has come down, but the height is normal. So what will happen to the weight for height? It will also come down. So in any acute process, the weight and the weight for height will be less, but the height will be normal. But what if the child is having a chronic condition? For example, the child is having some cyanotic congenital heart disease, or the child is a patient who is having some neurological problem like cerebral palsy. So because of that chronic disease process, the growth of the child is very much decelerated. So the height of the child will be less. In the case of an acute condition, it will be the height of the child will be low, because the growth is faltered because of the chronic systemic illness. And what will happen to the weight of the child? Since the height of the child is low, the weight also will be less. But the weight for the height, that is the weight of the child, will be adequate for the height of the child. So the weight for height will be normal. So in a chronic illness, the height will be less, and because the height is low, the weight also will be correspondingly low, but the weight for height will be normal. That is, for that height, the weight will be normal. I hope that is clear. So here you'll again look at this. So if the weight for age is low, but the height for age is normal, and the weight for height is decreased, it means that acute malnutrition is an acute illness which has caused the malnutrition. If the weight for age is reduced, height for age is reduced, but the weight for height is normal, it means that chronic. So if all three are decreased, it could be a chronic. Already the child might be having a chronic illness, but on the top of that, for example, a child with cerebral palsy developed a pneumonia. So what happens? Already the height is less, the weight is less, but the weight decreases further because of the acute disease process. So the weight for height also will be decreased. Then it is acute on chronic. So this is a simple concept. So if all three are decreased, it is acute on chronic malnutrition. If height and weight are decreased, but weight for height is normal, it is chronic malnutrition. If height is normal, but the rest two are decreased, then it is acute malnutrition. So this is the concept which has been asked in this question. So we'll try to answer this question again. So here, what happened to the height for age? The weight and height of the child is taken, and they have only mentioned about the height for age is less than -2 standard deviation. So we assume that the other two parameters are normal. So what will be the diagnosis? The diagnosis, it is a case of chronic undernutrition. I hope that is clear. And I just want to tell you about another classification system, the WHO classification system. The WHO classification system has been provided for weight, height, and weight for height. It's very easy. It's the same cutoff for all the three. It's not very confusing as you have learned in the IEP and the Waterloo's classification. The cutoffs are very easy. So that is, if it is more than -2 standard deviation, -2 to -3 standard deviation, less than -3 standard deviation. The terminologies that you use are also, if it is more than -2, it is considered normal. -2 to -3, mild. If it is less than -3, it is moderate. And if it is less than -3, it is severe. There is no mild here. Normal, -2 to -3 is moderate, less than -3 is severe. And the terminologies that you use for weight is underweight. So here it is normal. If it is -2 to -3, it is moderate underweight. If it is less than -3, it is severe underweight. Similarly for height, stunting. -2 to -3, moderate stunting, less than -3, severe stunting. Weight for height, the terminology that we use is wasting. -2 to -3 is moderate, and less than -3 is severe wasting. So this is the WHO classification. So WHO classification is based on the standard deviation score. It's not the percentage score. The standard deviation score is used for the WHO classification, and the cutoffs are same for all the three, just the terminologies are different. Okay, so that is that. Now moving on to that we have completed about the important points in the protein, energy, malnutrition, and some important points about the growth. Now, identify the next question. Identify the correct statement in an infant with a birth weight of 2.8 kg. So here the examiner is trying to assess your knowledge on what happens normally to the child when he grows. What happens to the weight, what happens to the height, and what happens to the head circumference. So first we'll see what happens, and then we'll try to answer this question. Okay. So, first we'll see about the weight. The baby is born with a birth weight, and the normal birth weight in Indian population is between 2.5 to 3 kg. And what will happen? The child at the time of birth will be having a lot of edema fluid over their body. And initially, this edema fluid is lost. So first, what happens? There is some amount of weight loss happening to the body. And this usually happens in the first 1 to 7 days. And what is the amount of expected weight loss? It should be less than 10%. If it is more than 10%, that means that the child is having excess weight loss and we have to look for causes like dehydration. So in the first 7 days, there is some degree of weight loss and the amount of weight loss expected is less than 10%. And what will happen in the next 7 to 10 days? In next 7 to 10 days, the weight is regained. So by day 10, what happens? The birth weight is reattained. So initially there is a weight, then there is a weight loss of 7 to 10%, and after day 7 the child gains weight, and by day 10 the birth weight is reattained. So that is what happens in the initial 10 days. And what happens after the 10 days? Then after the first 10 days, in the first 3 months, the expected weight gain of the child is around 25 to 40 gram per day. That is, every day the child, you can take it as an average of 30 also. Every day the child up to 3 months of age, the weight gain of the child is around 30 grams per day. Okay, that is what happens in the first 3 months. Now what happens after the first 3 months? After 3 months, you can use the formulas for calculating the expected weight. So 3 to 12 months, the expected weight is age in months plus 9 by 2. 1 to 6 years, it is 2x plus 8. You all know the formula, 2x plus 8. And 7 to 12 years, the formula is 7x minus 5 divided by 2. Okay, so initially there is a weight loss, birth weight is regained by 10 days, first 3 months 30 gram per day, and after that you use this formula. And another question that has been asked is, what happens? When does the birth weight double? The birth weight doubles at 5 months, quadruples at 1 year, quadruples at 2 years, and becomes 5 times at 3 years. So doubles at 5 months, triples at 1 year, quadruples at 2 years, and becomes 5 times in 3 years. So these are the important points with respect to the weight of the child. Now we'll deal with the height. What will happen to the height of the child? So what is the normal height or the length of the baby when the baby is born? It is around 50 centimeter. And what happens in the first 1 year? The baby gains around 25 centimeter. So that at the end of 1 year, the length of the baby will be around 75 centimeter. And after that, what happens? The growth velocity becomes around half of this, at 12 centimeter. Okay, the 12 centimeter per year, and such that by the age of 4 years, the height is around 100 centimeter. Okay, so this is the table showing what will happen to the height. At birth, it is 50 centimeter. Then you learn about 1 year. 1 year, it becomes 7 centimeter. And 4 years, it becomes 100 centimeter. Okay, so when does the height doubles? Height doubles, that 50 centimeter becomes 100 centimeter. That is 2 times when the baby attains the age of 4 years of age. So that is what happens to the height of the child. And then you also have from 2 to 12 years of age, the formula that can be used for calculating the expected height is 6x plus 77, where x is the age in years. Okay, so 2 to 12 years of age, the formula used is 6x plus 77. Okay, now what happens to the third parameter is head circumference, right? So what happened to the head circumference of the child? The normal head circumference at birth is 33 to 35 centimeters. What happens in the first 3 months? So it goes like this: 2, 1, 0.5, 0.2. So first 3 months it is 2 centimeter per month. Then 4 to 6 months it is 1 centimeter per month. And then from 6 months to 1 year it is 0.5 centimeter per month. And then from 1 year to 3 years it is 0.2 centimeter per month. Okay, so this is what happens to the head circumference. You remember it as 1 to 3, it is 2 centimeter. 4 to 6, it is 1 centimeter. 6 months to 1 year, 0.5. And 1 year to 3 year, 0.2 centimeter. So this is what happens normally to the head circumference of the child. Okay, now we know all of this. Now we'll try to answer the question. Going back to the question. So identify the correct statement in an infant with a birth weight of 2.8 kg. So what is your impression about the birth weight? The birth weight is normal. So first option is weight gain of 300 grams till 3 months. Is it correct? No. The baby gains 30 grams per day. So 300 grams will be attained in just 10 days, not 3 months. So that is a wrong option. Increase in length of 25 centimeter. Yes, in the first year of life, the amount of height that is being gained is 25 centimeter. That is the correct answer. AF, anterior fontanelle, closes by 6 months. Wrong. When does the anterior fontanelle close? Anterior fontanelle closes at 12 to 18 months of age. And weight under 75th and height under 25th, no, it does not fit into this question, right? It does not pertain to anything. So the correct option is increase in length of 25 centimeter per year. That is the right answer. I hope that is clear. This is also very important. What happens the height, weight and head circumference, especially the head circumference part has been asked multiple times. So please by heart these values. Okay. Now, next important area is adolescence. Adolescence, the question here is early adolescence is. So what is adolescence? Yeah, as you all know, adolescence is basically a transition period from childhood to adulthood. And adolescence can be divided into 3. Okay, yeah, this is how adolescence have been classified. It can be early, middle and late. 10 to 13 years it is early, middle is 14 to 16 years, late is 17 to 19 years. 10 to 13, 14 to 16 and 17 to 19. Here the question is what is early adolescence? So it comes under the category of 10 to 13 years of age group. Now let's see some of the important adolescent related questions here. So adolescence is the most important change that happened to the body during the adolescence is puberty. Okay. So what happens during puberty in girls and in boys? So first we'll deal about girls. What is the first change of puberty which happens during the time of, in the case of girls? It is the development of the breast bud. That is known as telarchy. So important question, what is the first change of puberty which happens in the case of girls? It is the development of the breast bud or the telarchy. And that usually happens during this 9 to 13 years of age group. And then after that, what is the next change which happens? The next change which happens is the development of the pubic hair. That is pubarche. And the last change which happens is the final stage, the final pubertal change which happens in the case of girls is the development of menarche. So the first is telarchy and the last is menarche. And now, what happens in the case of boys? In the case of boys, the first change which you see in the puberty is increase in the testicular volume. Important question. So what is the first pubertal change which occurs in the case of boys? It is increase in the testicular volume. And the next change which happens after that is there will be increase in the penile length along with pubarche. And after that, there will be spermarche or increase in the production of sperms. And the last change which occurs in boys is the development of axillary hair. So the first one in boys is increase in testicular volume and the last is development of axillary hair. And another question that has been asked from this, when does growth spurt occurs? As you all know, it is growth spurt usually happens when the body is going through puberty. Initial first year of life, there is an increase in growth and after that, the major growth happens when the child reaches puberty. So when does this growth spurt occur? So you can see in this diagram, the growth spurt on females occur earlier than males. So growth spurt in the case of females, it usually occurs in an SMR stage 3, whereas growth spurt in boys, it occurs at a later adolescent stage, that is when it corresponds to an SMR stage of 4. And usually the growth at the time of this growth spurt, the growth velocity increases to around 9 centimeter per year in the case of girls and it is around 10 centimeter per year in the case of boys. Okay, so that is about the growth velocity and when does the growth spurt is a little bit delayed in boys, but it occurs earlier in the case of girls. That is another important point. Now, another 2 important points, what is delayed puberty and what is precocious puberty? What do you mean by precocious puberty? Precocious puberty means puberty is occurring earlier. And what is the cutoff? In the case of girls and the case of boys, the girls, it is 8 years and males 9 years. Pubertal change is happening before the age of 8 years in girls and before the age of 9 years in boys is referred to as precocious puberty. And the another terminology is delayed puberty. Okay, and what is delayed puberty? Delayed puberty, again, the cutoff is different for females and males. In females, it is 13 years and males, it is 14 years. So if there are no pubertal changes, that is the first pubertal, at least TLRK or the increase in testicular volume, the first pubertal change should occur before this age. That is 13 years in girls and 14 years in boys. If it is not happening, then it is known as delayed puberty. Okay, so these are the important points that you have to cover under the heading of adolescence, and this can be asked as a spotter question for you. What is this? This is a Prader orchidometer. And why is it used? For what purpose this is used? This is used for measuring the testicular volume. For looking at the testicular, so the initial stage is increase in testicular volume, right? So in order to find out how much is the testicular volume, the instrument that we use is this Prader's orchidometer. And yeah. Moving on to the next, that's all about adolescence. Now moving on to something about short stature. So next topic a few questions that will be coming up will be related to short stature. Okay, so we'll go to the first question. True about constitutional delay is or are. A is normal length and weight at birth, catch-up growth at 6 to 12 months, height, velocity assume normal rate at 2 to 3 years, and bone age more than chronological age. Okay, before understanding or answering this question, you should have some concept regarding short stature. So we'll discuss about short stature before trying to answer this question. So the topic is short stature. All of you might be knowing the definition of short stature, I assume. So what is the definition of short stature? If the height is less than -2 standard deviation below the population mean for age and sex. -2. And if the height of the child is less than 3rd centile. If it is less than -2 standard deviation, or if the height of the child is less than 3rd centile, it is referred to as short stature. And now, while discussing about short stature, there are certain terminologies that you should be knowing. What are they? First one is chronological age. Chronological age means it is the age of the child. If the child is 10 years old, then his chronological age is 10 years. Then you have something known as height age. What is height age? Height age means the age at which the height of the child is at its 50th percentile. For example, if you have a child who is 4 years old, okay, and the height of the child is just 75 centimeters. So, though his chronological age is 4 years, the height of the child 75 centimeters usually seen in 1 year of age. So, the age of the child with respect to that height is 1 year. So that is height age, that the age at which that particular height comes at the 50th percentile. So that is height age. And then we have the bone age. Bone age means what is the skeletal maturity. Bone age tells to us about the skeletal maturity of the child. So these are 3 important terminologies: chronological age, height age, and bone age. And then you have something known as what is the mid-parental height. What does mid-parental height tell you? The mid-parental height tell you about the genetic potential of the child. That is, if the father and mother are very short, the child obviously will be having a little bit less potential to attain the normal height. The genetic potential will be low. Similarly, the father and mother is very tall, the child have increased genetic potential to be taller. So, in order to look at the genetic potential of the child, what we calculate is the mid-parental height. So, what is the formula for calculating mid-parental height? Age of the height of the father plus height of the mother divided by 2, and if it is a boy child you add 6.5, and if it is a female child you subtract 6.5. Okay, so height of the father, height of the mother divided by 2 plus 6.5 if it is a boy, and minus 6.5 if it is a girl child. Okay, so that are the some of the important terminologies that you have to know. Now moving on to the types of short stature. Okay, so short stature can be divided into 2 types. It can be either physiological short stature or it could be a pathological short stature. First, we'll discuss about physiological short stature. What is physiological short stature? The height of the child is less than -2 standard deviation, but it is more than -3 standard deviation. That is between -2 to -3 standard deviation, then it is physiological. If the height of the child is less than -3 standard deviation, then it is pathological. Okay, so that is the definition for physiological short stature. And one second. Now, okay, so first we'll study about physiological short stature before moving to pathological. So physiological short stature again can be of two types: constitutional short stature or familial short stature. Constitutional short stature is also known as constitutional delay of growth and puberty, CDGP. That is constitutional delay of growth and puberty. So constitutional delay, what happens? This is very important. The child is born with a normal length at birth, and the child grows normally till around 6 months of age, 6 months to 1 year. And after that, there is a period of growth faltering. That is, a growth undergoes a period of deceleration. And after that, the child slowly, by the end of 3 years, the child slowly catches up the growth, and then there is a catch-up growth after 3 years, and the final height will be normal. So the key points are: birth, the length is normal. The deceleration usually occurs between 1 to 3 years of age. After 3 years, there is catch-up growth and the final height is normal. So this is constitutional delay of growth stature, constitutional delay of growth and puberty. So what will happen to the bone age of the child? Since there is a delay here, the bone age will be lagging behind the chronological age. So the bone age will be less than chronological age. And there can be history of delayed puberty. And even you can even get a family history of delayed puberty in the parents. Okay, the parents might also have experienced a similar type of growth curve. Initially it was normal, then they had a faltering of growth, and after puberty, after 3 years and by puberty, the growth spurt is re-attained and the final height is normal. So the key points here is: length at birth is normal, final height is normal, the bone age will be less than chronological age, and there will be history of delayed puberty. Now, what happens in familial short stature? As the name suggests, familial short stature is basically the child is short because the parents are short. Okay, so here what will be happening to the length at birth? The length at birth can be normal, or it might be a little bit reduced also. So length at birth will be like this, and the child continues to grow. There is no period of growth faltering, but the growth of the child will be always below the 3rd centile, below the normal growth curve. And what will happen to the final height? The final height will be less. The final height will also be short, but it will be normal with respect to the parents. With accordance to the if you calculate the mid-parental height, the child will attain the genetic potential, but when compared to the population norms, the final height will be less. So here what will be the bone age? The bone age will be equal to the chronological age. And what can you get? There will be a family history of short stature. Is there any history of delayed puberty? No, here you do not get any history of delayed puberty. Okay, so this is the concept that you have to know between constitutional and familial short stature. So here again revising about the table. Just understand the key points. Bone age is less than chronological age in constitutional. Bone age will be equal to chronological age in familial. The length at birth is normal in constitutional, can be normal or reduced in familial. There is a growth in early childhood is reduced. And the final height will be normal in the case of constitutional, whereas in the case of familial, the final height is reduced. Family history, you will get delayed puberty, and in the case of familial, you will get a history of short stature. So that is the concept. Here, this is the graph which I showed. So first we will see the graph of constitutional. So this is the graph. The child was growing normally, then there is a faltering, then the child catches up, and the normal height is attained. So what happens to the familial? The child is growing at its own pace, but is always less than the mean, and the final height is also low. So this is the two graphs. This can be asked as a pictorial question, and all these concepts that have been described can be asked in and out, like in different ways it can be asked. It's a very hot topic. Okay, you have to learn about this. So moving back to the question. So now try answering this question. So the question is, true about constitutional growth delay. Normal length and weight at birth? Yes. Catch-up growth at 6 to 12 months? No. The child grows normally in the 6 to 12 months. And height velocity assume normal rate at 2 to 3 years. No, it is after 2 to 3 years only the height velocity attains the normal rate. Born age is more than chronological age. No, in the case of constitutional delay, born age will always be less than chronological age. So the true statement is A, that is normal length and weight at birth. That is the true statement. Okay. So that's about physiological short stature. Now we look at the how to measure this as a simple diagrams. The measuring up to 2 years, we measure the length of the child, and the instrument that we use is known as the infantometer, and the measurement is done from the vertex to the foot, and the measurement is adjusted to the nearest 0.1 centimeter. And if the child is older than 2 years, you use a stadiometer, and there is something known as a Frankfurt plane. What is Frankfurt plane? It is a horizontal line connecting the external auditory canal to the lower border of the orbit, and this Frankfurt plane should be parallel to the floor. So that means the child should be looking straight while measuring the length, and the back of the head, thoracic spine, buttocks and heel should be touching the floor. So that is about the stadiometer. Okay, now the next question. Growth hormone deficiency is diagnosed by. So here what are they asking? They are asking about a condition known as growth hormone deficiency. And under what heading that comes? It comes under the heading of pathological short stature. So we'll see about something about pathological short stature. So please try recollecting the definition of pathological short stature. When do you call it as pathological short stature? When the height of the child is less than -3 standard deviation. Then it is known as pathological short stature. And after that, you'll try to classify it into two types by looking at the upper segment, lower segment ratio. If the upper segment, lower segment ratio is normal, then it is known as proportionate short stature. And if the upper segment, lower segment ratio is altered or abnormal, then you call it as disproportionate short stature. Okay, so what are the causes of proportionate short stature? The causes of proportionate short stature are, the most common is undernutrition. If the child is not, especially chronic undernutrition, as I've already said, it can result in affection of the height. Then it could be because of any chronic systemic illness. If the child is having any chronic systemic illness which is heralding with the growth of the child can have proportionate short stature. Or it could be because of endocrine causes. And the most important causes is growth hormone deficiency or hypothyroidism. It's also important causes of endocrine causes for short stature. Or it could be because of syndromes. There are a lot of syndromes which are associated with short stature. The most important is Turner. In any female child who presents to you with short stature, which is pathological, it's a dictum that you should rule out Turner syndrome. You should examine the child, look for features of Turner syndrome. And other syndromes which can be associated with short stature, Noonan syndrome can cause short stature. Prader-Willi syndrome. Prader-Willi syndrome, it is characterized by short stature and severe obesity. The child will be very obese as well. And there are many other syndromes like Down syndrome. The child may be having short stature. And there are other syndromes like Russell-Silver syndrome. Many syndromes are there. So important, you have to know the Turner syndrome is the most important one here. In any girl child with short stature, you have to rule out Turner syndrome. And the last one is emotion deprivation short stature or psychosocial short stature. That is, even if the child is given nourishment, the child should have a tender, loving care, a good environment around them to get the normal growth. So if the child is having some psychosocial or emotional factors, that also can result in short stature. That is known as ED, that is emotional deprivation short stature or psychosocial short stature. So these are the causes for proportionate short stature. Now what if it is a disproportionate short stature? So for commenting a disproportionate short stature, we should look at the upper segment, lower segment ratio. And it can be divided into conditions which are associated with upper segment more than lower segment, or conditions where the lower segment is, the upper segment is less than the lower segment. So here I'll try to draw up man. Okay. So this is the upper segment. See, this is the upper segment, this is the lower segment. So if the upper segment is more than lower segment, it means that it's a lower segment that is being problem. There's a shortening of the lower segments. So what are the conditions which are associated with short lower limbs? Rickets. There will be defective growth of the limbs. So rickets can cause short limbs, and thus the upper segment will be more than the lower segment. Next one is achondroplasia. It's an autosomal dominant condition which is characterized by short limbs. Osteogenesis imperfecta. So rickets, achondroplasia, osteogenesis imperfecta, and sometimes hypothyroidism also you can get short limbs. So these are the cause of short lower limbs. Now, in which conditions you get a short upper segment? The short upper segment usually happens when you have problems with the spine. So the spinal problems result in short upper segment. For example, spondyloepiphyseal dysplasias, or if there is a port spine, or that is TB spine is also known as port spine, or if you have some hemivertebra. Okay, all these are conditions which can cause short upper limb, and also mucopolysaccharidosis, MPS, that are also a short spine. So short spine. So short spine, spondyloepiphyseal dysplasia, sport spine, hemivertebra, and mucopolysaccharidosis. So this is the classification of pathological short stature. So that you do by classifying whether it's a disproportionate or proportionate. The cause is under proportionate, cause is under disproportionate. And please study the normal upper segment, lower segment ratio at various age groups. At birth, it is 0.7:1. At 6 months, 1.6:1. At 2 years, it becomes 1.5. You can even remember it as 1.4:1. So 2 into 2 is 4. 3 years, 1.3:1. And by 7 years, it becomes 1:1. Okay, so you can remember it like this. Okay, that's about it. Now a little bit about how to evaluate the bone age of the child. The bone age, as I've already said, the bone age is a marker of the skeletal maturity. It's a marker of the skeletal maturity of the child. So usually how do you look at the bone age? You take X-rays, and which X-ray to be taken, it depends on the age of the child. So if it's a newborn, you take X-ray of the knee. If it's 3 to 9 months of age, the X-ray of the shoulder is taken. 1 to 13 years, you take the hands and the wrist, and 12 to 14 years, you take elbow and the hip. And the bone age in general is a little bit more advanced in girls than in boys. And you compare it with standard charts. And what are the charts called? Grealish-Pillay chart, or the Tanner-Whitehouse. Just remember the names. These are some of the two methods by which bone age is calculated. Grealish-Pillay and Tanner-Whitehouse method. And what happens to the bone age in different conditions? In these endocrine conditions, that is growth hormone deficiency, hypothyroidism, etc., there will be a significant delay in the bone age. So if there's a significant delay in the bone age with respect to chronological age, you have to think in terms of growth hormone deficiency, hypothyroidism, and also celiac disease. Okay. And then if it's a mild delay, we've already mentioned that in constitutional delay in growth of puberty, because of the faltering in that particular 1 to 3 years of age group, the bone age will be slightly lagging behind the chronological age. So if it's a mild delay, it can be a constitutional delay in growth and puberty. If the bone age is equal to chronological age, it is usually seen in familial short stature and also in all the syndromes, skeletal dysplasias, disproportionate short stature, everything, it will be equal. And a 20% variation can be considered to be normal. For example, the child's age is 1 year, and when you're looking at the bone age, it's 1 year, 2 months, it can be considered normal. So up to 20% allowance can be taken. Okay, so that is about the bone age. Now let's move back to the question. I've explained all this so that we can try and answer this question. So growth hormone deficiency is diagnosed by. So what happens to the bone age in a child with growth hormone deficiency? The bone age will be delayed. That's a simple concept you need to know. So bone age will be less than chronological age. it will not be more than chronologically it is not equal to, and the proportionate of the upper segment and lower segment body will not be increased. So all these are wrong. The first statement is the right answer. Okay, now moving on to the next question. A 15-year-old child has a short stature with that is height is only 145 centimeter and the upper segment lower segment ratio is 0.8:1. So this child is 15 years old. What is the expected upper segment lower segment ratio at 15 years of age group? Yes, after 7 years you expect it to be 1:1. So here the upper segment is not 1, it is 0.8. That is, the child is having small upper segment. So when it is small upper segment, it means that there is something wrong with the spine. So just search in your options which is the condition associated with spine. Is it achondroplasia? No. Is it hypothyroidism? No. Spondyloepiphyseal dysplasia? Yes. That is the right answer for you. So that is very simple. If you know the concept, you can easily answer any question that has been asked from this area. This particular question might not be repeated as such, but the concept, if it is clear, you can answer any question that has been asked from this particular area. Okay. Now, that's about the different types of short stature, constitutional, and yeah, I just want to say a few points about growth hormone deficiency also that might be asked, not asked so far, but growth hormone deficiency. Yeah. So growth hormone deficiency, some of the points you have to know is it is characterized by delayed bone age. Bone age will be significantly less than chronological age. And it can occur as an isolated growth hormone deficiency or multiple pituitary hormones can be affected. And what do you see in the facies? You can see midline defects. Very important. The presence of midline defects, you should think about growth hormone deficiency. For example, central incisor, micropenis. These are all midline defects, right? Or if any such things are present, you should think in terms of growth hormone deficiency. How will you diagnose? One is X-ray, the bone age will be delayed. Second one is you do a growth hormone stimulation test. That is, growth hormone is always secreted in pulsatile manner. So if you take a random sample, you might not be able to interpret. So you give something to stimulate the growth hormone and you look at the stimulated value. Okay. So the growth hormone stimulation test, if the value is less than 10, then you can confirm. After stimulation also, the value of growth hormone is less than 10, you can take it as growth hormone deficiency. And how will you treat? You give recombinant growth hormone. How it is given? Subcutaneous injection. How often? Daily. Subcutaneous injection is given. And what are some of the complications or side effects associated with growth hormone injection? It can cause slipped capitofemoral epiphysis, kypho, because growth of the patient can occur at a rapid rate. So it can result in kyphoscoliosis. And in some patients, it can also result in pseudotumor cerebri. Okay, so that is about growth. Few important points, key points that you have to know under the heading of growth hormone deficiency. Okay, next question is the fetal growth. The fetal growth is maximally affected by. So you have to understand that the growth of the child is affected by multiple factors. So the hormones which play a role in the growth of the child is different during each period of growth. So what happens in fetus? The major hormone which which influence the growth of the child is insulin. So that is why you can see that in infant of diabetic mother, there is hyperinsulinemia. And because of that hyperinsulinemia, the child will be macrosomic or LGA baby. What is LGA? If the weight for the child is more than 90th centile of expanded, that is known as LGA. So in fetus, the most important hormone which is affecting the growth is insulin. And in infancy, it is mainly thyroid. So please note that the growth hormone is not playing any role in fetal life or during infancy. The growth hormone plays a role only during the early childhood period. So here is the only time where the growth hormone comes into play. And in adolescence, it is predominantly the sex steroids, FSH, LH, everything, and the gonadotropins are the ones which are responsible for the growth. LH and FSH, all these hormones. So in the fetal life, it is insulin. In infancy, thyroxine or the thyroid hormone, early childhood growth hormone, and during adolescence, the sex hormones are the important one, which plays an important role in the growth. So here, the fetal growth is maximally affected by, the right answer is insulin. It's the growth hormone in early childhood. Okay, cortisol and cortisol usually occur in the later period, thyroxine in infancy. Again, a question from same area. Which factor does not cause fetal growth in uterus? Insulin, yes, it causes fetal growth. IGF-1, yes. Thyroxine to some extent, but growth hormone, the role of growth hormone comes only during early childhood. So the right answer is growth hormone does not play any role in the fetal growth. Okay. Now, this is another question about the anterior fontanelle. So when does the anterior fontanelle close? Yeah, the answer is between 12 to 18 months. So you can choose this as the right answer, 12 to 20 months. So something about the fontanelles. At birth, how many fontanelles do you have? Usually you have 6 fontanelles at birth. And which is the first fontanelle to close? It is the posterior fontanelle. It usually closes by 2 to 3 months. In some babies, it might be closed already at the time of birth itself. And then the last one to close is anterior fontanelle, and this anterior fontanelle closes at 12 to 18 months of age group. Okay, so that is clear. Now, these are the sutures. So, in this scenario, an important area that you have to know is about craniosynostosis. What about craniosynostosis? Craniosynostosis means there is premature fusion, or there is an increased fusion of the sutures. The sutures of the skull undergoes premature fusion. So what happens, depending on which suture fusion has opened, the shape of the skull will be different. So it is that is known as craniosynostosis. So there are different types. Okay, so we'll look at each one of them. First one is trigonocephaly. Here, which suture it is closed? The mectopic suture. So there is a premature closure of the mectopic suture. So what happens? The skull becomes more pointed in the front portion. So it becomes a triangle shape. So you can see it becomes a triangle shaped. So that is why it is known as trigonocephaly. Now, what is scapocephaly or dolichocephaly? It is because of the suture of sagittal suture. So you can remember it as S and S. So this is the sagittal suture. So this is the sagittal suture. So what happens if the sagittal suture fuses early? The anteroposterior diameter will be more. The anteroposterior diameter will be more, but the transverse diameter decreases. So sagittal fusure, if it closes, it results in scapocephaly, also known as dolichocephaly. And this is the most common type of craniosynostosis. The most common type of craniosynostosis is the fusion of the sagittal suture causing scapocephaly or dolichocephaly. Now, what happens if the coronal? So, this is the coronal suture. The premature closure of the coronal suture result in what? Brachycephaly. So, you can remember it as CBC. Brachycephaly, coronal suture. Brachycephaly occurs because of the premature fusion of the coronal suture. So what happens? The anteroposterior diameter becomes less. It becomes anteroposteriorly compressed. That is known as brachycephaly. And then we can have the lambdoid suture. If the one side lambdoid suture closes, it results in posterior plagiocephaly. So here is the lambdoid suture. So here if it closes, what happens? There will be a posterior plagiocephaly. And similarly, if it is the unilateral coronal suture, it causes anterior plagiocephaly. So these are the different types. Mectopic suture, triangular shape, trigonocephaly. Sagittal suture, scapocephaly or dolichocephaly. Coronal suture, brachycephaly. Posterior lambdoid suture, posterior plagiocephaly. Anterior unicoronal fusion, it results in anterior plagiocephaly. And there is another entity which is different from all these, that is known as deformational plagiocephaly. Deformational plagiocephaly is a condition, it is not craniostenosis. It is not craniosynostosis. Here what happens is that the child continuously lies on one side. For example, the child is always lying on this side. What happens? That part of the skull becomes flattened. So that is known as deformational plagiocephaly. Most commonly occurs in the posterior portions because the child prefers to lie in certain way, and here all the sutures are open. So that is known as positional or posterior plagiocephaly, which is secondary to the position of the skull. Okay, so these are the different types of craniosynostosis. Important question. The most common type is dolichocephaly. You might get a question like which suture closes in dolichocephaly, like that. So you have to learn this diagram. Now, one syndrome that you have to understand might be asked for your exam is Cruzen syndrome. So Cruzen syndrome is a type of craniosynostosis syndrome which occurs because of the fusion of the coronal suture, resulting in brachycephaly. It is characterized by proptosis. That's the most important. Meaning the eyelids will be very prominent. That's called proptosis. Occurs in Cruzen syndrome, and it is because of the mutation of FGFR, fibroblast growth factor receptor mutation. Another syndrome which is associated with craniosynostosis is Apert syndrome. Just remember the name. Might not be asked for your NEET-PG, but might be important for INI-CET. So Cruzen syndrome and Apert syndrome are two important syndromes which are associated with craniosynostosis. Okay, next question. The rate of increase in head circumference in infants less than 3 months of ages. We have already discussed this. So in the first 3 months, the rate of increase is 2 cm per month. After next 3 months, 1 cm, and after that 0.5. So at first 3 months, it is 2 cm per month. Okay, that you already know. Now, what are the causes of, what is microcephaly and what is macrocephaly? Microcephaly and macrocephaly. This is an important area. You need to know the definitions and some of the causes. Has been asked and can be asked in your coming up exam also. So what is the definition of microcephaly? If the head circumference is less than -3 standard deviation, it is known as microcephaly. And macro means large. If the head circumference is more than 2 standard deviations. So micro it is -3, macro it is 2. Okay, so that is the definition of microcephaly and macrocephaly. Now what are the causes of microcephaly? So this is a table. This is a very elaborate table. You did not by heart everything, but you should know something about each of the categories. For example, isolated microcephaly is also known as primary microcephaly. That is, the child is born with a small head. It is not secondary to any other cause. It's called primary microcephaly. It can be autosomal dominant or autosomal recessive. That's it. And the next important section or the classification is syndromic causes of microcephaly. So which are few syndromes where you can see microcephaly? The trisomies. Trisomy 21, 18 and 13. That is Down syndrome, Edwards syndrome, Patau syndrome. All these three is associated with microcephaly. Then some of the other important syndromes that you have to learn is Cornelia de Lange syndrome, Cry-do-Cat syndrome, Rubitson-Taby syndrome, Bloom syndrome, Angelman syndrome, Smith-Lemli-Opitz syndrome. So just have a pictorial memory of this table so that if you ask, all the following are associated with microcephaly except. So you can at least rule out and answer if you know some of the syndromes which can cause microcephaly. So all the trisomies and some important syndromes you have to remember. Then microcephaly can also occur because of any CNS malformations like neural tube defects, hollow prosencephaly, anencephaly, lysencephaly, etc. And metabolic causes. What are the metabolic causes which can cause maternal diabetes? Very important. Untreated maternal diabetes mellitus can lead to microcephaly. So we already know that maternal diabetes is a condition associated with hyperinsulinemia. And insulin is an anabolic hormone and it causes an increase in the growth of tissues. But insulin in a child with infant of diabetic mother causes an increase in the growth of all the tissues except the brain. The brain growth is not accelerated. So microcephaly can occur in a child who is born to a mother with maternal diabetes mellitus. Then untreated maternal phenylketonuria, that is also another cause for microcephaly. Phenylketonuria as such, the most common organ involved in PKU is brain. So PKU, one of the most important clinical features is microcephaly. Yeah, and then NCL, these are some rarer syndrome. You just remember the first three at least, minimum. And then environmental causes, infections. Infections which can cause microcephaly, mainly we are talking about the congenital infections which the baby acquires in utero. Important ones are the TORCH. I hope you know the full form of TORCH: Toxoplasma, rubella, cytomegalovirus and herpes. And what are the other infections which can cause microcephaly? Zika virus. Zika virus infection in the mother can cause microcephaly in the child. Varicella infection can cause microcephaly. Syphilis, congenital syphilis, can be associated with microcephaly. So these are the important infections. You have to know this. Multiple times this has been asked. So the infections, the congenital infections which can cause microcephaly, these are the causes. And then next one is the drugs. In utero exposure to the drugs which can cause microcephaly. Important ones are alcohol, fetal alcohol syndrome. It is characterized by microcephaly and limb defects that can occur. Anti-epileptic drugs, that is anti-seizure medications, like the use of valparin, carbazepine, phenytoin, etc. can cause. And also with alcohol, you remember cocaine as well. And then anti-neoplastic drugs. And along with chemotherapy, you also remain radiation exposure. All these can result in microcephaly. And the next one is perinatal insult. Any perinatal insult, that is the brain, when does the brain grow? The brain grows during from birth to 2 years. 90% of the brain growth occurs in the first 2 years of life. So any insult which can occur even after the birth of the child can result in microcephaly. Examples are hypoglycemia, neonatal hypoglycemia, hypothyroidism, hypopituitarism, HIE changes, if the baby didn't cry soon after birth and had some ischemic damage to the brain, and also meningitis in the first 2 years of life can also result in microcephaly. So these are some of the important causes of microcephaly. What is microcephaly? The height circumference is less than -3 standard deviation, and these are some of the important causes of microcephaly. Now what about macrocephaly? Macrocephaly, what is the definition of macrocephaly? Macrocephaly, if the head circumference is more than 2 standard deviation. It is 2. Micro, it is 3. Okay. So that it is very easy to remember. We can study, there can be diseases associated with the brain, or there can be diseases associated with the vascular compartment, or it could be diseases associated with the CSF pathway, or it could be some of the abnormalities with the bone. So what are, we'll move from out to in. So what are the bone factors? The bone factors can be one, chronic hemolytic anemias like thalassemia, sickle cell anemia. All this because of the increased extrapapillary hematopoiesis, there will be increase of bone marrow and the skull may appear large. Then rickets, it is associated with large skull, and osteopetrosis. These are some of the bony chamber, the enlargement of bony chamber which results in large skull. Second one is the vascular space. The CSF. The CSF, the most common cause is hydrocephalus. It's a cause of large head, and also chronic subdural effusions can also present with large head. In the vascular compartment, vein of Galen malformation can result in large head, and the brain, it can be the enlargement of the brain, that is known as megalencephaly. And megalencephaly can be megalencephaly can be familial. That is, it can be because the head circumference is large because the father and mother is having a large head, or it could be because of certain syndromic causes, overgrowth syndromes. Examples are Soto syndrome, Beckwith-Wiedemann syndrome, and Weaver syndrome. Or it can be occur secondary to some neurodegenerative disorders. You just need to remember the names: Canavan disease, Alexander's disease. These are the two important neurodegenerative diseases associated with the large head.
അതായത് ഇതിപ്പോ എങ്ങനെയാ ഇപ്പൊ നമ്മള് ലൈവിൽ നിൽക്കണ ഇതിപ്പോ ഇങ്ങനെ ഷൂട്ട് കൊടുക്കും ഇപ്പൊ ലൈവ് പോയിട്ട് അപ്പൊ
Alright. Okay, welcome back. Sorry, we had a small technical error. So we'll continue from where we left off. So we were talking about the causes of macrocephaly. So we dealt with the bony compartment. That is, the bony compartment may be enlarged in conditions like chronic hemolytic anemia, rickets, osteoporosis. CSF compartment is increased if there is hydrocephalus or chronic STH. Vascular compartment is enlarged if there is a vein of Gallen malformation. It is a vessel, it's an aneurysmal vessel dilatation which can present as large head. And finally, the brain. The enlargement of the brain is also referred to as megalencephaly. And megalencephaly can be familial, or it could be because of syndromes like Soto syndrome, Beckwith-Wiedemann syndrome, Weaver syndrome, etc. Or it could be secondary to some neurodegenerative disorders or storage disorders to be in particular. And examples are Canavan disease, Alexander disease. Other examples are Krabbe, metachromatic leukodystrophy, glutaric aciduria. Okay, so some of the neurodegenerative disorders which can be associated with large head. So that is about microcephaly and macrocephaly. Okay. Now we'll deal with the next question. So what is this question? Microcephaly is common in children of mothers with all except. So we'll just try to revise what we learned. Can alcohol intake in the mother cause microcephaly? Yes, definitely. Alcohol intake in the mother is associated with microcephaly. Is varicella infection in the mother associated with microcephaly? Yes. Congenital varicella syndrome can cause microcephaly. Zika virus infection? Yes. Zika virus infection can cause microcephaly. But warfarin intake in the mother? It is not a cause of microcephaly. Warfarin intake in the mother can mainly cause fetal bleeding and also hypoplasic nasal structures of the baby. But it is not associated with any microcephaly. So the right option is option number B. Now, that is all about the head circumference and all these anthropometric measures. Now, we'll come to some of the important, another very important high yielding area, that is micronutrients. That is vitamins and minerals. Repeatedly and very repeatedly asked area. So, we'll look at some of the important questions that have been asked from this particular area. So, what is the recommended daily dose of iodine in a child? So here we are dealing with iodine. So what is the RDA of iodine? Yeah, here this is the RDA, the recommended daily allowance of iodine that is being given by the WHO. So in children, less than 5 years it is 90, 6 to 12 years it is 120, more than 12 years and adults it is 150, pregnancy and lactation 250. So here it is they have asked about the daily RDA of iodine in a child. So the answer will be, yeah, 90 to 120. That is the right answer. Now something about iodine. So iodine is a very important mineral. And why is it important? Because iodine is involved in the biosynthesis of thyroid hormone. So whenever a child is having iodine deficiency, it can lead to something known as iodine deficiency disorders, IDD. And this iodine deficiency disorder is characterized by low IQ or mental retardation, because thyroxine is a very important hormone which is required for the growth of the fetal brain or the infant brain. So it can result in low IQ and MR, and it can also result in goiter, swelling of the thyroid gland, that is known as goiter. And maternal iodine deficiency can result in fetal iodine deficiency. And this fetal deficiency of iodine can result in the condition referred to as endemic cretinism. It is a type of hypothyroidism which occurs because of the deficiency of the iodine in the fetus, secondary to maternal iodine deficiency. So that is known as endemic cretinism. Now, how will you diagnose iodine deficiency? The test you use urine iodine excretion. That is the test that we use in order to measure iodine deficiency. If it is less than 100, it is deficient. And if it is less than 20, it is severe deficiency. It is severe deficiency. So in order to prevent this serious form of endemic cretinism, the government have put forward fortification programs. Okay, so iodine fortification. How are they fortified iodine? Iodized salt. The iodized salt are manufactured such that the target iodine content is, this can be asked as a question for you, it should be more than 30 parts per million at the site of manufacture, and it should be more than 15 parts per million at the site of distribution. So at the site of manufacturing, it should be 30 parts per million, and at the site of distribution, it is around 15 parts per million. So these are the important points about iodine. Now we'll look at a quick overview of the important points about the other micronutrients. So first we'll deal with the vitamins. Vitamin A. Okay, so what is the recommended daily allowance of vitamin A? The recommended daily allowance of vitamin A is around 400 to 600 micrograms. And what does vitamin A deficiency cause? It causes xerophthalmia. The WHO grading of xerophthalmia: XN, night blindness; X1A, conjunctival cirrhosis; X1B, B for bitot spots; X2 causes corneal cirrhosis; X3 is corneal ulceration, which can be A and B. A if it is less than 1/3 of the corneal surface, B if it is more than 1/3 of the corneal surface. This is also known as keratomalacia. And then you have XS, that is corneal scar, and XF, that is xerophthalmic fundus. Okay, so this is the WHO classification of xerophthalmia. Now, what is the source of vitamin A? Usually seen in vegetables like pumpkin, carrot, orange colored vegetables are usually considered as a good source of vitamin A. Now, what happens when there is hypervitaminosis? It can result in a condition known as pseudo tumor cerebri. What do we have we studied about pseudotumor cerebri earlier? Yeah, it can occur as a complication of growth hormone therapy. So in hypervitaminosis A also, there can be pseudotumor cerebri. And now, how is the government of India supplementing vitamin A? Yeah, the vitamin A is given usually along with the immunization visits. The first dose is given at 9 months along with the measles vaccine. And in a child who is less than 1 year of age, the dose is 1 lakh international unit. And after 1 year, the dose is 2 lakh international unit. So after 1 year, what they do is that give it every 6 monthly, and till the age of the child becomes 5 years. That is up to 1 to 5 years. The total number of doses that is being given is 17 doses. A total of 17 lakh international unit of iron vitamin A has been given by the government under this program. Now, how do you treat vitamin deficiency? If the patient is having vitamin A deficiency, it usually occurs in concomitantly with severe acute malnutrition. So we supplement vitamin A. So vitamin A is given at a dose of, if the child is less than 6 months of age, 50,000. If it is 6 to 12 months of age, 1 lakh, and more than 1 year, it is 2 lakh international unit. What is the schedule? It is given on 0, 1 and day 14. That is the schedule of giving vitamin A if there is severe deficiency. Okay. Now, what is this condition? This can be asked as a spotter. This is known as phrinoderma. It is a dermatological manifestation which can be seen associated with vitamin A deficiency. Okay. So that is about vitamin A. Important points I've covered. Now, vitamin B1, vitamin B, the B complex vitamin. So B1 is thiamine. So what does thiamine deficiency cause? A condition known as beriberi. And what are the at-risk population for developing beriberi? Those people who are eating polished rice. And also it can occur in chronic alcoholics. And in a pediatric point of view, it is mainly seen in people with refeeding syndrome. That is, in children who are having SAM, and if you start refeeding, they may develop a syndrome known as refeeding syndrome, and it is characterized by deficiency of thiamine. So this beriberi can again be divided into two types: dry beriberi and wet beriberi. Dry beriberi is predominantly characterized by CNS manifestations, most important being polyneuritis. Whereas wet beriberi, it is characterized by cardiovascular symptoms, that is, they present with high output cardiac failure. And the most severe form of thiamine deficiency is known as, what is it called? It is known as Wernicke-Korsakoff syndrome. What is the triad of Wernicke-Korsakoff syndrome? It is characterized by ocular abnormalities like ophthalmoplegia and nystagmus, along with mental changes like altered sensorium and ataxia. So the severe form of beriberi is known as Wernicke-Korsakoff syndrome. Okay, so that is about vitamin B1. So how will you treat? You give vitamin B1. That is the treatment. Next one is vitamin B2. Vitamin B2 or riboflavin. And what does vitamin B2 deficiency cause? It mainly causes angular cheilitis and stomatitis. And the MCQ point is it can cause circumcorneal vascularization. Circumcorneal vascularization is one of the manifestations of vitamin B2 or riboflavin deficiency. And the third one is vitamin B3. What is vitamin B3? Vitamin B3 is niacin. And which is the amino acid from which niacin is derived? It is derived from the amino acid tryptophan. And what is the conversion ratio? 60:1. 60 parts of tryptophan is required to make 1 part of niacin. That is 60:1 is the conversion ratio. And what is the deficiency of niacin cause? It causes what is known as pellagra. And pellagra is characterized by 3 Ds. What are the 3 Ds? Dermatitis, dementia, and diarrhea. And what is the classic dermatitis that you see in pellagra? Yeah, that is the Castle's necklace, which is a very important question, can be asked as a spotter. Pellagra, niacin deficiency, the 3 Ds, diarrhea, dermatitis, and dementia. And the dermatitis is, the classical picture is Castle's necklace. That is in pellagra. Very important area, multiple times has been asked. And the next one is vitamin B5. What is vitamin B5? That is pantothenic acid. It causes something known as burning feet syndrome. Just you need to know that name only. Then vitamin B6, pyridoxine. It is a component of pyridoxal phosphate. Deficiency can result in peripheral neuropathy. And in some cases, it can also cause sideroblastic anemia. Okay. Now, next one is vitamin B12. Vitamin B12 or methylcobalamin. What does it, which are the eight population which is at a high risk of developing B12 deficiency? It mainly seen in vegetarians, because the only source of B12 is mainly meat, egg, dairy products, etc. So pure vegetarians are at risk of developing B12 deficiency, and it can present with megaloblastic anemia. What is megaloblastic anemia? It is a type of macrocytic anemia where there is increase in the MCV. The usual cutoff we use is the MCV is more than 90. Age-related cutoffs are there, but still, if you are just arbitrarily, if you take if MCV more than 90, it is usually macrocytic anemia. So, what are the other causes of macrocytic anemia? Macrocytic anemia can also be seen in conditions like, one is megaloblastic anemia due to B12 deficiency. The other causes, it can be seen associated with liver disease, hypothyroidism, and orotic aciduria. These are other causes for macrocytic anemia. Now, what is the other manifestation of vitamin B12 deficiency? Severe form, it can cause what is known as subacute combined degeneration. That is, there is combined degeneration. The patient will present with pyramidal signs along with peripheral neuropathy. That is known as subacute combined degeneration. It occurs because of the deficiency of vitamin B12. And what is folate deficiency? It also is another cause for megaloblastic anemia. So the RDA folic acid has been asked previously as a question. So please study the RDA folic acid. The RDA folic acid in children is 80 to 120, similar to iodine. The RDA is 90 to 120. Folic acid, it is 80 to 120. And in pregnancy, it is 500 microgram. According to Nelson, the RDA of folic acid in pregnancy is 400 micrograms. And why is folate given during pregnancy? It helps in reducing the incidence of neural tube defects. And when should folate be started? It should be started 1 month before pregnancy, and it should be continued for 3 months, that is first trimester. So 1 month before up to the first trimester. And it what is if a patient has taken this preconceptional folic acid, the risk of neural tube defect is reduced by 50%. Okay, there's a 50% reduction in the risk of developing neural tube defects if the mother has taken folic acid, that's preconceptional folic acid during pregnancy. Now, what if the mother has one child affected with neural tube defect? Then if the mother is planning for the next pregnancy, she should take 10 times the dose. That is, in the place of 400 micrograms, she have to take 4 mg folic acid. Should be taken if the mother already has a baby who has had a neural tube defect. Then for the second pregnancy, to prevent the incidence of developing neural tube defect, the mother has to take folic acid but 10 times the usual dose. Okay. So these are the few important points among that. Now moving on to the next, so that we have finished the B complex vitamins. Now we come to vitamin C. So vitamin C, ascorbic acid. So what are it's a water soluble vitamin. It is an antioxidant. And it is very important in what? Wound healing and collagen synthesis. And how is it important in collagen synthesis? It helps in the hydroxylation of proline and lysine. Hydroxylation of proline and lysine. And that results in the collagen synthesis, and those vitamin C has got very important role in collagen synthesis and antioxidant, and it also plays very important role in wound healing as well. So what is vitamin C deficiency? The manifestations of vitamin C deficiency is known as scurvy. The source of vitamin C is predominantly the citrus fruit. The recommended daily allowance of vitamin C is 40 milligram per day. Now, scurvy, it's also known as bleeding gums. So it can manifest as bleeding gums. And the other manifestations, apart from bleeding gums, it can also present with other manifestations. What are they? One is, it can present with increase in the capillary permeability. And because of the increased capillary permeability, what happens? There will be increased hemorrhages. And these hemorrhages can be seen at various sites. There can be perifollicular hemorrhages. It can be seen as small hemorrhages around the skin, and you can also have subperiosteal hemorrhages, that is beneath the periosteum. And the subperiosteal hemorrhages can cause severe pains, and that can result in something known as pseudo paralysis. Because of the severe pain, the child will refuse to move the limb. So that is not a pseudo paralysis. It occurs mainly because of the subperiosteal hemorrhages. So these are manifestations of scurvy. Now the radiological manifestations of scurvy is a very important question from an MCQ point of view. Very, very important. So what are the radiological features? We will move from inner to outside. So there are ring epiphyses. There is a circumferential ring epiphysis that is known as Wimberger zone, W. Okay, and after that you can see a provisional zone of calcification. And what is it called? That is known as a white line of Frenkel. And below that you can see the Tummer field zone. It is a zone of rarefaction that is seen just below the zone of calcification. That's called Tummerfeld zone. So you remember it as WFT. That is, first there is a Wimberger sign followed by the white line of Frenkel, and below that we have the Tummerfeld zone. So these are the three important features. And then other than what can you see at the end of this last zone of calcification, you can see some projections here. That is known as the Pelkin spur. Okay, and here you can also see the subperiosteal hemorrhage. This is subperiosteum, and what we are seeing here is the subperiosteal hemorrhages. Okay, so this is just a description of the cortex will be very thin, so pencil thin cortex, subperiosteal reaction due to subperiosteal hemorrhage, and then there will be Wimberger sign, Frenkel line, Tummerfeld zone, and Pelkin spur. And what is the other important manifestation that you can see? That is known as scorbutic rosary. Scorbutic rosary is another important finding that you see in scurvy. What is the other type of rosary you know? Yes, rachitic rosary. So rachitic rosary is seen in rickets, R for R. Rachitic rosary, R, rickets. Scorbutic rosary, S, scurvy. And how is it different? The scorbutic rosary is basically because of the dislocation of the joint at the costochondral junction. So it is usually pointed and it is very painful. Whereas rachitic rosary is because mainly of the widening of the costochondral junction, and in that case it is not painful, it's more blunt and it is painless. So that is the difference between scorbutic rosary and rachitic rosary. Okay, so these are the important manifestations of vitamin C deficiency or scurvy. Now these are some important pictures that you can see. So try identifying these pictures. What is this picture? The first one. Are you able to identify? Yeah, this is a picture of keratomalacia, which occurs due to vitamin A deficiency. And what is this? This is a picture of Bitot spot. Again, vitamin A deficiency. And what is this? Angular cheilitis and glossitis. It occurs because of B2, that is riboflavin deficiency. This is Castle's necklace. Castle's necklace is a feature of pellagra. Pellagra it occurs because of niacin deficiency. Please study all this, very important. And what can you see in this picture? What can you see in this picture? Here we have a child who is showing a pallor. Okay, so what is the most common cause of pallor in a child? The most common cause of pallor in this age group is iron deficiency anemia. So little bit, some of the important key points regarding iron deficiency anemia. What is the age group? Usually affects children between 9 months to 2 years of age group. That's a peak age group. That is once the weaning starts. This is the most important age group where iron deficiency anemia happens. What is the type of anemia? It is microcytic hypochromic anemia. Iron deficiency anemia is a microcytic hypochromic anemia. And now, when do you say it is severe pallor? When you see it is severe pallor, when there is if there is paleness of the palmar creases. So here you can see the palmar creases are very faint, right? So when there is a faintness or the pallor extends to the palmar creases, then it is known as severe pallor, and that corresponds to a hemoglobin of nearly less than 7. Okay, so what are the other clinical features? The child may show anemia, paleness, increased irritability. That is a very important feature of iron deficiency anemia, loss of appetite. And if it is very severe, then only the child shows manifestation of congestive cardiac failure, like when it becomes less than 4 or something. But usually CCF is not seen in chronic iron deficiency anemia. Now, what are the investigations you do? Yeah, you always do a peripheral smear to look for microcytic hypochromic anemia, and There can be also other features like pencil-shaped cells and everything. You'll be learning it in your pathology sessions about the pathological features of iron deficiency anemia, which is very important. And then iron indices. That is also important. What will happen to the TIBC? TIBC will be increased. Serum ferritin value will be low. Serum iron will be low. And transferrin saturation. Serum transferrin levels will be low. So these are the blood indices findings which are seen in a child with iron deficiency anemia. So how will you treat iron deficiency anemia? You treat it with oral iron. The most common preparation that we use in children is ferrous sulfate. The dose of ferrous sulfate is 6 to mg per kg per day. And what is the first response that you see? That is increase in the retic count. The retic count is the first hematological response that you see after you start iron. And when do you see an improvement in the hemoglobin? After 1 month. So after 1 month of starting iron, you check at the hemoglobin and the hemoglobin has increased by 1. So it is previously 7 and after 1 month it is 8. It means that the child is responding to your iron therapy. And if the child is failing to respond to iron therapy, you have to look at alternative causes. That's a different scope of study. I'm not going to that area, but at least this you should be knowing about iron deficiency anemia. Okay. Now moving on to the next one, that is vitamin K. Okay, vitamin K. Why vitamin K? Vitamin K, there are two types of vitamin K. It's again a fat-soluble vitamin. And vitamin K can be two types, K1 and K2. And whereas K1 is known as phyloquinone and K2 is known as menadione. These are the two types of vitamin K. Phyloquinone, you mainly get it from green leafy vegetables. K2, also known as menadione, is mainly produced from the intestinal bacteria. Okay, what is the age group in which vitamin K deficiency is important? Because all our adults, in elderly or in the case, once you have a grown-up child, what happens is the vitamin K is produced by the intestinal bacteria itself. So it's very unlikely for an older child to get vitamin K deficiency. But which is the age group of children which are very prone for getting vitamin K deficiency? It is the newborns. Why? Because there are two reasons. One, the intestinal bacteria are not established or not grown enough to synthesize vitamin K1. And the second reason is that breast milk is a very weak source of vitamin K. There are two vitamins which are deficient in breast milk. The breast milk is deficient in K and D. Vitamin K and vitamin D is deficient in breast milk. That is why we always give vitamin D supplementation to breastfed babies. Similarly, vitamin K is also very less in breast milk. So newborns are the population which are at high risk of developing vitamin K deficiency. So in order to prevent that at birth, all babies across India, we give a vitamin K injection. Injection vitamin K is given as an intramuscular injection, 1 milligram at birth itself. So that is done so that the baby does not go in for vitamin K deficiency. Why is it vitamin K so important? Because vitamin K is required for the post-translational modification, that is gamma carboxylation of certain clotting factors. Which are these clotting factors? Very important. Please note 2, 7, 9 and 10. These are known as vitamin K dependent clotting factors. So if the vitamin K is deficient, these clotting factors are not produced and this patient can present with bleeding. And what is that bleeding called? It is known as hemorrhagic disease of newborn. Also, but the new terminology for that is vitamin K dependent bleeding, VKDB. That is vitamin K dependent bleeding. Now, vitamin K dependent bleeding again can be classified into three types: early onset, classic and late onset. So first we look at the early onset. Early onset is within 1 hour, 1 day of life, 0 to 24 hours. So any child presenting with bleeding in the first 24 hours of life, the cause is mainly maternal causes. The maternal medications like warfarins or anticonvulsants which are taken by the mother may be responsible for the vitamin K deficiency. And what does it cause? It mainly causes serious bleeding like IC bleeds. Classic, it usually happens between 2 to 7 days of age group. And that is usually idiopathic and sometimes it can be related to maternal medications, and that mainly causes a relatively minor bleeding like GI bleeding or wound bleeding from the site of circumcision, etc. And late onset, that is after 2 weeks. That is mainly because of the factors associated with the baby. That is the newborn factors, like the baby might be having some liver disease, and because the liver is not functioning, the clotting factors are not produced, and thus the child may develop vitamin K deficiency. Okay, so secondary to underlying disease like biliary atresia, chronic diarrhea, or even irrational antibiotic therapy in the newborn period can also cause secondary vitamin K deficiency, in which case also the more chances from IC bleeds. So classic one is the more common one, and there it occurs GI bleeding, and it is usually idiopathic because of some maternal factors. Early onset is predominantly because of antenatal factors, and late onset is usually happens because of the factors related to the baby itself. So time period is 0 to 1 day, 2 to 7 days, and latest if it occurs more than 2 weeks after the birth. So that is about vitamin K. Now, what about zinc? The next question is about zinc. The recommended daily allowance of zinc in a child is. So, what do you know about zinc? The RDA of zinc is 6 to 8 milligram per day. Okay, what is the deficiency of zinc cause? It causes a condition referred to as this. Can you identify this picture? What is it? Yeah, you're right. It is acrodermatitis enteropathica. Here, there is significant dermatitis predominantly affecting the acral sites. What are the acrals? The extremities around the mouth, on your hands, on your buttocks, on your limbs, etc. There will be extensive dermatitis. So that is known as acrodermatitis enteropathica. And this acrodermatitis enteropathica, it is characterized by a triad of findings, that is diarrhea, alopecia, and dermatitis. Can remember it as DAD. Diarrhea, alopecia, and dermatitis. The triad of acrodermatitis enteropathica. Now, another question that can be asked, what is the other illness where zinc is very important? You learn zinc? Yeah, it is always associated with acute diarrheal disease. So, sometimes you might get a question like, what is the dose of zinc in a child with diarrhea? So, it is depending on in a child with ADD, the dose of zinc depends upon the age of the child. If the child is less than 6 months old, then the dose of zinc is 10 milligram per day. And if the dose is age is more than 6 months, then the dose is 20 milligram per day. Okay, and for how long will you give? Give it for 14 days or 2 weeks. So that is the dose of zinc in diarrhea. And another disease in which zinc is important is Wilson's disease. In Wilson's disease also, zinc can be used as a treatment option. Okay, so just keep that in mind. But the zinc that is used in Wilson's, so all these things that you're talking about is zinc sulfate. In Wilson's disease, you usually use zinc acetate. It's not zinc sulfate. Okay, so that is about that. Now, next question, Keshan diseases due to deficiency of. So this is a commonly asked MCQ question, that is selenium deficiency. Selenium deficiency can cause a type of endemic cardiomyopathy that is known as Keshan's cardiomyopathy. Can be asked as a question for you. There has been previously been asked. Okay, that's about the important micronutrients. We have covered most of the no, I know that I have not addressed the elephant in the room, that is vitamin D. We have not talked about vitamin D. It is a very important area. Multiple questions have been asked from that area. So I thought I'll talk about vitamin D separately along with another set of questions. So that is why I have not purposefully discussed vitamin D here. We'll discuss vitamin D later on. Okay, we'll surely discuss it. Now, moving on to the next topic, that is breastfeeding. Another high yielding area, very hot topic. You need to know some things which is very important about breastfeeding. So, breast milk protects from infection as it contains all of the following except IgE, lactoferrin, bifidus factors, and para-aminobenzoic acid. Even without knowing anything, you can answer this question because IgE is not there in breast milk. It is always secretory IgA. The rest three are present in breast milk. So the wrong answer is first option, that is IgE. Now let's learn something about breastfeeding. So these are the advantages of breastfeeding. I'm not going to read it out again. These are there in your notes. Important points are there. There are certain lipid components in breast milk which are important. First is polyunsaturated fatty acids. Why is it important? It is important for the myelination of the nervous system. Then you have omega-2 and omega-6 fatty acid. It is important for the synthesis of prostaglandin and cholesterol. Then you have DHA, which is important for the brain growth. All these are contained in the breast milk. And there are two types of proteins, whey protein and casein. The whey protein is which is more well tolerated by the baby. So breast milk is rich in whey protein, 80% whey protein. What are the two types of whey protein? Lactalbumin and lactoferrin. And this lactalbumin helps in the formation of neurotransmitter. Lactoferrin, it helps in the absorption of iron and zinc, and it is bacteriostatic. So lactoferrin has got antibacterial property. Important question. Now, also the calcium content in the breast milk is high. It is more than 2, and generally breast milk have a low solute load so that the baby's kidneys are able to handle breast milk more easily. Then microbiologically, the breast milk is sterile and it contains certain components which protects against certain specific organism. That is lactoferrin. It acts against E. coli. Bile salt specific lipase, that is BSSL, it helps in protection against amoeba and giardia. Para-aminobenzoic acid against malaria, and bifidus factor against lactobacillus bifidus. So these are the important microbiological components of the breast milk. Now the breast milk can be of 3 types. The initial breast milk, the first 72 hours, what is being formed is known as a colostrum. It is known as the liquid gold. Also, it is the first immunization. The colostrum is known as the first immunization of the baby. It is very thick and yellow and has high content of immunoglobulin, proteins and macrophages. Then after that, the next 2 weeks, what you get is the transitional milk. And finally, you get the mature milk. Okay. Now, how is preterm milk different from term milk? Preterm milk contains increased SIP for better CNS development. What is SIP? Better sodium, iron and protein. So, preterm breast milk is richer in SIP, which is useful for a more intelligent central nervous system functioning. Now there are 2 types of milk again, fore milk and hind milk. So the milk that is being produced in the beginning of feeding is known as fore milk and the end is known as hind milk. So what does fore milk contain? More of water and minerals and vitamins and proteins, and this fore milk is mainly used for quenching the thirst of the child. Hind milk predominantly contains fat and that is required for the hunger of the baby. That is why you always ask the mothers to breastfeed completely so that the whole of the fore milk and the hind milk gets into the baby. If the baby does not feed on the hind milk, what happens? The baby will not get adequate weight gain. So that is the importance of fore milk and hind milk. And if the baby keeps on feeding only on the fore milk, there can be something also known as fore milk syndrome. What is fore milk syndrome? That is, the baby will have excessive water. So the baby may present with decreased weight gain and diarrhea. This happens in a baby who is fed only on fore milk and not on hind milk. Okay. Now, the very, very important table. This table is very important for you. Very, very important. The comparison between human milk and cow's milk. So, we'll see just the most important points we'll be seeing here. So, protein content. What is the protein content in human milk? It is 1. What is the protein content in cow's milk? It is 3. So, it is around 3 times. 1 and 3. So, it is around into 3. The cow's milk contains 3 times more protein than, cow's milk contains 3 times more protein than human milk. But the digestibility of the proteins, human milk, though it contains 1/3 of the protein content of cow's milk, that protein is better digested than cow's milk protein. Why? Because in the case of human milk, we have more amount of whey protein and less amount of casein. Whereas in the case of cow's milk, there is more amount of casein and less amount of whey. Next is lactose. What is the lactose content? The lactose content of human milk is 7 and the lactose content of cow's milk is 4.5. So this is an easily digestible carbohydrate that is present in human milk is lactose. So you can get a question like, what is the lactose content of human milk? So that is 7 gram. Now next important is the calcium phosphorus ratio. It is more than 2 in human's milk and less than 2 in cow's milk. And then vitamin K, it is very less. The vitamin K content is very less in human milk. And the calories is 67 kilocalories. The calories are equal in both cow's milk and human milk. The difference comes in the protein. It is 1.1 in human milk and it is 3 in cow's milk. So this table, these differences, you need not by heart everything, but these differences are very important. Okay, any type of MCQ can be asked from this particular table. Now, this could be image-based question for you. What is this? This is not a supplementary suckling technique. So what you can see here is that the baby is latching onto the mother's breast, but this is done in mothers who are having lactation failure. What is lactation failure? There is reduction in the breast milk or no breast milk. So the most important stimulus for production of breast milk is sucking. I hope you know that the two reflexes. There are two important reflexes, that is the prolactin reflex and the oxytocin reflex. The prolactin reflex, you can remember it as P for milk production. So prolactin reflex, it mediates increased production of the milk, and oxytocin reflex, it is important for the ejection of the milk. So not out, you can remember it as off or out. So the milk output, so the final release of the milk ejection is by oxytocin, by the contraction of the myoepithelial cells. So the important stimulus for both these reflexes is the sucking of the baby. So what we do is that we ask the baby, make the baby suck on the breast, but the baby might not be getting any milk because the mother is having decreased milk. So what we do is that we take a container and it will be contained either donor milk or formula feed, and with the help of a tube we attach that to the baby's mouth. So when the baby sucks, because of the vacuum, it is actually the milk from the container that is entering to the baby's mouth, but the baby also will start sucking at the breast because there's continuous milk is entering into the mouth, and because of the sucking of the baby, there is stimulation of the prolactin and the oxytocin reflexes, and the mother can relactate. So this is not a supplementary suckling method. So this can be asked as an image-based question for you. Okay. So that is that. Now, there are a few important points that you have to go back and read. That is the signs of good attachment. Please go and read about that. How the baby should be positioned, how the mother should be positioned, what are the signs of good attachment. These are few other areas that you have to just learn about while studying breastfeeding. So please go back to your notes and read about that. Okay. Now, we'll answer some of the questions on breastfeeding. All of the following are true regarding breast milk as compared with cow's milk, except. So, try to answer this with me. So, they are asking about breast milk. It contains more lactose. Yes, right. Contains more amount of proteins. No, contains only 1/3 of the proteins as in cow's milk. Less amount of fat. Yes. Minerals and salt is less. Yes. The solute load is less in human milk when compared to cow's milk. So, the right answer is option number B. That is except. So there are all the following are true regarding breast milk except more amount of protein. So the correct answer is option number B. Now that's all about. So we have dealt about important parts of nutrition, protein, energy, malnutrition. We have covered about micronutrient deficiencies. We have covered about important areas of the anthropometry, growth, short stature, and breastfeeding. This much areas we have completed, and please understand that in pediatrics, all these areas we have covered are very, very, very important. Questions have been asked from these areas. So we have covered that part of the general pediatrics we have completed. Now we will come to another very high yielding area, that is development. So the thing with development is that it's basically by hearting. But please spend that 10 to 20 minutes in by hearting these, because one question from development is a sure shot in any examination. So if you know the developmental milestones and if you are able to recollect that properly, you can get that 4 mark from this 10 to 20 minutes. Okay, so development is a very high yield area. I know it is very boring, it is very difficult to by heart, but if you are able to learn that topic, then you can surely get that 4 marks. You cannot afford to lose that 4 mark because of the difficulty in by hearting. Okay, so please learn development. So we can learn development now. We'll look at all the milestones roughly. We'll brush through it so that it can be a revision session for you also. So under development, we'll be dealing with development under 3 headings. That is, one is, first we'll about the primitive reflexes. Then we learn about the developmental milestones. And then we'll learn about something about disorders of development. A little bit. It's not disorders. These two parts are very important. The last session is not very important from a NEET-PG point of view, but maybe in INICT, for institute exams, even disorders of development can be asked. But the first two is very important even for your NEET-PG itself. So what are primitive reflexes? So primitive reflexes are basically what are primitive reflexes? So primitive reflexes are basically brainstem reflexes, okay? They are basically brainstem reflexes which the baby is born with. And whenever the baby acquires the newer milestones, the primitive reflexes are lost so that the normal developmental milestones are attained. Now, what are the important primitive reflexes? There are a lot of primitive reflexes. You need not learn everything, but the important ones we'll highlight here. So the first one is the palmar grasp. So what is grasp reflex? You place your fingers into the baby's hand and press against the palmar surface. The baby will flex all the fingers. You will press like this, the baby will grasp your hand. That is known as palmar reflex. And the palmar reflex is present from which gestation age? That is a question. So it appears at 28 weeks of gestation. Okay, and when does it disappear? Palmar grasp disappear when the baby develops voluntary grasp. And so about the grasp reflex, it appears at 28 weeks. It appears, and when does it disappear? It around 4 months when the voluntary grasp appears. And what are the stages of voluntary grasp? First, initially at 4 months it is ulnar grasp, ulnar grasp, 4 to 6 months. And then by around 8, that is around 4 to 6 months, it is ulnar grasp, and by 8 months it becomes radial grasp. That is, initially the baby grabs through the ulnar surface and later it becomes a radial grasp. When does it become radial grasp? By 8 months of age. And by 9 months, they'll learn immature pincer grasp. That is, they pick the object with the help of the fingers and the thumb. That is immature pincer. And by 1 year, that is 12 months, it becomes mature pincer grasp. Important, appears at 28 weeks. At 4 to 6 months, voluntary grasp appears. First ulnar grasp, by 8 months radial grasp, by 9 months it becomes immature pincer grasp. At 1 year it becomes the mature pincer grasp. So that is about the grasp reflex. So grasp reflex, again, what I'm talking about is a palmar grasp reflex. Then there is something known as a plantar grasp reflex. Here, what you do is that they touch the sole at the base of the toes. So what happens? The toes will curl. That is known as plantar grasp. The important MCQ point among plantar grasp is that is one of the last primitive reflexes to be lost. It is lost only by 9 months. That is when the baby stands up. That is, and starts walking. So usually by 9 to 12 months, the baby starts walking, right? So the last primitive reflex to be lost is plantar grasp. Then for the purpose of feeding, you have a rooting reflex. If you stroke on the side, the baby will turn the head to that. So it's called rooting reflex. And you also have the sucking reflex. If you stimulate the hard pellet, the baby starts sucking. Then the next important reflex that you have to learn is the Morose reflex. Morose reflex, very, very important reflex. So what do? You hold the baby on the supine position and you gently tilts the head of the baby. So what are the responses which occur in Morose reflex? First, what will happen is that the child will suddenly, the baby will be startled. So what happens? There is abduction and extension of the shoulders. The baby will go like this, and followed by the baby will open the hands, and after that the baby, there is flexion and adduction, and this is followed by a cry. So the components are abduction, extension, hand opening, followed by adduction and flexion, and finally there is a cry. This is known as the Morose reflex. And what about Morose reflex? You have to know, when does it appears? It usually is seen at birth. And when does it disappear? That is important. Usually disappears by 4 to 6 months of age. Persistence of Moro beyond 6 months of age, it's always pathological. Beyond 6 months, if the baby is showing Moro's reflex, it is always a pathological. And Moro's reflex are often used to assess the neurological status of the baby in the initial newborn days. And what are the conditions which can cause an asymmetric Moro? What do you mean by asymmetric Moro? Asymmetric Moro means there is one side the Moro's reflex is absent. That is known as asymmetric Moro reflex. It can occur whenever there is a fracture of the clavicle, or if the baby is having Erb's palsy. These are the reasons for asymmetrical Morose reflex. So that is about, so Morose reflex is an important reflex. And next one is ATNR. What is ATNR? Asymmetrical tonic neck reflex. So ATNR is usually present at birth. So what happens when the baby is led supine and when you turn the head to the one side? So what will happen? The upper limb facing that particular. So you remember like this, if the nose is like this, the upper limb facing that portion will be extended. And that part where the occiput is seen, that will be remained in a flexed position. Okay, so if the baby is looking towards the right side, the upper limb on the right side will be extended and the left upper limb will be in the flex position. So that is known as asymmetrical tonic neck reflex, ATNR. And what is the importance of ATNR? ATNR should be lost so that the baby can roll over. So when is ATNR lost? It's usually lost around, when does the baby roll over? Usually by 3 to 4 months of age. So the ATNR is lost by 3 to 4 months so that the baby is able to roll over. Okay, so that is the importance of ATNR. Then there are other reflexes like Galland's reflex, Landau reflex, parachute reflex, etc. You did not look about all these, but the parachute reflex is important because it is a reflex which appears at 8 months and does not disappear. So which is a newborn newborn reflex which persists throughout life. It is parachute reflex. Okay, so I hope that is clear. Now we'll take a short break and after that we'll get back to you. Okay, welcome back. Moving on. So we dealt about the primitive reflexes. Now here this is another question from primitive reflexes. ATNR disappears by what age? So as I've already said, it usually disappears when the baby is about to roll over. So the answer is around 3 months of age. That is the age of disappearance of ATNR. Now, here there's another question is delayed eruption of teeth is defined as. What is delayed eruption of teeth? We say that the baby has got delayed teeth eruption if the teeth fail to appear by 13 months. Okay, so then it is known as delayed eruption of teeth. And what are the causes of delayed eruption of teeth? It is usually, fried cap. That is the code that we usually use for studying this. It can be familial, or it could be because of rickets or hypocalcemia, or it could be idiopathic, or it could be because of endocrine causes. Most commonly hypothyroidism, hypopituitarism, etc. All these can cause delayed eruption of teeth. And C for cleidocranial dissociasis. What is cleidocranial dissociasis? It is a condition characterized by absent clavicle. The bilateral clavicle will be absent. Okay, so the delayed eruption of teeth, it is defined if the failure of teeth to erupt by 13 months of age, and the common causes is, it could be familial, rickets, idiopathic, endocrine causes, or cleidocranial dissociasis. So that is about delayed eruption of teeth. Now, quickly brushing through the developmental milestones. First, the gross motor. So when does the baby neck hold? 3 months. Rolls over by 5 months. Sitting in tripod fashion, also known as sit with support. It usually appears at sit with support, SSS. Sit with support usually occurs at 6 months. 8 months sit without support. At 9 months stand with support. You can remember 9 as a walking stick. That is how I remember. So 9 months it is with support. The baby stands with support. 12 months creeps well, walks but falls, and stand without support is by 12 months. 15 months they start walking alone. 18 months they start running. 2 years walk up and down and jumping. Jumping occurs by 2 years. 3 years he rides tricycle. So 3 for 3. Riding tricycles at 3 years. And then 4 years hopping. So 4 years, 4 looks similar to H. So 4 years hopping. And alternate feet upstairs is 3 years, and alternate feet going downstairs is 4 years of age. So these are the important developmental milestones. And there is something known as 2 milestones that you have to know: creeping and crawling. Which comes earlier? Yeah, crawling. What is crawling? Crawling is moving on the ground with abdomen on the ground, and creeping is abdomen off the ground. So crawling appears first. That occurs at around 8 months of age, and creeping is usually seen around 10 months of age. So the key gross motor milestones are being discussed. That is neck holding at 3 months, sit with support at tripod sitting at 6 months, sit without support at 8 months, stand with support 9 months, stand without support 1 year. Walking starts by 1 to 15 months, 18 months walks alone, by 2 years starts running, 3 years riding tricycle, 4 year hopping and climbing, alternate feet downstairs and upstairs is at 3 years of age group. So that is a gross motor milestones. Now moving on to the fine motor milestones. The fine motor milestones, what are they? They are the reach. So bidextrous reach occurs by 4 months. By 6 months there is unidextrous reach. So this is important. Bidextrous reach at 4 months, unidextrous reach at 6 months. 9 months there is immature pincer grasp. We have already mentioned about immature pincer grasp. 12 months the mature pincer grasp occurs. So these 4 is very important. Bidextrous reach, unidextrous reach, 9 months immature, 12 months mature pincer grasp, imitates scribbling at 15 months. And then there is something known as the towers and everything. So how will you learn about the towers? Yeah. So towers, you can remember like at 1.5 years, you multiply it with 2. They make a 3 block towers. At 2 years, you multiply by 3, 6 blocks. And at 3 years, they make 3, again into 3, they become 9 blocks. And 4 years, what they do? Yeah, you can see this picture. The 4 years, they start seeing a bridge, and by 4 to 5 years, a gate, and by 6 years, steps. Okay. 4 years bridge, 5 years gait, and by 6 years there will be steps. So this is how you can remember the towers. 1.5 into 2, 3 blocks. At 2 years, 6 blocks. 3 years, 9 blocks. 4 years bridge, 5 years gate, and 6 years step. And then what do they draw? That is the other thing. What do they draw at this ages? Drawing, you can remember like at 3 years, 4 years, and 5 years. And then you have 7 years, 9 years, and 11 years. So what do they draw? At 3 years, they will draw a circle. You can remember like this, 3-year circle. At 4 years, they will draw a cross. At 5 years, they will draw a triangle. At 7 years, they will draw a diamond. At 9 years, they will draw a cylinder. And at 11 years, they will draw a cube. So this is how you can remember. 3-year circle, 4 years cross, 5 years triangle, 6 years diamond, 7 years diamond, 9 years cylinder, and at 11 years they draw a cube. So that is the same thing that has been mentioned in this fine motor milestones. Now the social milestones. The social milestones, when the social smile appears, social smile usually appears by 2 months of age. By 3 months recognizes mother. 6 months of the age for stranger anxiety. 9 months waving bye-bye. So stranger anxiety at 6 months, waving bye-bye at 9 months. Comes when bald and simple ball game at 12 months. Jargon. When does jargon occur? Jargon occurs at 15 months. 18 months domestic mimicry or copying parents in the task. 2 years, they start asking for food, drink, and toilet. 3 years, they knows the full name and gender. So 3 years, it's the age when they know full name and gender. 4 years, they play cooperatively in a group and goes to toilet alone. 5 years, dressing and undressing. So these are the major social milestones. Language milestones again, 1 month alert to sound, 3 months cooing starts, 4 months laugh aloud, 6 months monosyllables, 6 months at monosyllables, 9 months bisyllables, 12 months you can learn like 12 months it is 1 to 2 words, 18 months it is 8 to 10 words. 8 to 10 words. At 2 years, they make 2-word sentences. 3 years, they ask questions and also make 3-word sentences. 4 years, by 4 years, they start singing poems and telling stories. 5 years, they ask the meaning of words. So these are the language milestones. So I've quickly read through this. So please go and by heart these milestones because it is very important for you. And also, next important thing is about hearing. So when the baby turns head to sound at around 3 to 4 months of age, turns head to sound and looks upward by 5 months, looks downward by 7 months, and pivoting, that is look diagonally in the direction of sound by 11 months of age. And at 11 months, another important thing you have to know is 11 months is characterized by the time where there is cruising around furniture. It occurs at 11 months, and pivoting, it also occurs at 11 months of age. Okay, so these are the important developmental milestones. Yeah. So there are multiple questions. I have not taken all those questions because it is simply, if you know the milestones, you will be able to answer. So please go back to your notes and study about the developmental milestones. At which age, whatever milestones develop, it is very important. Okay. Now, which of the following can lead to a regression of developmental milestones? So this is this question. So here, before answering this question, you need to do something about the developmental quotient. What is developmental quotient? Developmental quotient is a formula we use to calculate what is happening to the development in each domain for the child. So it is defined by developmental age divided by chronological age into 100. Okay, so what is the develop? So for example, if a child, he is just 3 years of age, but he's just started walking. So what is the developmental age? It is 1 year. What is the chronological age? It is 3 years. And so the developmental quotient will be around that 1 by 3, around 33%. So that is how you calculate the developmental quotient, and you have to calculate developmental quotient in each of the milestones. And when do you say DQ is normal? A DQ more than 85% is normal. When do you say there is significant delay? If the DQ is less than 70%, you say there is developmental delay. And what is the definition of global developmental delay? If the DQ is less than 70% in more than 2 milestones. more than or equal to 2 domains. If the developmental delay is characterized by GDD, if the developmental quotient is less than 70 in 2 or more domains of development, then you call it as a global developmental delay. And this can be again static encephalopathy or a progressive neurological disorder. What is static encephalopathy? The baby have a developmental delay, but the baby is slowly attaining the milestones. But it is a very slow rate, but there is no loss of attained milestone. Whenever there is a loss of attained milestones, it is referred to as neuroregression. Loss of attained milestones is referred to as neuroregression. So here in this question, they have asked about regression of developmental milestones. So they are asking about neurodegenerative disorders. It's a very vast topic, not very frequently asked in your NEET-PG examination, but can be asked in your institute exams as well. So neurodegenerative disorders can again be classified into white matter diseases and grey matter diseases. And white matter disease characterized by, white matter means mainly the axons are affected. So they are characterized by long tract signs like spasticity, large head, etc. Whereas grey matter disease is characterized by seizures, microcephaly, cranial nerve involvement, etc. Examples of white matter disease are Canavan disease, Alexander disease. Grey matter disease examples are neurod, seroid, lipofuscinosis, pernicious Merzbach disease, etc. It's a very, maybe some hi-fi things when in the point of view of NEET-PG, so I'm not discussing in detail about that. But with pertaining to this question, what is the disease among this four which can cause regression? It is Rett syndrome. So Rett syndrome is a neurodegenerative disorder and it is an X-linked dominant disorder. So since an X-linked dominant, it's only seen affecting girls. It is not seen in boys. And it is characterized by acquired microcephaly, along with peculiar hand movements, the abnormal hand movements. That is the features of Rett syndrome, and the mutation is MECP2 gene. If you're able to remember, you remember. If not also, it is not going to cause much harm. So that is Rett syndrome. Autism is not a neurodegenerative disorder. It is a behavioral disorder of the CNS. And neuromuscular disorder does not cause any regression of the milestones. It may cause a delay, but it is not a condition which can cause loss of the attained milestones. So the right answer for this question is Rett syndrome. Now, here they have a question like, child while playing has sudden loss of consciousness and appears pale. There is no significant medical health history and the child is otherwise healthy. What is the most probable diagnosis? The problem with this question is nothing is given in detail, but the only thing we can do about this question is ruling out the other answers. So ADHD, what is ADHD? ADHD is a disease characterized by hyperactivity, inattention and impulsiveness. There is hyperactivity, inattention and impulsiveness. That is not something which can cause the sudden loss of consciousness. So that is out. Then autism is again a disorder associated with the social and the language milestones where the patient have repetitive stereotypical behavior. But it also does not cause this kind of a presentation. And Rett syndrome, as I've already said, is a neurodegenerative disorder where there is loss of attained milestone. But here we have already said that the baby is otherwise healthy. See, the baby is otherwise healthy. The medical history is not significant. So the only option that we are left behind is a breath holding spell. But is the history typically fitting into a breath holding spell? No. This is very particularly, if you look at this question, this is something known as pallid spell. Pallid spell means the child has a simple stimulus like a simple trauma or anything. What happens? Child becomes suddenly pale and loses consciousness. That is a pallid spell. It is a variant of breath holding spell. What is breath holding spell? Breath holding spell is a condition, a behavioral disorder. What happens is that the baby will start crying and the baby will keep on crying against a closed glottis. So what happens? The baby is not breathing. So the baby will become cyanotic, and because of the CNS hypoxia, what happens? The baby may lose consciousness, and at end it may be also associated with a small amount of seizure as well. So is breath holding spell a worrying condition? No, it is a benign condition. And what is the age group which is being affected most commonly by breath holding spell? Usually occurs after 6 months of age, and it peaks at 2 years of age, and by around 5 years of age, it disappears. So that is a normal natural history of the disease. And what is the risk factor? The only identified risk factor is, one is the anxiety of the child, tantrums of the child, and what is treatable is iron deficiency. Iron deficiency may contribute towards breath holding spell. So treatment of iron deficiency can to some extent control these breath holding spells. So that is about this question. Now, okay, so now we have finished important areas of development. So we covered about the primitive reflexes, the important domains of development, and some disorders of development and behavioral issues also we briefly covered. The most important area you have to focus on the developmental domains and the primitive reflexes. Okay, now moving on to the next topic, that is newborn. Newborn again is a very important topic from an NEET-PG point of view, because multiple questions have been asked from this area, and as I've already said, the same areas have been repeatedly asked. So if you learn a few points about newborn, you will be able to cover most of the important questions which have been asked. So the first question is, a mother reported that her baby did not pass urine on postnatal day 1. What will be your next step? So what do you think is the answer? Yeah, the urine passage, the lack of passage of urine in first day of life can be considered as normal. Why? Because in a newborn, they usually passes urine till 48 hours of, within the first 48 hours of life. That is because for diuresis to take place, it might take some longer, and the allowance that has been provided is 48 hours. So if the baby is not passing urine beyond 48 hours of life, then you should be worried. In the postnatal day 1, if the baby is not passing urine, you just continue breastfeeding and observe. Yeah. That is the answer here. So urine passage within 48 hours. That is the cutoff. Urine should be passed in the first 48 hours. Now, regarding high-risk infants, which of the following are correct? So, what is a high-risk infant? So, there are a lot of criteria that has been put forward for defining a baby as a high-risk infant. Why are we defining a baby as a high-risk infant? Because we can closely follow up this child and improve the outcome, the nutritional, the developmental outcome of the child, if we are earlierly identifying the child as a high risk. So, this chart I have attached here. These are the various factors which should be taken into consideration before calling the patient high risk. So what are the factors? One is demographic and social factors. For example, it's a young mother, less than 16, or an elderly mother with the age of more than 40. Drug usage, alcohol usage in the mother, poverty, unmarried mother. Past medical history, if the mother is having any significant history like diabetes, hypertension, immune-mediated disease, SLE in the mother. Previous pregnancy, if they had complications like neonatal death, prematurity, IUGR, jaundice, etc. in the baby. And in the present pregnancy, if they had an antepartum hemorrhage, multiple gestation, oligo or polyhydramnios, etc. And then factors related to the labor and delivery, premature labor, post-term pregnancy. So what is a post-term pregnancy? It is any pregnancy which is past 42 weeks of gestation. And the baby is having a meconium stain labor, cesarean section, forceps delivery. All these are risk factors with respect to the labor. And neonatal factors like low birth weight baby, or a baby who is having a birth weight of more than 4 kg, preterm or post-term baby, SGA or LGA baby, if the baby is having respiratory distress or congenital anomalies, etc. So this is a very extensive, elaborate list. So please go through this list, and this has been asked previously, so can be asked again also. So please go through this list. So from this answer, we can find out what is the correct answer. So we'll try by ruling out weight of more than 2.5 kg. Is it classified as a risk factor? No, because weight of 2.5 kg is considered to be a normal. Birth order of more than 3. It is not a criteria for qualifying the baby as a high-risk baby. Single parent, yes, it is a risk factor to identify the baby as a high-risk baby. Artificial feeding, yes, if a baby is put on artificial feeding, it is considered to be as a risk factor for qualifying as a high-risk baby. Birth weight less than 85th percentile, no. So what is the definition of LGA and SGA? LGA if the baby's birth weight is more than 90th percentile, and SGA if the birth weight is less than 10th percentile. These two are risk factors, but birth weight less than 85 percentile, it is not a risk factor. So the correct option is option number A, that is 3 and 4. These are the two risk factors for identifying the baby as high risk baby. 1 second. Okay, sorry for that. Now, moving on to the next question. First stool after birth is green due to. Why is it green? Yeah, the first stool after birth is green due to meconium. So something about meconium. So in this picture, you can see three types of stools. So this is a dark green sticky stools. What is this known as? This is known as the meconium. And what is this stool? This is a little bit more lighter, but still it has got a greenish tinge to that. That is known as a transitional stool. It usually happens during the 3 to 4 days of life. And after that, they becomes the golden yellow breastfed stools. So these are the three progression. First there is meconium, then there is a transitional stool, then there is a golden yellow breastfeeding stools. Now something about the meconium. So what is meconium? Meconium is basically water. More than 80% of meconium contains water. It also contains the denuded epithelial cells and also some of the secretions by the epithelial cells. These are the main components of meconium. And now meconium, when should meconium pass? Meconium should be passed within 24 hours of birth. What if there is delay in passage of meconium? What are the causes of delayed passage of meconium? If the meconium is not passed within the first 24 hours, it is known as delayed passage of meconium. It could be because of any surgical causes like any anorectal malformation. The anal opening might not be there. That might be the reason for not passing meconium. Or it could be because of other surgical conditions like Hirschsprung's disease. Or it could be because of something known as meconium ileus, which occurs as a complication of cystic fibrosis, or other medical conditions like hypothyroidism. These are the causes for delayed passage of meconium. And what is the disease condition associated with meconium? It is known as meconium aspiration syndrome, MAS. That is, if a baby has had any increased stress within the uterus, the baby may pass meconium within the uterus itself, and this passed meconium may be aspirated into the lungs and cause a syndrome known as meconium aspiration syndrome. The risk factors are post-term baby, more than 42 weeks. It's a risk factor. And any case of fetal distress. Distress may cause premature passage of meconium. That also may cause meconium aspiration syndrome. So what is the clinical feature? The baby presents with respiratory distress soon after birth. On the X-ray, what you can see? The characteristic appearance is known as sunburst appearance. What is the management? You give supportive management. And what is the complication of MAS? They can develop something known as PPHN, persistent pulmonary hypertension. That is another complication which is usually associated with meconium aspiration syndrome. Yeah, so that is about that. Moving on to the next question. A premature baby develops respiratory distress syndrome. Okay, which cells are defective in this baby? So here the question is from a very, very important area, that is hyaline membrane disease or respiratory distress syndrome. Okay, what is which group of babies are at risk for developing hyaline membrane disease? It is usually seen in premature babies or preterm babies, usually less than 34 weeks of gestation. Now, why does this occur? It occurs because of the deficiency of surfactant. And what is the components of surfactant? Yeah, surfactant mainly contains phospholipids. And the most important phospholipid is phosphatidylcholine, also known as lecithin. It also contains neutral lipids, and the third contains surfactant proteins. SP for surfactant proteins, it can be A, B, C, and D. So these are the components of the surfactant. So what is the lecithin? What is the most important content of surfactant? Is lecithin. This has been asked as a previous year question. Okay. Now, which cells reduce surfactant? Surfactants is being produced by the type 2 pneumocytes. And where are they stored? They are stored in the lamellar bodies. They are stored in the lamellar bodies and they are released by a process known as exocytosis. Now, what is the function of the surfactant? The surfactant, it mainly functions by decreasing the surface tension and prevents the collapse of the alveoli. So, if the surfactant is deficient, it leads to premature atelectasis of the alveoli and the lungs will not be expanded. So, under expanded lungs. And because of this underexpanded lungs, the gaseous exchange will not be proper and the baby will present with respiratory distress soon after birth. Now, when does surfactant appear in the amniotic fluid? So the surfactant synthesis begins at around 28 weeks. At 28 weeks, the surfactant will be visible in the amniotic fluid. Amniotic fluid surfactant will be seen in the at 28 weeks of gestation. And when does the lung maturity complete? It is completed around 34 weeks of gestation. The lungs become mature. So in any baby who is born before 34 weeks of gestation have the risk of developing RDS or hyaline membrane disease. Now, what are the risk factors for developing RDS? The risk factors for developing RDS, the most important risk factor, as I've already said, is prematurity. And the second risk factor is infant of diabetic mother, because if the baby is having excessive amount of blood glucose levels, it may interfere with the formation of the surfactant. So infant of diabetic mother and prematurity are the two important risk factors for developing respiratory distress syndrome. Okay, so how will the baby present? The baby will present with respiratory distress soon after birth. And now what are some of the important named tests which can be used for diagnosing RDS? The investigations previously, when x-rays were not there, something known as a shake test, it was a bedside test, was used for diagnosing surfactant deficiency. Here what you do is that you take 0.5 ml of the gastric aspirate and you mix it with equal amount of 95% ethyl alcohol, and after that you will see whether the bubble, shake it for about 15 seconds and then you keep it for 15 minutes and you see whether bubbles are formed or not. If bubbles are formed, it means that surfactant is there. If bubbles are not formed, it means that there is surfactant deficiency and the child is at risk for RDS. So that is one of the older tests that was used for the diagnosis of RDS. Now it has not been used because of the widespread use of X-rays. We have a small technical problem. We'll take a short break now. Okay, we'll resume now. So that was about shake test. And the second one that we previously used to use is something known as lecithin by sphingomyelin ratio, L by S ratio. And if L by S ratio more than 2, it means that we have a mature lungs. And another previously used test was known as lamellar body count. This lamellar body count, if it is more than 50,000 per microliter, it is a sign of mature lungs. So these are old tests, might be asked for an MCQ point of view, not practically important right now. These were used in order to see whether the child is at risk for RDS or not. Now what we have now, if any child at preterm baby, if it is born with respiratory risk, we take it as RDS, and we can also always take a chest X-ray. And what are the chest X-ray findings in a child with respiratory distress syndrome or hyaline membrane disease? There can be air bronchogram. And there can be under-expanded lungs. Ground glass opacities. And finally, at the severe stage, there can be something known as whiteout lung. So whiteout lung, one point I'd like to highlight is whiteout lung can be seen in another two conditions as well. What are they? One is obstructed TAPVC. So if you see a child, especially if a term baby with a whiteout lungs and respiratory distress, you should always think about a cardiovascular condition, that is obstructed TAPVC may also present as whiteout lung. And the second one is surfactant protein deficiency. Surfactant protein deficiency may also, it's a congenital defect, they also be present as a whiteout lung. Okay, so these are the investigation findings. So how can you prevent? So if you are anticipating a preterm delivery, then you can do certain measures in order to reduce the risk of developing an RDS. What are they? We can give antenatal steroids. Antenatal steroids, because steroid helps in hastening or speeding up the lung maturation process. So antenatal steroids are given for any baby between 24 to 34 weeks of gestation if the delivery or impending delivery is being anticipated. And there are two courses. Either you can give betamethasone or you can give dexa. And betamethasone, the doses you give 12 milligram as IM. And you give it daily, Q24 hours for 2 doses. These are all important. Please study these. Betamethasone 12 milligram intramuscular daily for 2 doses, or you can give it as dexamethasone, which is given as 6 milligram intramuscularly, Q12 hourly, and you give it for 4 doses. So betamethasone or dexamethasone. Betamethasone 12 mg daily 2 doses. Dexamethasone 6 mg 12 hourly, you give it 4 doses. And when is it given? It should be given minimum 24 hours before delivery. Should be given minimum 24 hours before delivery. And for example, if you gave this dexamethasone, but the delivery did not happen, the 1 week have passed. So if more than 1 week have passed after the point of giving the steroid, and after 1 week the baby is going to deliver, then you have to repeat. So if there's more than 1 week has passed after giving this antenatal steroid, you can always repeat a second dose. So this is antenatal steroid. Very important. You have to study this. And then how will you manage the treatment? The treatment of RDS or highly membrane disease is basically to prevent the atelectasis. That is, you have to maintain the FRC, that is functional residual capacity, so that the alveoli are protected from complete collapse. So what is the gold standard treatment option for hyaline membrane disease? CPAP. Very important question. So what is the diagnostic or the treatment of choice for a child with hyaline membrane disease? It is CPAP. If the CPAP is failed, when do you say there is CPAP failure? That is, even after putting the child in CPAP, the child is having a persistent distress, requiring a supplemental oxygen with FiO2 of more than 40%, then you call that this child is having failure of CPAP. That is, this distress is not settling with CPAP alone. What is CPAP? It is continuous positive airway pressure. Then you have to give exogenous surfactant. That is, the child is having a deficiency of the surfactant, so you administer surfactant. How was surfactant administered? Surfactant is administered in different methods. The classical method in which it is administered is Ensure. What is Ensure? Intubate, surfactant is given and extubate. In for intubation, SUR for surfactant, and then you extubate. Now there are newer modalities of treatment that has been available without intubation. So you can give MIST, minimally invasive surfactant therapy, or LISA, less invasive. These are basically the same thing. MIST, also known as LISA, minimally invasive surfactant treatment or less invasive surfactant administration. And another newer form of administration is there, that is known as INREC-SURE. What is that? You intubate, then you connect the baby to the ventilator for a short time, especially to HFOV ventilators, that it gives some positive pressure and the lung gets recruited, and after that you extubate. That is known as INREC-SURE. It's a newer modality of giving surfactant. So these are the important points. So RDS is a very important point. You should know each and every point that I have mentioned here is an MCQ. So please learn about that. Okay. So what is this? Let's go back to the question. A premature baby develops respiratory distress. Which cells are defective in this baby? Yeah, you're right. It is the type 2 alveolar pneumocytes. Right answer. Now, next question. A newborn present with chest retractions, dyspnea, and lethargy. The baby is diagnosed having respiratory distress syndrome by the pediatrician. This occurs due to the deficiency of, yes, lecithin, also known as phosphatidylcholine. That is the right answer. Next. Ensure is associated with which condition? Ensure is intubate, surfactant, extubation. It is given with respiratory distress syndrome. The newer methods are LISA and MIST. That can be asked in your NEET-PG also. LISA means less invasive surfactant administration. MIST is minimally invasive surfactant therapy. Now, which of the following are components of Downey score? So here the question is about Downey score. So what is Downey score? Downey score is a scoring system which we mainly use for term babies in order to degrade the severity of their respiratory distress. So look at the scoring system. Very important question. Downey score. So modified Downey score, the components are respiratory rate, presence of cyanosis, retractions, grunting, and air entry. So respiratory rate, so the scoring is 0, 1, and 2. Less than 60 score 0, 60 to 80 score 1, more than 80 to score 2. Cyanosis, absent in room air, score 0. No cyanosis, oxygen support. How much oxygen? Less than 40% oxygen. Then it is grade 1. Cyanosis, in spite of oxygen support such that the FiO2 requirement is more than 40%, then it is scoring is 2. Retractions, none, mild and moderate to severe, 0, 1, 2 respectively. Grunting, none. Audible with stethoscope, then it is score is given as 1, and if it is audible even without stethoscope, the score is given as 2. Air entry good, decreased, barely audible. So if the lungs is not expanded, the air entry will be reduced. So based on that, the final parameter is air entry. So 1, 2, 3, 4, 5 parameters are used: respiratory rate, cyanosis, retractions, grunting, and air entry. And if the score is less than 3, it is considered to be as mild. 4 to 6, moderate. And if it is more than 7, it means severe distress. And this might be an indication, can be considered as an indication for the child is going for respiratory failure and may require mechanical intubation and surfactant administration. Okay, so that is about the Downey score. So here you can try answering this question. What are the components? Respiratory rate, yes, it is a component. Feeding, no. Grunting, yes. Cyanosis, yes. So the answer is 1, 3, and 4. The option number B is the right answer. Now, as I've already said, Downey score is used for children who are term. So what score do you use for preterm babies? You use something known as Silverman-Anderson score. If you ask me which is more important for your entrance point of view, I'll always say Silverman-Anderson score, because SAS has been asked multiple times in your exam. So please study the Silverman-Anderson. They might even show you a video of the baby and ask to score the Silverman-Anderson scoring. So SAS is very important. So what are the... Sure. everyone. So we'll just finish off what you were just mentioning about. We were talking about how to score respiratory distress in a preterm baby. So in term baby, the scoring that we use is Downey score, and preterm babies what we use is a Silverman-Anderson scoring. That is, the parameters here used are 1, 2, 3, 4, 5 parameters. Upper chest retractions, lower chest retractions, xiphoid retractions, flare of the nasal, LA nasal flaring, and finally the expiratory grunt. You can use the code X-lung. This is the code that we commonly use for this. X is for xiphoid retractions, L is for lower chest, U is for upper chest retraction, N is for flaring of the LA nasal, and G is for grunting. So again, the scoring is like 0, 1, and 2. Upper chest retraction, if it is synchronized, 0. If there is a lag on inspiration, it is grade 1. If it's seesaw pattern, it is grade 2. Lower chest, no, just visible and marked, 0, 1, and 2 respectively. Xiphoid retractions, mild, just visible and marked. Nare again, if it is none, minimal and marked retraction. And expiratory grunt, similar to what we studied in Down syndrome. Downey scoring, that is expiratory grunt is absent if it is heard only with the stethoscope. And the third one, if it is audible even without the stethoscope. So this is known as the Silverman-Anderson scoring. So remember the mnemonic X-lung. And now how will you score? That is, if the score is more than 7, similar to what we studied in Down score as well. Downey score, a score more than 7 indicates that the baby is respiratory failure and requires maybe mechanical ventilatory support. Okay, so this covers most of the important topics regarding respiratory distress and hyaline membrane disease. Now we'll go back and see one question which I had skipped in between. Yeah. Here you have a term baby, newborn, who has a birth weight of 2,700 grams, that is 2.7 kg, with jaundice on the 5th day of life, with serum bilirubin of 14. So what is the appropriate management? So here the topic of interest is neonatal jaundice. So here on the 5th day, the value of 14. What do you think? Yeah, according to that, any value of more than 15 beyond 5 days, only if the value is more than 15, the baby requires phototherapy. So here you can see that the baby can be continued with the routine newborn care. So that is the right answer because there are no other identified risk factors for developing a jaundice. So what are the important points you have to know about the neonatal jaundice? This is also a very important area. Frequently questions have been asked from this. So neonatal jaundice can be, first of all, it can be divided into unconjugated and conjugated. But conjugated, we usually use the term as neonatal cholestasis and we usually take it as a separate entity. Now we are talking only about the unconjugated hyperbilirubinemia. That is neonatal jaundice, which can again be divided into two types: physiological jaundice and pathological jaundice. And this classification is basically depending on when the jaundice, onset of jaundice. If it is less than 24 hours, it is known as pathological jaundice. That is, if the baby develops jaundice within 24 hours of life, then it is known as pathological jaundice. If the baby develops jaundice beyond 24 hours of life, it is more likely to be a physiological jaundice. Why the babies develop physiological jaundice? Physiological jaundice occurs because when the baby is born, they have very high hemoglobin content. And after birth, this hemoglobin all undergoes hemolysis and bilirubin is being formed. But the liver enzymes are immature in the newborn baby to handle this much of unconjugated bilirubin. So because of that, there is a mild increase in the level of the unconjugated bilirubin, which is physiological, does not require any treatment and will come down on its own. How is the natural cause of physiological jaundice? It usually appears after 24 hours of life and it usually peaks in 2 to 3 days of life and it usually settles by 7th day of life. So this is the normal way in which the physiological jaundice progresses, and this does not require any treatment. We can look at the check the serum bilirubin levels, and you can plot it against the graphs. We have phototherapy graphs as well as exchange transfusion graphs, and only if the baby's value is getting above the phototherapy line, then only we will have to give phototherapy. Otherwise, breastfeeding itself is necessary. Only breastfeeding is necessary. So this case, in this baby, there is no risk factors. The baby is otherwise feeding well. The bilirubin value is only 14. So the answer is simply to continue breastfeeding. Now, what if the baby is having pathological jaundice? So pathological jaundice, there are a number of causes. The most important cause for developing pathological jaundice is when there is a blood group incompatibility, especially if there is an RH incompatibility, that is an RH negative mother giving rise to an RH positive baby, especially if the second baby. The first baby will be spared. During the first baby, sensitization occurs, and during the second baby, the hemolysis occurs. Or even ABO incompatibility in some cases may cause severe hemolysis. The second causes maybe it could be because of some enzymopathies. That is hereditary enzymopathies which can present as hemolysis in the initial newborn period are hereditary spherocytosis, G6PD deficiency. These are two hemolytic anemias which can present even in the newborn period. All your other things like sickle cell thalassemia usually presents after 6 months of life, but these two can even present in the newborn period. And the third causes, it could be because of if there's any bleeding in the child. Most commonly there can be a cephalhematoma. That is the bleeding can be seen in the subperiosteal plane because usually occurs because of instrumental delivery, traumatic delivery. So what happens? Blood is being collected there, and this collected blood undergoes hemolysis and result in hyperbilirubinemia. So cephalhematoma can be a risk factor for developing this thing, or if it's a subgaleal bleed, subgaleal hemorrhage. It's also a different type of hemorrhage where the bleeding occurs under the galea, galea aponeurotica, which can cause rapid fall in hemoglobin as well as increased hyperbilirubinemia. So these are another risk factors. And the fourth and the most common one is breastfeeding jaundice, and last is breast milk jaundice. So what is breastfeeding jaundice? Breastfeeding jaundice usually appears early, usually in the second or third day of life. It is occurring because of the defective or the inadequate breastfeeding. So when there is inadequate breastfeeding, there will be exaggerated enterohepatic circulation. So whatever bilirubin goes into the gut is being recirculated by the enterohepatic circulation, and there is excessive hyperbilirubinemia. So what is the treatment option? You have to ensure proper breastfeeding, and if needed, you can give phototherapy. Now, what is breast milk jaundice? Breast milk jaundice is something which occurs in a later time, usually maybe after 7 days of life or in the second week of life. What is it? Because of a certain end substance that is present in the breast milk, which can inhibit the conjugation of bilirubin, and this cause increase in the level of the unconjugated bilirubin. So even if it is a breast milk jaundice, there is no need of stopping breastfeeding. We have to continue breastfeeding and observe the child. These are the more important causes of pathological jaundice. Okay, now what will you do if the baby have a jaundice? So how will you assess the jaundice level in a baby? We have something known as a Kramer's visual inspection scale. It is a visual inspection of jaundice. So what happens is that whenever the unconjugated bilirubin increases in the body, it causes pigmentation, icterus. And this icterus always follows from the cephalocaudal direction. First it appears on the face, and last area to be affected is the palms and the soles. So by seeing which area there is icterus, we can identify a rough estimate of what the serum bilirubin value will be. That is called as the Kramer's zones. Now how do you see the Kramer's zones? So if you have a man like this, just pardon with my drawing skills. So you can remember like from below. If the palms and soles are involved, these are the palms and soles. If the palms and soles are involved, then the value is more than 15. The serum bilirubin value will be more than 15, which is usually abnormal and may need interventions like phototherapy. Now, if it is involving the legs, it will be 10 to 15. Okay, legs and if it is involving the thighs and the upper part of the leg, then it will be 8 to 10. The value will be 8 to 10. And if it is the upper chest and abdomen, then it will be 6 to 8. And if it is the face, it will be 4 to 6. So if you go from down upward, you won't mistake. So it is more than 15. The lower legs and the upper thighs, it's 10 to 15. Lower part of the abdomen and the thighs, it is 8 to 10. Upper chest, 6 to 8. And the face, it is 4 to 6. So this is the Kramer's index. This can be asked as a question like the baby is having icterus here. So what will be the rough estimate of the serum bilirubin levels? So Kramer's index is used usually only till 2 weeks. After 2 weeks, Kramer's index is not a reliable marker for identifying the icterus. Okay, so that is about that. Now, how will you manage if the baby is having very high levels of serum bilirubin value? You may need to start phototherapy. So, what about phototherapy? So, phototherapy you will usually start at a nanometer of 460 to 490 nanometer. What does this phototherapy do? It converts the toxic bilirubin, or the unconjugated bilirubin is a toxic form of bilirubin, okay, into conjugated or the more soluble form of bilirubin, that is known as lumirubin. And that is being excreted out in the urine. If it's a very high value, you may even go for exchange transfusion. The second modality is exchange transfusion. Okay. Now, why are we worried? Why are we worried that if the baby has got hyperbilirubinemia, let it increase? Why should we be worried about it? Yeah, you are right. We are worried about hyperbilirubinemia because in the babies, this unconjugated bilirubin is water soluble and it can be excreted in the urine. But this unconjugated bilirubin is not water soluble and it is toxic. Why is it toxic? It is water insoluble and it is toxic. Why it is toxic? In the babies, the blood-brain barrier is not mature. And even more risk is there if the baby is a preterm baby, the blood-brain barrier will be even more immature. So it will crosses the blood-brain barrier and cause injury to the CNS and leads to something that is referred to as kernicterus. So in order to avoid this or prevent this complication from happening, we are aggressively managing this hyperbilirubinemia so that this particular sequelae does not happen. So what is kernicterus? Kernicterus can later lead to a peculiar type of cerebral palsy known as chorioethitoid cerebral palsy. Okay. Extrapyramidal CP or chorioethitoid cerebral palsy can occur as a complication, the later sequelae of kernicterus. So that is the reason why we are aggressively managing this hyperbilirubinemia in children. Okay, that is done. Now we'll move on to the next question. All this we have already answered about the respiratory distress syndrome and everything. Okay, now a pregnant patient has taken lithium and the neonate should be screened for what? So we are now dealing with teratogenic drugs. Okay, teratogenic drugs. So the teratogenicity of there are various teratogenic drugs and here they have asked about lithium. So what does lithium cause? Lithium causes Epstein anomaly. So the defect that is associated with the maternal intake of lithium is Epstein anomaly. So can you mention some other teratogenic drugs which are important? Yeah, there are a lot of teratogenic drugs. Actually, we have a code as well. So this is known as teratova. T for thalidomide. And what does thalidomide cause? It causes something known as phocomelia and limb defect. And then you have E. What does E stands for? Anti-epileptic drugs. And among the anti-epileptic drugs, you have phenytoin. It is teratogenic. And it can cause neural tube defects and cardiovascular side effects can occur with phenytoin. And next one is valparin. It can also cause cardiovascular and CNS defect and carbamazepine. It can also cause cardiovascular defects, CNS defect, especially neural tube defects. And then R is for retinoids. So increase in vitamin A can also cause CNS defects and cardiovascular defects in the baby congenital heart diseases. A is for ACE inhibitors and ARBs intake by the mother can cause intrauterine fetal insufficiency. T is for third element, that is lithium. Lithium is the third element and lithium causes Epstein anomaly. O is oral contraceptive pills. It can cause virilization of the fetus. And then you have warfarin. W is for warfarin. What does warfarin cause? Warfarin causes hypoplastic nasal structures. And A is for alcohol. So fetal alcohol syndrome can be asked as a question for you. It causes microcephaly, limb anomalies, and congenital heart diseases. So these are some of the important teratogenic drugs. And another important teratogenic drugs that you can remember is vitamin D. Excess intake of vitamin D in the mother can result in supravalvular aortic stenosis. And among antithyroid drugs, carbimazole. What does carbimazole cause? And methimazole also. Carbimazole and methimazole. What does intake of carbimazole and methimazole cause? It causes aplasia cutis, that is scalp defects, choanal atresia, tracheoesophageal fistula, and also fetal goiter. Okay, so these are the important teratogenic drugs. Any MCQ can be asked. The most important one which has been asked here is the lithium, which causes Epstein anomaly. Okay, and a fetal alcohol syndrome can also be asked as an MCQ for you. Now, there are certain another MCQ point that you have to learn is there are certain drugs which are taken by the baby itself which can cause injury to the baby. So what are they? These are not taken by the mother, the fetal, the drugs which cause adverse effects in the baby. Adverse effects in infancy, drugs which are not routinely given during infancy because of their common drug adverse effects. The most important one is oxygen. Excessive oxygen causes retinopathy of prematurity and bronchopulmonary dysplasia. Second one, chloramphenicol. What does chloramphenicol cause? Chloramphenicol causes something known as gray baby syndrome. Then tetracyclines. What does tetracyclines cause? It causes enamel hypoplasia. Then aminoglycosides, as you all know, aminoglycosides can cause ototoxicity and nephrotoxicity. Then lastly, erythromycin. Erythromycin can cause hypertrophic pyloric stenosis. Okay, so these are some of the important drugs by the baby as well as by the mother and the common side effects. Anything out of this can be asked as a question, so please try to remember these. Now, next question is a 28-year-old female with Graves' disease was taking medication for hypothyroidism during pregnancy. So the baby mother was taking some drug for hyperthyroidism. She delivered a child with congenital anomaly and aplasia cutis congenita, which is the most likely drug which is responsible for this teratogenic effect we have already studied. That is carbimazole. Carbimazole is a drug and also methimazole to some extent, if taken by the mother, can result in aplasia cutis and also can result in other cardiovascular side effects in the baby. Other birth defects can also occur. Okay, that's that. Now, which of the following will be moving on to the next question, which of the following will be an incorrect laboratory finding in RH incompatibility? So RH incompatibility is a important topic for your NEET-PG. So what is RH incompatibility that you all will be knowing? RH negative mother, during their first pregnancy, if the baby is RH positive, the mother gets sensitized, antibodies are formed in the mother, and when the mother conceives for the second time, and if that baby is also RH positive, the antibodies crosses from the mother to the baby and causes hemolysis in the baby. And this is a condition known as hemolytic disease of newborn. Okay, so what happens? There is excessive hemolysis. So from the hemoglobin, there is release of heme. And this heme undergoes conversion by heme oxygenase. That is the name of the enzyme, gets converted into biliverdin. And this biliverdin then gets converted into unconjugated bilirubin. And what happens? The unconjugated bilirubin is, as I've already said, it is toxic and water insoluble form. This unconjugated bilirubin is bound to albumin, and this bound form of unconjugated bilirubin reaches the liver. And in the liver, conjugation occurs by the enzyme UDP glucuronyl transferase and forms conjugated bilirubin. Okay, the conjugated bilirubin is a non-toxic and the water-soluble form. So what happens is conjugated bilirubin? The conjugated bilirubin then gets converted into, this conjugated bilirubin then gets converted into stercobilinogen and urobilinogen. And this gets converted again into stercobilin. Urobilinogen gets converted into urobilin. Stercobilinogen gets excreted in the stool, S for stool. Urobilinogen gets excreted in the urine. And some of the stercobilinogen may undergo enterohepatic circulation and may go back into the liver. So this is how the bilirubin metabolism takes place. So you have this in mind. Now let's try answering this question. So, which of the following will be an incorrect laboratory finding in RH incompatibility? Raised unconjugated bilirubin, is it true or false? Yes, unconjugated bilirubin obviously will be high. Increased urine bilirubin. No, bilirubin is not excreted in the urine as such. Raised urine urobilinogen? Yes. Raised stool stercobilinogen? Yes. So the wrong answer is increase in the urine bilirubin. So this is how the bilirubin metabolism takes place. Now, a little bit more about RH incompatibility. How do you manage RH incompatibility? The treatment basically is exchange transfusion. That is the most important treatment for RH incompatibility. We have to remove all these antibodies and the excess bilirubin. Otherwise, the baby will go in for cardiac arrest. So, what is the indication for exchange transfusion? So, we look at the cord blood. Two values are looked for: hemoglobin and total bilirubin. If in the cord blood the hemoglobin is less than 10 or the total bilirubin is more than 5, then it is an indication for starting exchange transfusion. What we do here is a double volume exchange transfusion. That is the procedure that is being done in newborns. And the second option is we can, as this is an antibody mediated disease, if the baby is not responding to ET, then you can always give IVIG, intravenous immunoglobulin, which can block this maternal antibodies and control the hemolysis. The dose is 1 gram per kg, which is given over 2 hours. And how will you prevent this? If the mother have already had an RH negative mother, gave birth to an RH positive baby, in the second delivery, the mother can be given anti-D, so that this isoimmunization can be prevented. Investigations, this will be showing a DCT and ICT will be positive. ICT is a test which is done in the mother and DCT is a test that is being done in the baby. DCT and ICT will be positive in RH isoimmunization. Okay, so that is about RH incompatibility. Now, a newborn baby born through cesarean section did not cry immediately after birth. On further evaluation, the baby had a heart rate of less than 60. What will be the next step? So now we have a few questions which are coming from the topic of neonatal resuscitation program or neonatal resuscitation protocol. So first we look at the neonatal resuscitation protocol and after that we'll try to answer these questions. Okay, so NRP. Please pay attention because NRP is a very frequently asked question. It is a high yield area. So please pay attention. Okay. So neonatal resuscitation program. Okay, so what happens is that before delivery, there are, actually now this is a 2020 modified NRP. There are certain differences between the 7th edition and the 8th edition. So before we are planning, so if we have a delivery happening, there will be pediatrician in the labor room. So when a high-risk delivery is happening, there are 4 pre-birth questions. There are 4 pre-birth questions that you have to ask before the baby is being born. What are these 4 pre-birth questions? First one is the gestational age. Second one, what is the color of the amniotic fluid? Whether it is there could be some bleeding, there could be a meconium stained amniotic fluid. What are the additional risk factors of the mother, like multiple gestation, gestational diabetes mellitus, fetal bradycardia? There's multiple risk factors. And the 4th question, that is the important, that is a news change. The 4th question is umbilical cord management plan. Previously, the question was how many babies, but now the question have been changed to umbilical cord management plan. Why is it important? Because in a normal baby, if it's a well baby, a vigorous baby, then we practice something known as delayed cord clamping, right? What do you mean by delayed cord clamping? We delay the clamping the cord by a time gap of 60 seconds. Why are we doing this? It helps in reducing the risk of neonatal anemia. So that much of blood extra is getting to the baby. Okay, so this delayed cord clamping is done only if the baby is a well baby. But if the baby is having some risk factors and the baby requires immediate resuscitation, this delayed cord clamping is not done. So we have to, before delivery itself, we have to have an umbilical cord management plan. So these are the 4 pre-birth questions. Now, what happened once the baby is born? Then first we do an antenatal counseling, team briefing and equipment check and everything. So once the baby is born, what will you look? Whether the baby is term and whether the baby has a good tone and whether the baby is breathing or baby is breathing means crying. The first respiratory effort of the baby is basically crying. So gestation, tone and cry. These are the 3 important things that you look for. And if the baby is not doing that, then you do the initial steps. That is, you try to stimulate the baby. How do? You first warm, then you dry, stimulate, position the airway, and you suction if needed. And even after that steps, the baby is not responding, the baby is apneic, or the baby is gasping, or if the heart rate is less than 100, what do? That is an indication for starting positive pressure ventilation, PPV. And once positive pressure ventilation is starting, you have to connect the baby to a pulse oximeter, and it's always better if you have a cardiac monitor or ECG monitor attached. And even after giving PPV for 1 minute, so all these steps are completed in the first 1 minute, the baby is not responding, the heart rate is less than 100 itself, then you can ensure that we are giving the PPV in the correct method. So you have certain steps known as the MR SOPA. That is a corrective method of, if you are not giving the PPV, the positive pressure ventilation, if you are not giving properly, we might not get the improvement in the heart rate. So what is MR SOPA? MR SOPA, the first a few corrective steps that you take in order to ensure that we are giving the PPV correctly. So what is M? M stands for mark repositioning. The mask might not be correctly placed. So that stands for mark repositioning. And then R. R is for reposition the airway. The baby might be lying with a flex neck or something like that. So you have to reposition airway. And S is you have to give suction if needed. Sometimes there may be secretions collected, so you have to give a suction. O is for open the mouth, wide opening of the mouth. P, you ensure that the pressure that you are giving is correct. And A is, if this is not working, then you have to consider additional or another airway, like endotracheal tube, LMA, etc. So you take the corrective steps, and after that also, you can either corrective steps and try giving PPV itself, and consider endotracheal intubation or laryngeal mask airway if you're not able to get adequate chest rise with positive pressure ventilation. And even after that, if the heart rate is less than 60, then it is an indication for starting chest compressions. If the heart rate is less than 60, then you have to give chest compressions along with bag and mask ventilation or PPV. And once you're starting chest compressions, till then we were resuscitation, the resuscitation was being done using how much percentage of oxygen? 21% oxygen if the baby is more than 35 weeks of gestation. If the baby is less than 35 weeks of gestation, we can use 21 to 30% of oxygen. But once you start chest compression, you have to increase the oxygen to 100%. And even after giving chest compression, the heart rate is less than 60, you have to give intravenous adrenaline. So this is the basic steps of neonatal resuscitation protocol. So quickly revising it once more, you can recall it along with me if you are hearing this live. So the baby did not cry after birth. DCAB means did not cry soon after birth. So what you first do, you step the initial steps. What are the initial steps? You warm, dry, stimulate, position the airway, and give suction if needed. After that also the baby is not responding. The heart rate is less than 100 and the baby is not breathing. Then you will do positive pressure ventilation, and then you give it for about 1 minute. So the entire steps should take around 1 minute. At the end of 1 minute, if the baby is not improving and the heart rate is less than 100, PPV can also be considered as bag and mask ventilation. So if the heart rate, even after giving PPV, the heart rate is less than 100, you can do MR SOPA, the corrective measures, and you can consider endotracheal intubation if the baby is not improving. Okay, endotracheal intubation if needed. And even after that, the baby is not improving, and if the heart rate falls below 60, then what do you have to do? If the heart rate is below 60, you have to do chest compression along with bag and mask ventilation. And at this time, you increase the oxygen to 100%. Till here, we were using 21% for term babies, and preterm babies, that is less than 35 weeks, we are using 21 to 30% FiO2. But once you start chest compression, you increase the FiO2 concentration 100%. And even after that, if the baby is not improving, heart rate is less than 60, then you can give an UVC, an arteriovenous line is put, and you can give adrenaline. So if you're not able to get an arteriovenous venous access, then you can always give it via UVC, or you can also give it via the endotracheal tube. Intratracheally also you can give this adrenaline. So this is in a nutshell what you have talked about in NRP. And here there is another important area. What is the target oxidation? When we are doing this, what is our target? We have a pulse oximeter connected. So how do you know the baby is getting adequate oxygen? You do not expect an oxygen SpO2 of 100% soon after birth. At 1 minute, the oxygen saturation is 60 to 65. Then it increases in increments of 5, and it only at the end of 10 minutes, the SpO2 improves to 85 to 95%. So this is the target oxygen saturation at various times: 1 minute, 2 minute, 3 minute, 4 minute, 5 minutes, and 10 minutes. Okay. Now, a few changes. So already I've mentioned the first change. The fourth question has been changed to umbilical cord management plan. And the next change is that initial steps was the order of the initial steps has been changed. Now it is warm, dry, stimulate, position the airway, and suction if needed. And then whenever we are placing an alternative airway, they say that a cardiac monitor has to be applied. And the dose of adrenaline here is, if you are giving adrenaline, you have to give it at a dose of 0.02 mg per kg. If it is via the UVC, if you are giving it via the trachea, the dose is 0.1 mg per kg. And when to stop resuscitation, they usually give a cutoff of 20 minutes. Even after 20 minutes of active resuscitation, the baby is not improving. After discussion with the parents and your team members, you can even stop the resuscitation. That is one of the latest changes that has been brought by the NRP 8th edition. Now, there are another few important points. What is the most important step in the neonatal resuscitation protocol, which is greatest survival benefit is given derived from? Yes, the positive pressure ventilation. If you're able to give the correct positive pressure ventilation, that's the most important resuscitation step that you have to timely do, so that the baby survival can be. So most important step was positive pressure ventilation. And what is the best indicator of improvement? Increase in heart rate. Whenever the baby is having an improved ventilation, the first change that you can see is the improvement in the heart rate. So first clinical sign you can see once the baby starts improving is the improvement in heart rate. The most important step to be taken is positive pressure ventilation. And how do you give positive pressure ventilation? And if you're giving chest compressions along with bag and mask ventilation, what is the ratio? It is 3:1. You give 3 times chest compressions followed by 1 time bag and mask ventilation. Pediatrics, you usually use a 15:2, but here in newborn, the ratio is 3:1. Okay, so I hope that is clear. Now let's try answering these questions. Okay. A newborn baby born through cesarean section did not cry soon after birth. On evaluation, baby has a heart rate of less than 60. So what will you do? If the heart rate is less than 60, it is always chest compressions along with bag and mask ventilation. And even after that, if the baby is not improving, you have to give adrenaline. Okay. Now, what is the indication for starting chest compressions? Again, same question if the heart rate is less than 60. Now, how much percentage of oxygen should be given to a newborn in the neonatal resuscitation? The baby is having apnea or heart rate less than 100. Ideally, this question should have specified whether the baby is having a term or a preterm baby. So I have already said, if the baby is a term baby, you start it at 21% more. If the baby is more than 35 weeks, if the baby is less than 35 weeks, then it is 21 to 30% of FiO2 is used. Okay. Hope that is clear. So that is about NRP. Very, very, very important. Multiple questions have been asked and will be asked again. So please make sure that you know the NRP very thoroughly. Now, which is the most possible finding seen in an infant of diabetic mother? So here there is another important area, EDM. So what are the problems associated with infant mother? Quickly, we will mention it only in points. So first one is because of the high blood sugar level in the mother will be having insulin resistance. So because of the insulin resistance, the mother will be having hyperinsulinism, and the baby will also be having hyperinsulinism. And as you all know, insulin is an anabolic hormone, and because of that, the baby will be having increased growth of all the tissues in the body, resulting in the macrosomia or an LGA baby. All the organs are enlarged except, yes, brain. All the organs are enlarged except the brain. And second one, what is the another problem? Because of the hyperinsulinism, they are at higher risk of developing hypoglycemia. So what is the cutoff for hypoglycemia in the newborn period? It is usually taken as less than 45. Okay. And then third complication is they are at high risk of developing hypocalcemia and jitteriness, and because of hypocalcemia they have high risk of developing jitteriness as well. What is the cutoff of neonatal hypocalcemia? It is usually done if it is serum calcium is less than 7 or ionized calcium less than 1. This is the definition for hyperinsulinism, macrosomia, hypoglycemia, hypocalcemia, and they are also at high risk of polycythemia. And because of the polycythemia, they are at increased risk of, all this hemoglobin undergoes hemolysis and they are at increased risk of neonatal jaundice. And since the baby is a very large baby, they are at high risk of developing obstructed labor. And they can develop complications like shoulder dystocia, Erb's palsy, cephalometoma. Birth injuries are more common in infants of diabetic mother. Then what are the other congenital defects associated with this CVS? The most common is ASH, asymmetrical septal hypertrophy, and VSD. The next more common is ventricular septal defect, and the most specific is TGA, transposition of great arteries. In the CNS, the most specific anomaly that you see is sacral agenesis. Sacral agenesis can occur as a complication. You may even get, it's also known as a mermaid syndrome. That is, both limbs will be fused together. You can even get an image-based question from this. That is, both the lower limbs be fused together. So, in which disease you get this anomaly? It is usually seen in infant of diabetic mother. Okay, so these are the most the important complications that we see in a baby who is born to a mother who is having uncontrolled diabetes mellitus. And also microcephaly can also occur in, because all the organs are released except the brain. So uncontrolled gestational diabetes can result in even microcephaly. Okay. Yeah, that's that. Now we have completed our section of newborns. But though I have said I have completed, there are certain areas which I have not covered, but still it is important for your exam. So please go back and read about these areas. I'll tell you them. One is new Ballard scoring, expanded new Ballard scoring. It is very important. Questions can be asked. One thing I'll tell you is that the scoring is between 10 to 50. Okay, the scoring is between 10 to 50, and it is corresponds to 20 to 44 weeks. So that is the new Ballard scoring, and you also have to learn about the Apgar scoring. These two topics, please go back and read new Ballard scoring and Apgar scoring. These the questions have been asked from this area also. So go back to your notes and read this area as well. Then only you can say that you have completed your newborn. And one more thing I have to say is that neonatal sepsis. Not very frequently asked, but can be asked. We can divide it into two: early onset sepsis, late onset sepsis. Early onset sepsis if it is less than 72 hours, late onset sepsis if it occurs after 72 hours, and late onset sepsis, the most common site of infection is meningitis. Whereas early onset is more likely to be pneumonia or systemic sepsis. Okay, so these areas, please go back and read in detail, because sometimes a question can be asked from that area also. Okay, now quickly moving on to the next section, that is inborn errors of metabolism. Okay, so inborn errors of metabolism is very important because for a person who's putting MCQ, it is always a favorite area, because it's actually 1 + 1 = 2. There is no logic or something behind that. If you know the answer, you can write the correct answer. That's it. So please, IEMs are always asked. It's another hot area, very high yielding topic in pediatrics. So we'll look at some of the important inborn errors of metabolism in pediatrics. Okay. So here the question is, match the following. So here, before going into the question, from the options we can say Cory's, McArdle, Pompey's, Von Gerke. So what is the inborn error of metabolism they are talking about? Yes, they are talking about the group of diseases which are referred to as glycogen storage disorders. Okay, so glycogen storage disorders. Here, what are the types of glycogen storage disorders? We can divide them into the table showing the different types of glycogen storage disorders. So glycogen storage disorders, we have different types. So very important, most of the time questions like this, match the following questions will be asked. So what are the important points? Which is type 1? Type 1 is known as Von Gerke disease. Which is the enzyme deficient? glucose 6 phosphatase. Type 2 POMPs. The enzyme deficiency is alpha 1,4 glucosidase or acid maltase. It is a lysosomal disorder. POMPs, this is a lysosomal disorder. And then type 3. Type 3 is known as Cory's disease, and it is due to the D-branching enzyme. So you can remember like CD. Cory's disease is because of the D-branching enzyme. And then you have the type 4. What is the name of the type 4 disease? Type 4 disease is known as Anderson disease. It is because of the branching enzyme. So it is like AB. And then type 5 disease is known as the McArdle's disease. And a McArdle's disease is because of muscle phosphorylase. And type 6 is Her's disease. So this is MM, McArdle's muscle phosphorylase. Her's disease, I remember uses her love letter. So Her's disease is due to liver phosphorylase. And then type 7 is known as Story's disease. And it occurs because of the deficiency of phosphofructokinase. Okay, so please remember this names. So CD, type 3 Cory's D branching, AB Anderson branching enzyme, McArdle's MM muscle phosphorylase, Her love letter. So Her's disease liver phosphorylase and Tory's disease phosphofructokinase. Type 1 and 2 you have to study by heart. There is no other way. Von Gerke's disease glucose phosphatase. Type 2 is Pompe's disease alpha 1,4 glucosidase. Now which one is important among this? Yeah, you have to study in detail about mainly two, Von Gerke's and Pompe. So before that, these glycogen storage disorders can be divided into 3: liver or muscle and mixed. The example for mixed is Cory's. Cory's disease is a mixed disease. Muscle, it is 2, 5 and 7. So you can remember it as 2 plus 5 equal to 7. So type 2, 5 and 7 comes under muscle. The excess glycogen deposition mainly occurs in the muscle, and the person usually presents with muscular diseases like fatigueness, weakness, exercise intolerance, lactic acidosis, etc. And all the others are liver. So after this, whatever is left behind, all that comes under the heading of liver. The excess deposit of this glycogen occurs in the liver, and they usually present features of chronic liver disease, hypoglycemia, etc. Okay. So that is one thing. Now we come to the Von Gerke's disease. So this is an image of a child who's having Von Gerke's disease. What do you have to say about the facies? Yeah, it is known as doll-like facies. They look very cute, like a doll. It's called doll-like facies. And what are the other features that you can see? There will be increase in the size of the liver. There will be hepatomegaly. Along with that, these deposits can also be seen in the kidney. So there will be renomegaly. There will be hypoglycemia because the glycogen is not getting used up. So what happens is that the patient is having high risk of developing hypoglycemia, and they will also have hyperuricemia, hypertriglyceridemia, and there will be lactic acidosis. So these are the features of Von Gerke's disease. And how will you diagnose? The diagnosis is mainly done by liver biopsy, where you can see PAS positive, diastase positive deposits of glycogen deposits. And how will you treat? Treatment is basically by preventing hypoglycemia. So you can give treatments like cornstarch, which have delayed release of glucose. So it helps in maintaining euglycemia for a longer period of time. So cornstarch can be used as a method to prevent the episodes of hypoglycemia. So that is about von Gerke's disease. Now the second disease which you have to know in detail about is Pompey's. Very important. Pompey's disease, it's a lysosomal storage disorder. The importance of Pompey's disease is that here it's not just the liver, but the heart is also involved. So they present with all the features of a chronic liver disease. Along with that, they will be having features of CCF, congestive cardiac failure, and they can also have hypotonia. Oh, sorry, so this basically, Pompey's disease mainly affects the muscle and the heart. So there will not be features of liver disease. They will be usually presenting with hypotonia along with features of congestive cardiac failure. They'll be having cardiomegaly, that is large heart. Liver may be enlarged secondary to the cardiac failure, etc. So if you have a child who is presenting with floppy infant with cardiac failure, you have to think in line of Pompey's disease. What do you see in ECG? ECG, you can see very tall QRS complexes along with short PR. And treatment is we have enzyme replacement therapy for Pompey's disease. So enzyme replacement therapy is the treatment modality for Pompey's disease. So that is about glycogen storage disorders, important points. Now let's try answering this question. So let's match the following. So Cory's disease. So Cory's disease is because of the deficiency of what? Debranching enzyme. So the debranching is not happening. So branched structures will be accumulating. So branched structure can be seen in the liver biopsy. McArdle disease. So M is for muscle phosphorylase, and this is mainly affecting the muscle. So when muscle is affected, the patient will have exercise intolerance. So B3. And Pompey's disease, what? It is basically a lysosomal storage disorder. So the accumulation of glycogen is seen in the lysosomes. And von Gerke's, there is hypoglycemia with lactic acidosis. So the correct option will be A1, B3, C2 and D4. That is option number B. So that is how you derived at the diagnosis. So glycogen storage disorders are very important. And then the another two headings that you have to do here is also important. That is galactosemia and hereditary fructose intolerance. Galactosemia is because of the UDP galactosyl transferase enzyme deficiency. It is usually present with hypoglycemia, cataract. What is the type of cataract known? It is known as oil drop cataract. And this is a condition where breastfeeding is contraindicated. And all components which contain lactose, all milk and dairy products and everything should be avoided in a child with galactosemia. And second one is hereditary fructose intolerance, HFI. It occurs because of the deficiency of the enzyme aldolase B. And in this, the child will be apparently normal when the baby is breastfeeding, but once fructose is incorporated, like the use of fruit juices or something is given to the child will start showing symptoms of failure to thrive, liver disease, etc. So this is the other two types of carbohydrate metabolism disorders. Apart from glycogen storage disorders, you have to know is galactosemia and hereditary fructose intolerance. Okay. So that's about the carbohydrate metabolism. Now moving on to the next. A baby is brought to the OPD complaining of lethargy and poor feeding. On examination, it is noted that the urine smelled of burnt sugar. The defect is this particular type of order of urine is seen in which disease? So here we are dealing with amino acid metabolisms. Last time we dealt about carbohydrate. Now we are dealing about amino acid metabolism. Okay. So here what is the smell of the urine? It is burnt sugar. So in which disease you get burnt sugar order? In maple syrup urine disease. You get burnt sugar or mousy. Sorry, not mousy. Maple syrup order. Maple syrup is something that we use in the Western countries and it smells like burnt sugar. That is MSUD. And because of which enzyme deficiency it occurs? It occurs because of the enzyme branch chain keto acid dehydrogenase. branched chain keto acid dehydrogenase. So burnt sugar is a characteristic feature of MSUD. What are the other orders? What is the order of the urine which you will get in a case of child with phenylketonuria? There you get the mousy order. Which is the enzyme deficient? Phenylalanine hydroxylase. So what are the clinical features of a patient with phenylketonuria? The most important organ that is affected in PKU is brain. So they present with microcephaly, intellectual disability, and as you all know, phenylalanine hydroxylase converts phenylalanine to tryptophan, and this tryptophan is required for melanin synthesis. So here the tryptophan synthesis is not taking place, and hence melanization is not happening. So they will develop hypopigmentation of the skin and hair. So they will be having blonde skin, blonde hair, blue iris. So in any child who is presenting with microcephaly, intellectual disability, blonde hair, blonde skin, blue iris with a musty odor in the urine, you have to think about phenylketonuria. And maternal phenylketonuria, as we have already studied, is one of the cause for microcephaly in the baby. Okay, then what are the other orders of urine? You can get that you have already measured in the table. Glutaric aciduria, sweaty fit order. Hawkins urea, you get swimming pool order of the urine. Isovaleric acidemia, sweaty urine. Maple serum, you already mentioned maple serum. Multiple carboxylase deficiency causes something known as tomcat urine. So a little bit about multiple carboxylase deficiency. It is characterized by alopecia, seizures, and feeding difficulty. So the treatment is usually biotin. So if the patient is having a history of, in the question there is alopecia and there is a peculiar smell of the urine, then you have to think in line of multiple carboxylase deficiency or tomcat urine. Phenylketonuria, we already mentioned about the mousy or the musty order, and tyrosinemia, that is the other important. You get boiled cabbage. So what is tyrosinemia? Tyrosinemia is a disease which occurs because of there are three types are there, but the most common is fumarate acetoacetate transferase. Acetoacetate transferase enzyme. And what is the peculiar order of the urine? That is boiled cabbage is the smell of the urine. And which is the treatment that we use? Nitisinone. This can be asked as an MCQ. So tyrosinemia is another one which can be asked as a smell of the urine will be boiled cabbage. Drug of choice is nitisinone. And then we have another disease which is also important, multiple times that has been asked, is alkaptonuria. What is alkaptonuria? Alkaptonuria, it occurs because of the deficiency of homogenic acid oxidase. So what happens? There is excessive accumulation of homogenic acid. It is characterized by onchronosis, where there will be arthritis, erosive onchronosis, there will be joints will be involved, there will be excessive pigmentation of the skin because of this, and also the urine will turn black on standing. This is known as alkaptonuria, which occurs because of the deficiency of homogenic acid oxidase. So that is alkaptonuria. So you may get a question like a patient is having a joint symptom and skin hyperpigmentation with urine turning black on standing. The diagnosis is alkaptonuria and the deficiency of the enzyme is homogenic acid oxidase. Okay, so that is that. So these are the most important inborn errors of metabolism. And then we have another one also which can be asked, that is homocystinuria. Homocystinuria is important because it is a mimicker of Marfan syndrome. The phenotypical manifestations of homocystinuria is very similar to Marfan syndrome. The enzyme that is deficient is cystathione beta synthase. Cystathione beta synthase. And it is characterized by tall stature, extensive hypermobility of the joint. Everything is similar to Marfan syndrome, but the difference is in homocystinuria and Marfan's you get lens dislocation. But the site of lens dislocation is different. In homocystinuria, the dislocation is inferomedial, that is down. Whereas in Marfan syndrome, it is superotemporal. So the site of this thing, lens dislocation is different between homocystinuria and Marfan syndrome. That is important. Okay. So these are some of the important inborn errors of metabolism with respect to amino acid metabolism. So you have to study the peculiar smell of urine. The smell of urine and what is the disease. That has been asked in previous examination, very frequently asked. In the now years, it is not that frequently asked, but you can always get a question from this area. Okay. And phenylketonuria, very important. Yeah, here there is another question. A 4-year-old boy, just revising, blonde hair, blue iris, developmental delay. The baby is having an autosomal recessive condition. All of the following statements are true for this condition except. So, blonde hair, blue iris, developmental delay, what is your diagnosis? The diagnosis is phenylketonuria. So, it is a case of tyrosinemia? No. So, ferric chloride test, yes. Phenylketonuria, the test you do in the urine is ferric chloride test. That will be positive in phenylketonuria. The urine odor will be mousy, that is true. Enzyme deficiency is phenylalanine hydroxylase. So, ferric chloride test is used in phenylketonuria, whereas in MSUD, the test that you do in urine is DNPH. It's a DNPH test. You need not know the full form and all, but the DNPH test is usually positive in MSUD. PKU, it is ferric chloride test. Okay, with this, we'll take a short break. Okay, so the main organ damaged by PKU is, as I've already said, the most important organ affected in phenylketonuria is the brain. That is why the child develops microcephaly and intellectual disability. Okay, that's about the important inborn errors of metabolism. Now, syndromes, and that is another very important, I'm telling very important repeatedly because I've taken the most important areas. So these part, the general pediatrics part is very core pediatrics. You have to know this in and out, and only the most important topics are selected for discussion. Okay, so first about syndromes. Which syndrome we are discussing first? Down syndrome. Sorry. So there is Down syndrome. Okay, so what about Down syndrome? Which of the following is not feature of Down syndrome? Hypotonia, infections, female infertility, early onset Alzheimer's disease. The answer we'll see after we discuss about Down syndrome. So Down syndrome, what do you know about Down syndrome? All of you might be knowing about Down syndrome. It is also known as trisomy 21. It is the most common trisomy. And the trisomy 21, it is mainly because of the meiotic non-disjunction. So meiotic non-disjunction is the most important underlying pathogenesis beyond the underlying this Down syndrome. And 95% of the cases, it is trisomy. 4% of the cases it is because of translocation, and 1% it can occur because of mosaicism. Okay, so that is the mechanism of action. And what are the clinical features of Down syndrome? When we go from head to toe, what happens in the head? In the head, you can see brachycephaly and the AF. So in the the anterior fontanelle will be wide AF, and there will be delayed closure of the anterior fontanelle. So can you mention few causes of delayed AF closure? Yeah, one is Down syndrome, the other one is rickets, and the third one is osteogenesis imperfecta. And also in people who are having congenital hydrocephalus also, they may get a large head and delayed AF closure. So in Down syndrome, you can get brachycephaly, wide AF, and delayed AF closure. And now when coming to the face, in the eyes, what all you can see the epicanthal folds will be seen. Mongoloid slant, that is the upward slant of the iris will be seen, and they are also having something known as a brush field spots. The brush field spots can be seen on the iris. That is about the eyes. Now coming on to the nose, we can see hypoplastic nasal bridge, and there can be a flat nasal bridge will be present. What about the ears? The ears will be low set and dysplastic small ears. What about the mouth? The mouth will be very small. It will be always partially open with a protruded tongue. Now on the hands, what can you see? You can see simian crease. On the neck, you can see abundant neck skin and low posterior hairline can also be seen. Now, in the heart, what is the most common congenital heart disease that is associated with Down syndrome? Yes, AV canal defect. That is mainly an endocardial cushion defect, an AV canal defect, also known as endocardial cushion defect. In how much percentage of Down syndrome can you get this? Yes, in 50% of the children with Down syndrome, you can get this cardiac anomaly. Now, coming to the abdomen, what can we see? The most common surgical or the intra-abdominal pathology associated with Down syndrome is duodenal atresia. Okay, and then the umbilical hernia can be present, and then in the limbs, what can you get? There will be hypotonia, and in between the toes there is a gap between the first and the second toe, and that is known as sandal gap. It can also be associated with renal anomalies also, and in the males it is associated with infertility. Males will always be infertile, whereas females, they can have delayed puberty, but they're not usually infertile. So males are always infertile. Okay, then there is something known as a Hall's criteria. What is Hall's criteria? Hall's criteria are basically some of the, when a baby is born, all these features might not be very evident. So in a newborn, to pick up whether the baby is having features of Down syndrome or not, use Hall's criteria. So there includes 10 points. Poor moro, hypotonia, flat facial profile, upslanting palpebral fissures, dysplastic ears, loose redundant skin on the neck, simian crease, hyperextensible joint, pelvic dysplasia, and hypoplasia of the fifth finger, that is known as clinodactyly. That is also another important feature of Down syndrome. So of this 10, if 4 or more is positive, then you can consider as Hall's criteria positive for Down syndrome. Then what is the most common hematological abnormality associated with Down syndrome? Yes, it can result in something known as transient myeloproliferative disorder. Transient myeloproliferative disorder, and it usually occur during the initial newborn period, and they are also having increased risk of malignancy. What malignancy? AML. Which AML? M7. So that is about Down syndrome. Now, what is the risk factor for Down syndrome? The age of the mother. The age of the mother, if it is less than 35%, is the risk. Oh, Sorry for that delay. Okay, so now we were talking about Down syndrome. The last and one final pointing about Down syndrome, the age of the mother, which makes the child at risk of developing Down syndrome is more than 35 years. That is, if the baby, the risk of developing Down syndrome in a mother who is less than 35 years of age is 1%. But once the age of the child becomes more than 35 years, the risk becomes twice. So elderly gravid is one of the most important risk factor for development of Down syndrome. So these are the important points. Everything that I have mentioned here is an MCQ. So please, Down syndrome, very, very important topic. Now, what does this can be asked as a photo question for you. What is it? Yes, this is a double bubble sign. And it is seen in duodenal atresia. Duodenal atresia is the most common in cause of intestinal obstructive lesion which is seen in children with Down syndrome. Okay. Now, which of the following is not a feature of Turner syndrome? So next syndrome is Turner. So trisomy 21 is Down syndrome. Now we are coming into 45XO. That is Turner syndrome. So for you, did we answer the other question? No, right? So the answer for the other question is, which of the following is not feature of Down syndrome? Hypotonia, yes. They have reduced immunity. They have high chance of recurrent infection. Female infertility, no. Early onset of Alzheimer's disease, yes. That is, Down syndrome patients are at high risk of developing later Alzheimer's disease. But Down syndrome mainly causes infertility in males but not in females. Okay. So that is about Down syndrome. Now moving on to Turner syndrome. Which of the following is not a feature of Turner syndrome? So what is Turner syndrome? Yeah, I have an image here. So Turner syndrome, it occurs because of the trisomy 45XO. One X chromosome is missing. So it is always seen in females, short females. So I've already said that any female who's short stature, with pathological short stature, you have to look for features of Turner syndrome. So what are the features of Turner syndrome? If you go from head to toe, you can see that they may be having short stature. Low hairline will be present. The characteristic facial features may be present. They may be having a shield-shaped chest. Okay, wide space nipples. And shortened fourth metacarpal, small fingernails, and they'll be having cardiovascular defect. What is the cardiovascular defect? The most common cardiovascular defect is bicuspid aortic valve. But it's usually not symptomatic. But the most symptomatic one, if you ask, it is a coarctation of the aorta. And they'll be having rudimentary breast months. In the elbow, you can see the anomaly that is known as increased carrying angle, also known as cubitus valga. Ovaries will be rudimentary or streak-like gonads, and then they'll be having infertile. Most of every female who's having Down syndrome will be infertile, and they cause something known as primary amenorrhea. Okay, primary amenorrhea can occur in. And at birth, what is the feature that you can see? You can see lymphedema. So if a newborn is born with a severe edema over the dorsum of the feet, you always have to think about Down syndrome. Lymphedema on the dorsum of the feet at the time of birth in the newborn period may be suggestive of Turner syndrome. And okay, that's the most important findings in Turner syndrome. Moving on to the next one. The other trisomies, we mentioned about trisomy 21 and we completed Turner syndrome. Next one is trisomy 18 or Edwards syndrome. This is the next common, most common after Down syndrome. The second most common after Down syndrome is this Edwards syndrome. So the mnemonic is rock mind. It is characterized by rocker bottom feet, overlapping fingers, prominent occiput, cardiac defect. So what is the most common cardiac defect that you see in the case of most common is ventricular septal defect, but it is very common. In how many percentage you can get VSD? In around 90%. In Edwards syndrome, the incidence of heart disease is much higher than in Down syndrome. In Down syndrome, the incidence of heart disease is 40 to 50%, whereas in the case of Edwards syndrome, the incidence is around 90%. And they can have renal anomalies like horseshoe kidneys, and then they can have microcephaly and intellectual disability. And trisomy 18 is associated with hypertonia. All the other trisomies you will get hypotonia, but the trisomy which is associated with hypertonia is Edwards syndrome. So prominent occiput, small jaw, small neck, short sternum, sheet-like chest, clenched fingers, rocker bottom feet. What is rocker bottom feet? There is prominent heels with the loss of the plantar arch. Flat foot with prominent heels is what is known as rocker bottom feet. All these are features of Edwards syndrome. And then while discussing Edwards syndrome, you should always know something about Patau. What is Patau syndrome? It is trisomy 13. The features are similar to that of Edwards syndrome, but cleft lip and palate is associated with Patau syndrome. Dysplastic ears will be seen. Clenched or overriding fingers of the hand, that is present, and they can have undescended testis or cryptorchidism. All these are features of Patau syndrome, that is trisomy 13. So what was our question here? The question here was which of the all of the following are associated with Turner syndrome except cubitus valgus, that is wide and carrying angle, yes. Short fourth metacarpal, yes. Shield-like chest, yes. Cryptorchidism is not a feature of Down syndrome, it is seen in Patau syndrome. Okay. So that is about Turner syndrome. Now last syndrome is Marfan syndrome. So Marfan syndrome, the code is Marfan itself. It is the most common cardiac defect associated with Marfan syndrome is mitral valve prolapse. And the most life-threatening cardiac defect which is associated with Marfan syndrome is aortic aneurysm and dissection. It is the most life-threatening, which can cause death. The most common is mitral valve prolapse. It can also cause retinal detachment, and which is a mutation. It is a fibrillin defect, FBN1 gene, chromosome number 15. So F. And it can cause arachnodactyly, long limbs with hyperextensible joints. And negative nitroprusside test. Why do I mention about nitroprusside test here? Because nitroprusside test is positive in homocystinuria. I've already mentioned homocystinuria, they look alike like Marfan syndrome. But in homocystinuria, the urine nitroprusside test will be positive, whereas in Marfan syndrome, it will be negative. And there will be lens subluxation. So can you recollect where is the lens application happening in Marfan? It is always superotemporal, whereas it is inferior dislocation or subluxation of the lens which occurs in homocystinuria. Okay. Next question. So these are some of the most important syndromes frequently being. There are a lot of syndromes in pediatrics. We cannot cover everything, and if you overload yourself with a lot of clinical features, you may get confused with each other. So you just remember few syndromes and the key points in that syndrome. So for a revision point of view, this will be enough. Now, which of the following syndromes is associated with a congenital heart disease? So what is Lesch-Nyhan syndrome? Lesch-Nyhan syndrome is a syndrome which is associated with self-mutilation, and there is defective in the purine metabolism. So it is not associated with congenital heart disease. Rasmussen syndrome is a syndrome which is associated with multiple seizures which causes status epilepticus. It is not associated with congenital heart disease. Holt-Oram syndrome is a syndrome which is associated with congenital heart disease. And what is the most common heart disease associated with Holt-Oram syndrome? It is ASD and VSD. The mode of inheritance of Holt-Oram syndrome is autosomal dominant, and this is associated with limb defects. Heart disease along with limb defects, then you can think of Holt-Oram disease. Now, what are the, just revising once again, what are the types of heart diseases and what are the incidents? So as I've already mentioned, what is the most common cardiac disease which occur in Down syndrome? What is the incidence? 50%. Most common is AV canal defect or endocardial cushion defect. Turner syndrome, the most common one is bicuspid aortic valve, and the most symptomatic one is coarctation of aorta. Then next one is Edwards syndrome. The incidence is around 90%. Most common one is VSD. Then Dijot syndrome. Dijot syndrome is a syndrome where it is associated with the third and fourth pharyngeal pouches. Third and fourth pharyngeal pouches are not formed, and Dijot syndrome is associated with conotruncal anomalies like truncus arteriosus, DORV, etc. Conotruncal anomalies. Okay, and then you have another syndrome known as Noonan syndrome. Noonan syndrome is also known as male Turner. Okay, because the phenotypically it is looked like a Turner syndrome, but it is not Turner syndrome. Here it occurs in males as well as females, and the mutation is PTPN11 gene mutation. PTPN11 gene is the mutation, and what is the cardiac defect that is seen in Noonan syndrome? Peripheral pulmonary stenosis, peripheral PS. That is the heart disease which occurs in Noonan syndrome. And then another syndrome that you have to remember is Alagille syndrome. Alagille syndrome, it is a syndrome which is it's chronic liver disease, neonatal cholestasis along with vertebral anomalies plus eye anomalies plus cardiovascular anomalies. And what is the serious anomaly which occurs in Alagille syndrome? It is against peripheral pulmonary stenosis. So these are few syndromes and the associated heart disease. Might be asked as a question for your MCQ. Now that's about the syndromes and associated diseases. Moving on to immunology. Immunology. A child is suffering from recurrent chronic infections encapsulated bacteria, deficiency of which IgG subclass is suspected in this case. So IgG2 is the immunoglobulin subtype which acts against the lipopolysaccharide on the capsule of bacteria. So if there is a deficiency of IgG2, there is increased incidence of infection with encapsulated bacteria. So the answer is IgG2. So moving on to primary immunodeficiencies, what are the types of primary immunodeficiencies? We have antibody defects, cellular or combined defects, phagocytic defects, and complement defects. And usually the most common one you encounter is the antibody defects. There is X-linked agammaglobulinemia. About X-linked agammaglobulinemia, here what happens is that there is no B cells. Since there are no B cells, there are no immunoglobulins. So the patient will be asymptomatic. For all these antibody defects, what happens is that the baby will be asymptomatic till 6 months of age. The baby will be normal. Why the baby is normal? Because the baby have passively received antibodies from the mother. But after 6 months, the baby starts becoming symptomatic. CVID is a condition where the B cells are present but are not functional. And hence they result in no immunoglobulins are formed. Okay, so these are the two important, so XLA and CVID are the two important ones which count our antibody defects. Cellular defects or combined defect, the most important one is SCID. That is severe combined immunodeficiency, SCID. SCID, it occurs because there is a defect in T cells plus B cells plus or minus NK cells. If all the cell lines, if the mixture of cell lines are involved, then it is called as SCID. Okay, what you can remember is an X-linked SCID which can occur because of the deficiency of the enzyme adenosine deaminase. That can be asked. X-linked SCID is occurring because of the deficiency of the enzyme adenosine deaminase. Then Dijot syndrome. Why there is Dijot syndrome? In Dijot syndrome, what happens in Dijot syndrome? There is thymic hypoplasia because it is a defect in the development of the third and the fourth pharyngeal arches. So thymus is a structure that is derived from the third pharyngeal arch. So thymus is absent, and thymus is a site where the T cells are formed. So the T cells are absent. So when T cells are not present, obviously the patient will have immunodeficiency, Dijot syndrome. And then we have Viscott-Aldrich syndrome also. That is also another type of severe combined immunodeficiency. Now lastly we have phagocytic defects. Under phagocytic defect you have to remember leukocyte adhesion defect and CGD. Leukocyte adhesion defect is characterized by delayed separation of umbilical cord. Okay, and there will be very high TC, which will be predominantly neutrophils. So, delayed fall of umbilical cord with severe leukocytosis, you have to think in line of leukocyte adhesion defect, which usually occurs because of the deficiency of the integrins and CD18. That's a bit high-fi for you if you did not remember, but see, if the child is having a history of delayed umbilical cord separation with high total count, it could be because of LAD, and the defect is CD18 or integrins. So that the integrins and the CD18 are important for the neutrophil migration. So what happens is the neutrophils are not able to migrate to the site of insult or the site of infection. So that is LAD. Now what is CGD? CGD is a condition where there is defective NADPH oxidation. NADPH oxidase. So this oxidative burst, which is a mechanism of the body to kill the bacteria, it is not happening, and hence they have increased infection with catalase positive organism. Can you give some examples of catalase positive organism? Yes, Staph aureus, Burkholderia cepacia, and also fungal infections like aspergillosis can occur at a high rate in children with CGD. Okay. Then complement defects are also. Next we come to the immunodeficiency syndromes. So as I've already said, Dijot syndrome. Once more, Dijot syndrome, which is a mutation, it is 22q11.2. It's a microdeletion syndrome. 22q11.2. It is characterized by congenital heart disease. What congenital heart disease? Conotruncal defects, hypoparathyroidism, peculiar facies, and absent thymus. Thymic hypoplasia. So there is no T cells. Now, Viscott-Aldrich syndrome has been asked previously as a question for you. So Viscott-Aldrich syndrome, it is characterized by the triad of thrombocytopenia, eczema, and immunodeficiency. And it is an X-linked recessive condition, so that only males are affected. So WAS is a condition affecting predominantly males. The triad is thrombocytopenia. And what thrombocytopenia? There will be microplatelets. Very important. Microplatelets. There will be microplatelets along with thrombocytopenia and eczema, and ataxia-telangiectasia is ataxia pistelangiectasia, and Ivermectin and polyendocrine are not important. But what is important for you is Dijot syndrome. So Dijot syndrome, it is because of the defective development of the second and the third and fourth pharyngeal pouches. So there is defective formation of thymus causing immunodeficiency. There is defective formation of the hypoparathyroid gland. So there is hypoparathyroidism with hypocalcemia, and there is defective what is there? Abnormal facies occur. So what is the abnormal facies? They'll have elongated facies, ear anomalies, elongated philtrum, etc. So these are some of the manifestations. You can even look at the pictures of children with Dijot syndrome, because they can be asked as a pictorial question for you. And thymic hypoplasia causing immunodeficiency. And sometimes they may also be associated with cleft palate also. So these are the findings of Dijot syndrome. Viscott-Aldrich syndrome, it is characterized by the triad of thrombocytopenia, whereas there is microplatelets along with eczema, along with immunodeficiency. It's an X-linked recessive condition occurring only in male children. Okay. So a question here, a delayed umbilical cord detachment with leukocytosis seen in which disease? It is seen in leukocyte adhesion syndrome, LAD. So LAD, there is delayed umbilical cord with leukocytosis, which is the defective CD18 and integrins. CGD, defective NADPH oxidase, catalase positive organisms. KID, it occurs mainly because of the defective T cells, B cells with or without NK cells, and X-linked SCID occurs because of the deficiency of adenosine deaminase, for which now we have enzyme replacement therapy. Now moving on to another important area is vaccines. There are no two ways about it. You have to learn about all the vaccines. You'll always, I think, sometimes you have covered these topics in your community medicine as well. So this will be just a revision for you. So vaccine contraindicated in a 3-month-old with recurrent respiratory tract infection. So which are the vaccines which are given, not given in 3-month-old? Usually measles. Measles vaccine is usually given at 9 months. Why? Because the antibodies derived from the mother are sufficient enough to protect the child from measles till 9 months of age, and only after 9 months we give the measles vaccination. So according to National Immunization Schedule, the first dose is given at 9 months and the second dose is given at 16 to 18 months. Okay. So that is about the measles vaccine. But what if there is an outbreak of measles? If there is an outbreak of measles and a child is exposed to measles, and if the baby is between 6 months to 9 months of age, you can give the measles vaccines, but that vaccine is not counted. Okay, so if the baby is 7-month-old, has contact with a measles person, and the baby is given one measles vaccine, but when the baby reaches 9 months, he again has to take the measles vaccine. That vaccine has been given earlier is not taken into account. Okay, so that is just one extra point. So this is the National Immunization Schedule. Just we'll quickly go through it and revise. At birth, we give 0 dose of OPV, BCG and hepatitis B, and 6, 10, 14 weeks. Which are the vaccines given? OPV, rotavirus, fractional IPV, pentavalent and PCV. And at these same vaccines are repeated at 6 weeks, at 14 weeks, the same vaccines are given. At 10 weeks, the two vaccines are omitted. Which are the vaccines are omitted? PCV and IPV is not given in 10 weeks. And then 9 months, we have the first dose of MR vaccine, fractional IPV third dose, PCV booster, and JE vaccine in selected areas. In Kerala, we are mainly giving it at Trivandrum and Alappuzha. And 16 to 24 months, OPV booster, MR2, DPT booster, and JE second dose. 5 to 6 years, we give DPT booster. 10 years, you give TD vaccine. And at 16 years also, that is 10 years, and after that 16 years also TD vaccine. And pregnant women, we give 2 doses of TD, first and second dose 4 weeks apart. So this is the national immunization schedule. Please learn it by heart. Now, ideal interval between 2 live vaccines is 4 weeks. Between 2 live vaccines, the minimum interval that is advised is 4 weeks is the interval. Now, not true about diphtheria vaccine. Can be given as pentavalent vaccine? Yes. For infant, DPT is the vaccine of choice? Yes. First dose is given at 6 weeks? Yes. So everything is true. None of the above will be the answer. If the child is more than 7 years of age, then you give Tdap. Okay. In a child who is allergic to egg, which vaccine is avoided? So if the child is allergic to duck, 2 vaccines are avoided. Which are those vaccines? Influenza vaccine and yellow fever vaccine. These are the 2 vaccines to be avoided if the patient is having an allergy to egg. So influenza vaccine is not given if the patient has history of egg allergy. A 10-year-old came for routine immunization. Which vaccine should be given to the child? So if the patient come to you with at 10 years of age, the right answer is TD vaccine. Okay, at 10 years and 16 years, the vaccine that is given is TD vaccine. Okay. So that is all about vaccination. So please go and read about all the immunization schedules, the various vaccines, how are they given, the route of immunization. Everything is very important, but there is nothing to explain more about it. That is why I'm skipping that session. Please, just before going for the exam, have a quick revision of the vaccines as well. Don't forget. Now, moving on to the next. So with this, actually, we have come to the end of the most important topics pertaining to the general pediatrics we have finished. That is, we have finished growth, we finished development, we finished nutrition, we finished anthropometry, we finished neonatology, and also we have finished important topics in immunology, vaccination, as well as inborn errors of metabolism. These are very core pediatrics topics. You won't be studying any of this anywhere else. It only in pediatrics you'll be studying about these topics. So that we have come to an end. Now what we are going to learn is more of a systemic and infections. And this maybe you'll be studying a little bit about this in medicine and your other subjects as well. So I might not take that much time for explanation from now on as I have taken earlier, because these are not pure pediatrics. It can be a mixture between the two. Okay. Now, moving on to the infections. So infections. Your first question is: a child has a fever and rash spreading from the face and behind the ears to the other body parts. On examination, Koplik spots are present. The likely diagnosis is, the diagnosis is glaring at your face. What is your diagnosis? Yes, the diagnosis is measles. So a little bit about measles. Measles is a what type of virus? It is an RNA virus. And when does the measles spread? 4 days before the appearance of rash to 4 days after. So 4R4, that is how I usually run. 4 days before to 4 days after the appearance of rash. So what is the first symptoms? There will be the 3C. That is, there will be cough, coryza, and conjunctival congestion. These are the initial symptoms: cough, coryza, and conjunctival congestion. And after that, what happens? There will be the appearance of Koplik spot. Koplik spot, this is the image of the Koplik spot. You can see there. White spots can be seen along erythematous margin, usually seen in the buccal mucosa opposite the second lower molars. So this is the Koplik spots. So after the cough, coryza, and conjunctival congestion, the patient develops Koplik spots. And after the Koplik spots, on day 4, Koplik spots usually develop on the second or third day of illness. And on the 4th day, the rash appears. The typical maculopapular rash typically starts appearing from behind the ear, then spread to the face and then into the trunk. And they disappear in the same order. And while disappearing, they leave behind something known as a brani desquamation. Okay. So this is how the measles progresses. And what are the complications of measles that can occur? The complications of measles which commonly seen as most common complication is otitis media. And the most common complication which can lead to death is pneumonia. What is the type of pneumonia? You can get giant cell pneumonia. And the most serious complication or the CNS complication you get in the immediate period is encephalitis. You get acute meningoencephalitis. And what is the late sequelae? The late CNS complication on measles? SSPE, subacute sclerosing panencephalitis. This can occur as a late complication characterized by extensive myoclonus-like seizures, myoclonic seizures. And how do you diagnose in the CSF? They will be positive for IgE measles antibody. Will be positive. So that is about SSPE. Now, how will you treat measles? So measles is basically, the treatment of measles is basically supportive management. What is the vitamin which is being used in the treatment of measles? Vitamin A. Vitamin A, 2 doses. On day 0 and 1 dose is given. It can help in decreasing the severity of the illness and shortening the course of illness. Along with that, you can give supportive measures for oxygen, etc. And if there is secondary bacterial infection, you can give antibiotics, etc. So all the supportive measures, and vaccination we already covered. That is about the measles. And there are a peculiar type of giant cells that you can see in measles. What is called? Warthin Finkelney giant cells. It can be seen on the microscopic examination of the lesions. So this has been asked. This has been asked. SSPE, the diagnosis has been asked previously. Complex spots has been asked. So measles, very important topic. Questions have been asked, and sometimes you might be always asked to give a identification question. So this is the characteristic rash you see in measles, and this is a picture of the complex spots. Now, a little bit about other fever with rashes. So, fever with rash, the diagnosis of fever with rash can be made by seeing when the rash appears with respect to the fever. So, the code name is very sick people must take double tablet. Okay, so very sick people must take double tablet. So what is if on the day 1 the rash is appearing, then it is varicella. What is that peculiar rash? It will be vesicular rashes, pleomorphic rashes, and it usually appears in the centripetal. First appears at the trunk and then spread to the other parts of the body. And S stands for the second day, scarlet. If the rash appears on the second day, scarlet fever. So what is the causative organism of scarlet? Streptococci. What are the other features of scarlet fever? Strawberry tongue, sandpaper rash. You can get strawberry tongue and sandpaper rash in childhood scarlet fever. Now, what if it occurring on the 3rd day? 3rd day rash is usually rubella. And the 4th day, measles. And on the 5th day, it is typhus. 6th day, dengue. And on the 7th day, it is typhoid. So these are the common differential diagnosis for fever with rash. So first day varicella, second day scarlet, third day rubella. Rubella is also known as third day measles, and then 4th day measles, 5th day typhus, 6th day dengue, and on the 7th day it is a typhoid. So these are common differential diagnosis for fever with rash. Okay, moving on. An infant presents with hepatosplenomegaly, thrombocytopenia, and periventricular calcification. What is your diagnosis? So you have a child who is having HSM, thrombocytopenia, and the key word here is periventricular. So what are you dealing with? We are dealing with torch infections, toxoplasma, rubella, cytomegalovirus, and herpes. So we are dealing with C, cytomegalovirus. So which is the most commonest torch infection? CMV. The most commonest among the torch infections is cytomegalovirus, which is the most severe. The most severe one is rubella. So a little bit about CMV, that is cytomegalovirus. So congenital CMV. So congenital CMV is the most common congenital infection, and if the mother is having the primary infection, the risk of transmission is more compared with the mother who is having a reactivation of the disease. And then the CMV can be transmitted, as we already know, transplacentally. When the mother is having the infection, the baby can get the infection, or it can also be we can get by organ transplantation, or we can also get from the healthcare workers as well. And now, most of the cases, 90% of the cases, the baby will be asymptomatic. And if the baby is asymptomatic in the neonatal period, it's very less likely that the baby will get any later sequelae. But sometimes the baby can be symptomatic. And what are the features of congenital CMV infection? Yes, there will be hepatosplenomegaly. There will be thrombocytopenia. And there can be intracranial calcification. And where do you see the calcification? It is always periventricular. In congenital toxoplasmosis also you can get calcification, but in congenital toxoplasmosis always the calcification is diffuse calcification. So if you're getting periventricular calcification, the diagnosis is congenital CMV. And then you can get the peculiar rashes over the body called as the blueberry muffin rash. These are common with most of the torch infections. Then you can get chorioretinitis, which is the most common congenital, most common anomaly or the defect which is seen in people with CMV. It is sensorineural hearing loss. That is the most common sequelae that you see. The most common sequelae of congenital CMV. The most common question can be like the most common congenital infection which can cause hearing loss, sensorineural hearing loss in the baby. Then your answer should be CMV. Okay, now how do you diagnose? You can isolate the CMV by using a PCR method, and this PCR can be done in any sample. It can be done in the blood, it can be done in the urine, it can be done in the saliva, but the most specific is if it is done in the urine. And if the CMV is isolated in the urine in a baby within the first 2 weeks, then you can say it is congenital. If the isolation is after 2 weeks, we cannot say it is congenital. It could be perinatally acquired also, because the CMV is very ubiquitous. It is present all over us. We all might be CMV positive. So if a baby is showing positive urine CMV PCR in the first 2 weeks of life, then only we can consider it as congenital. Otherwise, it is a perinatal. If more after 2 weeks, then you can consider it only as a perinatal infection. And now, what is the treatment? What is the treatment of congenital CMV infection? Yes, the drug of choice is ganciclovir or valganciclovir. That is a drug of choice. So that is about congenital CMV infection. Now, moving on to the next question. So here you can see the diagram. There's a periventricular calcification. See, just along the borders or the walls of the ventricle, you can see calcification. So, if periventricular calcifications are present, the diagnosis is CMV. Now, which of the following statements are true regarding cytomegalovirus? Neonates who are asymptomatic at birth have lesser risk of later sequelae. Yes, that is true. 20 to 40% is symptomatic. No, only 10% of the children will be symptomatic at birth. In developing countries, the transmission rate of CMV infection in the infant is more common after primary maternal infection than reactivation. Yes, it is always following primary infection, the transmission rate is higher when compared to reactivation. Diagnosis is done by urine specimen at 4 weeks of age. No, it should be done in before 2 weeks of age. So the correct option is 1 and 3. That is option number D is the correct answer. Now, if you are learning about congenital CMV infection, then you have to learn about 2 other things. Which are they? CRS, congenital rubella syndrome. It has also been asked previously in your examination. Very, very important. It is the most severe intrauterine infection. So, the risk of congenital rubella syndrome, it increases when the infection is acquired in the first trimester. So, if the infection occurs less than 11 weeks, the risk of the baby getting affected is 90%. If it is between 11 to 12 weeks, the risk is 33%. If it is after 13, that is 13 to 16 weeks, it becomes 22%. And more than 16 weeks, the rare, it is very less likely that the baby gets. So the first trimester and the early second trimester, if the mother gets rubella infection, then there is very high risk of the baby getting the congenital rubella syndrome. So what is congenital rubella syndrome? What is the classical triad? You all might be knowing. What is the code? C, D, C. Cardiac defect, deafness, cataract. What is the most common cardiac defect? Patent ductus arteriosus. And deafness and cataract. These are three classical. What are the other findings you can see? You can see in the retina, you can see salt and pepper retina. That is because of the chorioretinitis. Microcephaly, microphthalmia. All these are features of congenital rubella syndrome. Okay, these are the important points regarding the congenital rubella syndrome. There is no treatment. You cannot treat it. It's a condition which cannot be treated. There are no definitive antiviral agents. But what we can do is that we can give MR vaccination for the people in the reproductive age group. That is the principle behind the MR campaign, so that we can decrease the incidence of congenital rubella syndrome. Okay, now next is toxoplasmosis. Congenital toxoplasmosis. In congenital toxoplasmosis, the important point is the highest risk of transmission is in the third trimester. In the case of rubella, we told that the highest risk of transmission in the first trimester. Whereas in toxoplasmosis, the highest risk is in the third trimester. And the triad is hydrocephalus, intracranial calcification. What is the type of calcification? Diffuse calcification. In CMV, it is periventricular calcification. And finally, chorioretinitis, of which is the most commonest? Chorioretinitis is the most common manifestation. How do you diagnose? The diagnosis by IgM toxo. And how will you treat? Treatment is pyrimethamine. It's a treatable condition. Pyrimethamine plus sulfadiazine. And antenatally, what can you give to the mother? Spiramycin. If spiramycin is given to the mother antenatally, it can decrease the incidence of congenital, the spread to the baby. The incidence to which the baby is affected can be decreased if the mother is treated with spiramycin. So trimester wise, if I am speaking, the highest risk of transmission in the first trimester, second trimester and the third trimester. First trimester, the highest risk of transmission is in the rubella and varicella. Third trimester, toxo, CMV, syphilis. Second trimester, parvovirus. That is risk of transmission to the baby. In which trimester there is highest risk? So first trimester, rubella and varicella. Second trimester, parvo. Third trimester, toxoplasmosis, CMV and congenital syphilis. Okay, that's that. Now, next question. A lady developed chickenpox during pregnancy. The highest risk of transmission to the fetus in which period? Yes, it is in the first trimester. 11 to 14 weeks is the right answer. So, what is congenital varicella syndrome? Congenital varicella syndrome, it occurs when the mother has got varicella infection early in the pregnancy. And it is characterized by what? Cicatricial skin lesions. Very, very important. Cicatricial skin lesions. And where does the cicatricial skin lesions occur? It usually occurs in a dermatomal pattern. Then you have limb defects, CNS defects, microcephaly. That is about congenital varicella syndrome. Now, this is how to manage if the mother gets varicella in the third trimester. This is what happens in the third trimester. So, if the mother gets the infection 5 days before delivery, that is, this is the day of delivery. Okay, so if the baby gets an infection, if the mother gets the rashes before 5 days, before prior to the deliveries, then it means that the infant has protective antibodies and there is no need for giving any IVIG to the baby. And similarly, if it occurs after 48 hours, from the third day after delivery, then also there is no need for IVIG. But if the baby is born 5 days before the delivery to the postnatal day 3, so in this time period, then the baby does not have any protective antibodies and they are high risk of developing neonatal varicella. We are not talking about congenital varicella syndrome. That is a syndrome because the varicella infection occurs during the period of organogenesis. Here the organogenesis is completed, but if the mother gets the infection in the third trimester, the baby can contract neonatal varicella disease, which can be very severe in the newborn period. So in order to prevent that, if the mother gets the rashes 5 days before the delivery is to 2 days after the delivery, there is high risk. So we have to give varicella immunoglobulin within 72 hours of exposure. So a scenario-based question may be asked from this chart. So that's why I just mentioned it here. Now, a 3-week-old child presents with paroxysm of cough followed by apnea. The total leukocyte count is elevated. What is the treatment? So what do you think is the diagnosis here? So there is paroxysm of cough and the age of the child is only 3 weeks and the total leukocyte count is elevated. So these are the key points. So the diagnosis here is pertussis. Pertussis is an infection that is being caused by the bacteria Bordetella pertussis. So pertussis mainly is also known as whooping cough. You all might be knowing the name whooping cough. So this pertussis, but when it occurs in very young infants, the characteristic whoop and the cough will not be present. They might present with symptoms like apnea or a cyanotic smell. But if it's an older child, it usually passes through 3 stages. Initially, there will be a catarrhal stage, which is characterized by cough, coryza, like an upper respiratory infection, followed by there is the paroxysmal stage where the paroxysm of cough appears, and then finally there is a convalescent phase, which is the period of maximum infection. The catarrhal stage is the most infectious stage. But in very young infants, these stages are not well demarcated. They may simply present with apnea and cyanosis. Okay, so that is about pertussis. So how will you diagnose pertussis? Investigations, what you can, especially in the young infants, there will be very high TLC. It will be like 50,000, 60,000. It's also known as absolute lymphocytosis. The TC will be high with absolute lymphocytosis. The whole of the count will be lymphocytes. So increased TLC with absolute lymphocytosis will be present. And we can always isolate the organism from the nasopharyngeal swab or through the cuff plate culture. And what is the medium that we use? We use a Burgott-Landau medium. That is the name of the medium that you'll be studying in your microbiology classes. And so cuff plate cultures can be used, or you can take the swab from the nasopharynx, or also you can use serologically, you can identify the IgM antibodies also can be detected. But basically, this is a clinical diagnosis. So what happens is the child coughs very severely, and because of this intense cough, that can lead to complications. What are the complications? They can get subconjunctival hemorrhages, they can develop epistaxis, they can develop intracranial hemorrhages, they can develop hernias like umbilical hernias, incisional hernias, etc. because of the severity of the cough. And even they can develop pressure injuries to the lung like pneumothorax, pneumomediastinum. All these are the complications that you see in pertussis because of the high intensity of the cough. And so how will you treat? The treatment of pertussis mainly by antibiotics, and the antibiotic of choice is macrolides. And among macrolides, it can be either azithromycin, clarithromycin, or erythromycin. Okay, so macrolides are used for the treatment of pertussis. So the diagnosis here is azithromycin. Now, Next is about parvovirus B19. Parvovirus B19 does not cause. So this is your question. So parvovirus B19 infection. What is it also known as? Erythema infectiosum. So parvovirus B19, the classical feature of parvovirus B19 infection is it has got a peculiar affinity towards the hematopoietic stem cells, especially the erythrocytes. The RBC precursors are affected, and in which stage the normoblast stage. So it has a predilection towards the RBC precursors in the normoblast stage. So what happens is that they are at high risk of developing aplastic anemia. Not ordinary people with parvovirus B19 infection. If a person is already having a chronic hemolytic anemia, like hereditary spherocytosis, sickle cell disease, etc., if that person gets infected with parvovirus B19, they can rapidly go into an aplastic crisis or aplastic anemia. And then antenatal, if the mother gets parvovirus infection, the baby has high risk of developing hydrops fetalis. And it can also cause pure red cell aplasia. So all these are features of parvovirus, but petechial rash with fever is not a feature of parvovirus B19 infection. And parvovirus infection can also cause the characteristic what is known as the slapped cheek appearance. And also it can be associated with arthropathy. Joint pains may also be seen as a feature of this thing, and is also known as a fifth disease, parvovirus B19. So these are the just 5 or 6 points that will be sufficient. That is about parvovirus B19 infection. So incorrect about parvovirus B19 infection. Does it cause lap cheek appearance? Yes. Does it cause aplastic crisis? Yes. Does it cause non-immune hydrops fetalis? Yes. Does it cause erosive arthritis? No, it is not an erosive arthritis. It is an arthritis or arthralgia secondary to the infection. It's not an erosive arthritis. Okay. Next question. A 16-year-old boy had pain in the calf muscles for 2 days. He gives history of sore throat, cough before 5 days, and which lasted for 3 days. There is pain on pressing the calf muscles. The CNS examination reveals no abnormal findings. Reflexes are normal. CPK level are 2000. What is your diagnosis? So this is a previously asked question. So here, while this is not a pure pediatric based question, but this is a multi-system based question. Okay, so you need to have an idea about all these different options so that you can tick it off, or you can arrive at a diagnosis by excluding the other options. So first we look at the options. First is DMD, that is Duchenne muscular dystrophy. Can Duchenne muscular dystrophy be the answer? Why it is not the answer? Because the CNS examination is normal. In DMD, what you can get? In DMD, it is a muscular dystrophy. You will get features of proximal muscle weakness. So that is not here. So it cannot be DMD. Can it be dermatomyositis? In dermatomyositis, it is usually there will be characteristic dermatological features like rashes, the Gottron papules, the heliotype rash will be present. That are also not present. Then can it be GBS? GBS has no relation with CPK. GBS is a condition where there is a ascending paralysis. Ascending paralysis usually occurring secondary to viral infections or following vaccination, etc. So this is not GBS, because in GBS you do not expect a very high CPK levels. So what is left behind? The only option that is left behind is viral myositis. Now what are the features? Now you can again think whether it is viral myositis also. What are the points in favor of viral myositis? First thing is it's a short duration, that is 2 days only. So it is more likely to be a simple acute illness rather than a chronic disease. Second one, he had a viral prodrome of fever, sore throat and cough before this. And there is pain on pressing the calf muscle with a normal CNS examination. And the CPK value is just 2000. It is not very high like in 10,000, 20,000 or not. So all these are positive points in favor of viral myositis rather than DMD or dermatomyositis. A little bit about the options. What is DMD? Duchenne muscular dystrophy. It is a type of most common type of muscular dystrophy. As I've already said, it results in proximal muscle weakness. The mode of inheritance is X-linked recessive, so only males are getting affected. The gene that is involved is dystrophin gene. It is characterized by the child will be normal initial grade, but once the child starts walking, that is after in any boy child who fails to walk by around 3 years of age, the child shows difficulty in walking. And there will be proximal muscle weakness. And what you can see on examination, you can see pseudo hypertrophy of the muscles, most predominantly seen in the calf muscle. Okay. What is the treatment? The treatment option is we can give glucocorticoids. Steroids can be tried, but it's not just a curative, it is just a supportive measure. So here you can see the Gower's sign. Because of the proximal muscle weakness, the child is climbing upon himself. So this is known as the Gower's sign. It is a sign of proximal muscle weakness, and it is characteristically seen in Duchenne muscular dystrophy. Now, this is what is known as valley sign. A valley sign is two mounts behind. So this is a valley. Here what happens is that the posterior axillary fold, the muscles forming the posterior axillary folds are wasted, resulting in the creation of a valley-like sign here. So valley sign is also seen in Duchenne muscular dystrophy. Now, dermatomyositis, as I've already said, it is the rheumatological condition where there is involvement of the skin as well as the joints. So, it will be arthritis along with dermatological manifestations. So, what are the two important dermatological manifestations? Gottron's papules. Yeah, you can see on the knuckles. So, these are the Gottron's papules. Can be asked as a spotter question for you. And around the eyes, you can see the heliotrope rash. Okay, so these are the two important clinical findings that you see in a child with dermatomyositis. Okay. Moving on to the next section, that is hematology. Hematology is very briefly discussed because it's not just a simple pediatrics. It's always a mixture of the others too. So we'll just see the previously asked important hematological questions. I'm not going to explain everything, and every topic will not be discussed here. Just the previous year questions will be discussed here. So the first question is, a child presents hemolytic facies and splenomegaly. What all are the investigations that you do? So how will you work up a child with hemolytic anemia? So first let's see the options. Peripheral smear, yes, we get a lot of information from peripheral smear. That is the presence of sickle cells, the presence of bite cells, whether it's a microcyte or a macrocyte, presence of parasites. A lot of information can be gotten from the peripheral smear. HB, HPLC, yes, because if you want to know the hemoglobinopathies like sickle cell anemia, thalassemia, you have to do a peripheral smear. Bone marrow aspiration is not needed for the workup of a hemolytic anemia. A bone marrow aspiration is required mainly for bone marrow failure syndromes and also for the diagnosis of leukemias, but not for hemolytic anemia. And PT and APTT, it is mainly done for the evaluation of a bleeding disorder, not for a hemolytic patient. So the correct answer will be 1 and 2. The causes of hemolytic anemia, everything you please go and read, okay? All of the following are true regarding hemophilia except. So hemophilia A, it occurs because of the deficiency of factor 8, correct. Hemophilia B occurs because of deficiency of factor 9. It is more common in males, yes. Why? Because it is an X-linked recessive condition and hence it is seen only in males. So the third option is also correct. Mucosal bleeding is seen commonly. No. In hemophilia, it is a disorder associated with the coagulation pathway. In coagulation pathway disorders, you usually see deep bleeds, intracranial bleeds, and bleeding into the joints. Mucosal bleeds are not seen in hemophilia. Whereas in platelet disorders like ITP or platelet function disorders, you can get petechiae, purpura, and mucosal bleeds are seen in platelet disorders, not in disorders associated with coagulation pathway like hemophilia. We'll take a short break and after that we'll return. Okay, next question. Welcome back, everyone. Moving on to the next question. Which is the most common intra-abdominal solid organ tumor in children? So this is a question asked from the topic of medical or the pediatric oncology. So here, what is the answer? The most common intra-abdominal solid organ in children is neuroblastoma. So some important points with regard to this. Which is the most common tumor in children? Yes, it is in acute lymphoblastic leukemia, ALL. That is the most common tumor in children. After that, which is the second most common? The second most common is brain tumors. And of these brain tumors, it can be divided into benign and malignant. The most common benign tumor is pilocytic astrocytoma. And the most common malignant tumor is medulloblastoma. And which is the most common site? The most common site in children is infratentorial. In any child, the most common site of development of brain tumors, if the child is between 2 to 12 years of age, the most common site is infratentorial. Now, the most common extracranial, that outside the brain, solid organ tumor is neuroblastoma. What about neuroblastoma? Neuroblastoma is a tumor which is arising from the autonomic nervous system. Most common site is the abdomen from the adrenals. And in microscopy, you can see something known as Homer right rossets. And some of the important clinical features you can be associate neuroblastoma as panda eyes, opsoclonus myoclonus, a peculiar eyeball movement which can occur in neuroblastoma. And also it can usually, the most common presentation is mass per abdomen. Okay. And they may also sometimes present severe limping pain, bone pain if the bone marrow infiltration is there. They may also present severe skeletal pain might also be present. And then the most common renal tumor in children is Wilms tumor. The most common renal tumor is Wilms tumor. What are the syndromes associated with the Wilms tumor? The syndromes associated with Wilms tumor are, one is VAGR, that is Wilms, aniridia, genitourinary abnormalities, mental retardation, and Danish-Dash syndrome. What is Danish-Dash syndrome? It is characterized by Wilms tumor, nephropathy, and genital abnormalities. Okay, so that is about solid organ tumors. And please go and read about acute ALL, some important topics, the important prognosis. If you have studied it in pathology, that is okay. But pediatrics also the most important factors which determine the prognosis, the different types, everything from ALL may be asked, and the different types also. The most common AML which is associatedly seen in Down syndrome is AML M7 or the megakaryocytic type. Okay. Now, next question. A 7-year-old boy presented with abdominal pain, vomiting, oliguria, and periorbital puffiness. And when did this happen? Following chemotherapy. Investigation revealed hyperuricemia, raised creatinine, and hyperkalemia. So what does you see here? What is the examiner trying to tell you? The child is suffering from what? Yes, the child is suffering from TLS. TLS is also known as tumor lysis syndrome. So what happens is that when the patient is having a tumor, what we do, you start chemotherapy, right? And when the chemotherapy is given, all the tumor cells may undergo rapid lysis. And when there is excessive cell lysis, what happens? There is a massive release of uric acid. Okay, so there will be hyperuricemia. And this increase in the urate crystals. What happens to the urate crystals? These urate crystals will go and accumulate in the kidney and can cause renal injury. And that results in AKI. That is shown by the increased creatinine. Simultaneously, because of the cell lysis and secondary to the AKI, there is increase in the level of potassium. And what happens to the phosphate level? The phosphate levels will be very high. There will be hyperphosphatemia. So everything is high. Uric acid is high, potassium is high, phosphate is high, but only one thing remains low. And which is that? Very good. It is calcium. There will be decrease in the calcium. So, hypocalcemia, hyperkalemia, hyperuricemia, hyperphosphatemia with AKI in a patient who have undergone chemotherapy, and even in some patients who have very high, for example, in child with ALL and all may present with very high counts like 1 lakh, 2 lakh, etc. Even without chemotherapy itself, they can go in for TLS also. So, it is a life-threatening oncological emergency. Tumor lysis syndrome is an oncological emergency. If we have to treat it as an emergency, otherwise the child may go in for complete renal shutdown. So how will you treat it? Most important thing is this accumulated uric acid should be flushed out from the kidney. So you have to give good hydration. And you can give drugs to reduce the uric acid level, that is allopurinol and rasburicase. So first you give hydration, after that you give allopurinol, and final way is giving rasburicase. So here the next best step. So the first step is always hydration. So that is the right answer here. So that is about hematology and a little bit about oncology. Now moving to the next important system, that is the central nervous system. So identify the abnormality seen in the MRI brain of a 12-year-old child presenting with headache. So what do you have this child? It's a 12-year-old child and he's presenting with headache. So if you look at a close-up of the image, you can see that there can see the herniation. The cerebellar tonsils are herniating into the foramen magnum. So what is this deformity called? This deformity is known as Arnold-Chiari malformation. So Arnold-Chiari malformation again can be of two types, type 1 and type 2. So type 1 is what we see here, that is it usually present in an older child presenting with headache, and if you do an MRI you can see the herniation of the cerebellar tonsil, and it is often associated with syringomyelia. Now what about type 2? Type 2 is which presents more early. It usually presents in the early childhood itself. Here what we all are herniating the cerebellum plus the brainstem herniates. And it is always most often associated with hydrocephalus and meningomyelocele. And you have to do a surgical repair for this condition. And because of this herniation, what will happen to the occiput? The occiput will be flat occiput. So if you have a child with a flat occiput, hydrocephalus with a flat occiput, then you have to, along with the meningomyelocele, then the diagnosis is Arnold-Chiari malformation. What about the other option? What is Dandy-Walker malformation? So here you can the Chiari malformation. So Dandy-Walker malformation is another type of malformation. Here what you can see is the cystic expansion of the fourth ventricle. Here you can see the cystic expansion of the fourth ventricle plus midline cerebellar hypoplasia. So this is known as Dandy-Walker malformation. So because the fourth ventricle is expanded, what will happen to the occiput? The occiput will be prominent. So in a child with hydrocephalus and a prominent occiput, what you should think? Dandy walker. If it's a flat occiput, the diagnosis is Arnold-Chiari malformation. And the third one is vein of Galen malformation. So vein of Galen, what is vein of Galen? So vein of Galen is actually a, it's also referred to as the great cerebral vein. It's actually a union of the two internal cerebral veins along with the basal vein of Rosenthal. The two internal cerebral veins join with the basal vein of Rosenthal and it forms a vein of Galen. But aneurysmal dilatation of the vein of Galen results in a deformity known as vein of Galen malformation, VGAM. And this vein of Galen malformation, what will the child present with? The child will present with large head with high output cardiac failure. So your question might be like this: a child presents with large head and the child is noted to have respiratory distress and a gallop rhythm. So these are all features suggestive of a high output cardiac failure. And you look at the transillumination cyst, you can say broadly illumination. And in the even in the brain on auscultation, you can get a cranial bruit. Because it's a vascular malformation, a cranial bruit will be positive. So if that is the clinical scenario that has been given there, then the diagnosis vein of Galen malformation. So this is an MRI finding of vein of Galen. So this is the vein of Galen malformation. Okay. Now these are the other different types of anomalies. So the most severe anomaly is known as cranio Rashichiasis, that is completely open brain and spinal cord. This is anencephaly, that is open brain and lack of the skull vault. Encephalocele is herniation of the meninges and the brain. Meninges along with the brain, it is encephalocele. And then you can see this is spina bifida occulta. What do you mean by occulta? It is a closed asymptomatic neural tube defect. That is, there is a neural tube defect is there, but the skin and this everything is well intact. So it is remained as a hidden, and the child is usually asymptomatic. That is spina bifida occulta. Now this is closed spinal dysraphism, where there is deficiency of it. It is two vertebral arches, and sometimes it may be replaced by a lipoma-like lesion. That is called closed spinal dysraphism. What is a meningocele? It's a protrusion of the meninges filled with the CSF. Meningomyelocele, if it is a spinal cord, along with the meninges is protruding out, it's a meningomyelocele. So these are the different types of neural tube defects that can be seen in children. Now, next question: a child presented with mental retardation and spastic limbs. There is history of perinatal distress. What is your diagnosis? So there is spasticity along with the history of a perinatal illness. So the diagnosis is, yes, you might be confused with the term HIE and cerebral palsy, but now the child is presented to you with the motor weakness and the sequelae to the HIE. So the answer will be cerebral palsy. HIE is the hypoxic ischemic encephalopathy. It refers to mainly the changes which occurs in the immediate newborn period. If it's a older child presenting to you with the motor and the deformity secondary to the HIE, in that case you have to always choose the option of cerebral palsy and not HIE. Okay. So what is cerebral palsy? Cerebral palsy, it occurs, it is basically a static encephalopathy, right? It's a static encephalopathy and it occurs because of a injury into the growing brain. And most of the time, it can be because of an insult during the birth period, any birth trauma, the child didn't cry off soon after birth. But now it is said that only 10% of the cerebral palsy is because of perinatal causes. Rest of them, there are multiple causes are not identified. And initially, we used to think that all the CP were due to perinatal issues. Now it is that only 10% of the cases of CP are associated with perinatal causes. Okay, now what are the types of cerebral palsy? Cerebral palsy can be divided into different types depending on its topography. Topography means which parts of the body is involved. And it can also be divided depending on the physiologically. Topographically, we can have spastic quadriparesis. What is meant by spastic quadriparesis? It will involve all four limbs along with the muscles of swallowing and the neck muscles. And there is predominant pseudobulbar lesion, the difficulty in swallowing, drooling of saliva, all that is present in this spastic quadriparesis. The next one is spastic diplegia, where diplegia means it is involvement of the lower limbs. Just two limbs, usually lower limbs more than the upper limbs. Then you have spastic hemiplegia. Spastic hemiplegia means only one side upper limb and lower limb is involved. And the last one is spastic monoplegia, if only one limb is involved. And finally, we can have chorioethitoid or extrapyramidal CP. So spastic quadriparesis, what can you see in the MRI of a child with spastic quadriparesis? We can see cystic encephalomalacia. Spastic diplegia, what you can see is periventricular leukomalacia, and it is most commonly seen as a sequelae to prematurity. So in premature babies, what is the type of CP they can develop? They develop spastic diplegia. Spastic hemiplegia can occur because of intrauterine stroke or any focal structural malformations of the brain. Okay, and what is the lesion that is in extrapyramidal CT? The lesion is status marmoratus. That is what is seen extrapyramidal CP. Now, physiologically, we can divide it into, depending on what is the tone, we can divide it into spastic CP, dyskinetic CP, which is the type of extrapyramidal CP, or we can give a mixed CP. Okay, so this is important. This part is important. You have to learn this. This can be asked as a question for you. Now, spastic quadriplegia, what is the next question? Spastic quadriplegia seen in a child with cystic encephalomalacia. Periventricular malacia is seen in spastic diplegia. Of this, which is the most common type of cerebral palsy? The most common type of cerebral palsy is spastic diplegia. Okay. Next question. Which of the following is not true about febrile seizures? So we'll look at each of the options. 54% recurrence rate. No, that is not right. 6 months to 5 years of age group. That is the correct age group. Symbol if it is lasting for less than 15 minutes. Sorry for this typing error. And if there is less than one episode in 24 hours. And no need for anti-epileptics. That's all three are correct. But the recurrence rate is not simply 54%. So how do you calculate the recurrence rate in febrile seizures? This is a graph given in that table that has been given in the Nelson. Here we say that there are major risk factors and minor risk factors. Which are the major risk factors? Age of the child less than 1 year. If the duration of the fever is less than 24 hours and the fever occurs at a temperature between 38 to 39, that is at lower temperature range itself, if the patient has developed seizure, then the recurrence rate is more. And if the seizure happened with a fever of less than 24 hours duration, then also the recurrence rate is more. And if the age of the child is less than 1 year, so also the recurrence rate is low. So we can the code is like 1, 24 hours is 1 day, and here the 1 degree, 100, you can remember is 100. That is 111. So you can remember it like that. What are the minor risk factors? If there is family history of febrile seizures, family history of epilepsy, if it's a complex febrile seizure, daycare, if it happens during daycare, male gender, and lower serum sodium at the time of presentations are conditions associated with, considered as a minor risk factor. So what we say is that if there is one risk factor, the recurrence rate is 12%, two risk factors 25 to 50, three or more risk factors 50 to 59, and even if it is more than 10%, 73 to 100%. Okay, so this is how the recurrence risk of cerebral palsy. So this is very important. Now, risk of developing further epilepsy, that is febrile seizure is not an epilepsy disorder, it is a self-limited condition, but does the child have a increased risk of turning out into a epileptic disorder? How does you assess the risk? If a simple febrile seizure, the risk of subsequent epilepsy is just 1%, but if there is a recurrent febrile seizure, the risk is 4. Complex febrile seizure, what is complex febrile seizure? If the seizure is lasting for more than 15 minutes, or if there are more than one episode seizure occurring within the first 24 hours of seizures, or if it's a focal seizures. All these are categories which are qualifying for the criteria of complex febrile seizures. In this case, the risk of recurrence is 6%. And fever of less than 1 hour before febrile seizure, 11. Family history, 18%. Complex febrile seizure, 29. If there is associated neurodevelopmental abnormalities, the risk is 33%. So sometimes you can ask us, they can ask a question like, what is the risk of developing subsequent epilepsy in a child with simple febrile seizure? In simple febrile seizure, the risk of developing subsequent epilepsy is just 1%. Okay, so that is that. Now, drug of choice for infantile spasm. So what is infantile spasm? Infantile spasm is usually seen associated with West syndrome. And what do you see? It is an infantile spasm. It's a sudden inward jerk, where the baby usually can be two types, can be a flexor spasm or an extensor spasm. Most commonly flexor spasm. So what happens is that there is sudden flexion contraction of the muscles of the upper limb and the lower limbs, and there's sustained contraction for a minute, and after that it is being released. So that is known as an infantile spasm. And what is the EEG correlate of infantile spasm known as? Hypsarrhythmia. So this the question can be framed in another way, like if the baby is showing EEG with hypsarrhythmia, which is the drug that you will give? In that case also the answer will be ACTH. So the drug of choice for infantile spasm or hypsarrhythmia is ACTH. But if this infantile spasm is happening in a child secondary to tuberous sclerosis, tuberous sclerosis is a neurocutaneous syndrome which can be associated with infantile spasm. If the infantile spasm is occurring in a child with tuberous sclerosis, then the drug of choice is vigabatrin. Okay. Now, what is ethosuximide? Ethosuximide is a drug of choice for absent seizures. So, the drug of choice for absent seizures is ethosuximide. But the drug of choice for atypical absent seizures is valproate. If this is atypical, then the drug of choice is valproate. Then carbamazepine, what is the drug of choice? It's a drug of choice for Beck's or benign Rolandic epilepsy. It's a drug of choice for Beck's or benign Rolandic epilepsy or benign epilepsy with centrotemporal spikes. That is the full form of Beck's. Then what is the drug of choice for febrile seizures? Usually no antileptic is required because it usually settles on its time. But if the febrile seizure is prolonged, then you can give benzodiazepines. Diazepam, midazolam are usually used. Midas or diazepam. And what do you use for the prophylaxis of febrile seizures? Either you can use diazepam or clobazam, which is usually used for intermittent prophylaxis. That is, during the episodes of fever they can take. If the baby is having continuous episodes of febrile seizures, they may require even continuous prophylaxis. And what do you use for continuous prophylaxis? Valproic acid. It is used for, but nowadays the prophylaxis is not recommended for febrile seizures. Okay, so but if the question asks which is the drug used for continuous prophylaxis, it is valproate, and intermittent prophylaxis, it can be clobazam or diazepam. Okay, moving on. So what is the rate of CSF formation in children? So this is a bit of a twisted question, because we all know that the rate of CSF formation in children is around 20 ml. Okay, so 20 ml per hour. But 20 ml per hour, if you convert it into ml per minute, it comes around 0.3 ml per minute. So if you're not very thorough with the subject, you might inadvertently mark the option D and make yourself wrong. So it is 20 ml CSF production. The rate is 20 ml per hour, which is equal to 0.3 ml per minute. Okay. So the right option is option number A. Now about CSF circulation. So CSF circulation, what is the amount of CSF that is present in adult? The amount of CSF is 150 ml. Whereas in the age of children, the amount of CSF production is 50 ml. It is usually produced from the lateral ventricle by the choroid plexus and from the lateral ventricle through the foramen of Monro. It enters into the third ventricle, and from the third ventricle via the aqueduct of Sylvius, it goes to the fourth ventricle, and from the fourth ventricle through the foramen of Lushka, which is seen laterally, and the foramen of Megendi, which is seen medially, it goes into the basal cisterns. And from the basal cisterns, they go to the subarachnoid space. And from the subarachnoid space, they are being absorbed by the chorionic villi. So that is the CSF circulation. So any block in this can result in hydrocephalus. So hydrocephalus can be of two types. It can be obstructive hydrocephalus, or it can be non-obstructive or communicating hydrocephalus. The most common cause of obstructive hydrocephalus is congenital aqueductal stenosis. That is the most common cause. Non-obstructive hydrocephalus usually occurs secondary to intraventricular hemorrhage or meningitis. Okay, and how do you treat hydrocephalus? By the placement of a VP shunt. Okay, so that is about that. Now, next question. An adolescent schoolgirl complains of dropping objects from the hands and it gets precipitated during morning and during exams. There is no history of loss of consciousness and cousin sister has been diagnosed with epilepsy. EEG was done and was suggestive of epileptic spikes. So what is your diagnosis? So what is your diagnosis here? So the key points here are, one, this is an adolescent girl. Okay, so let's discuss about the key points. First is, it's an adolescent, the age group of onset adolescence. Second one is drop attacks, dropping of objects from hands. And it mainly occurs during the mornings and during exams. So early morning and in stressful situations it occurs more. There is no history of loss of consciousness. And there is a family history of epilepsy. And in the EEG, what you can see, epileptic spikes are present. So everything pointing towards the diagnosis have been given in the question. What is it? It's the JME, juvenile myoclonic epilepsy. This is a very favorite area for INI CET. Many questions have been asked from this area. Can be asked in your NEET as well. So about juvenile myoclonic epilepsy, it is usually seen in girls of 12 to 16 years of age group. Which is the enzyme GABA receptor gene is the gene that is being mutated. And what they present with seizures and sometimes dropping of the hands from the objects. It usually occurs during morning and during stress. It is because of the myoclonus. They develop this drop attacks. And what is the drug of choice? The drug of choice is valproate. They usually have a positive family history. Now, what is Lafora disease? Another possible question. What is Lafora disease? Lafora disease is a progressive myoclonic epilepsy. It's a progressive myoclonic epilepsy is known as Lafora disease. It has got an autosomal recessive inheritance and treatment is again valparin. Plus along with valparin you have to give clonazepam. And diagnosis is by skin biopsy where you can see PAS positive inclusions. They are called as Lafora bodies. So that is Lafora body disease or Lafora's disease is a progressive type of myoclonic epilepsy. Now, tigroid appearance of white matter on MRI is seen in. So what is tigroid appearance? Yeah, this is the tigroid appearance. You can see there is linear hyperintensities. So these are linear you can see this, right? I hope that is clear. Yeah, these are linear hyperintensities. Okay, and that is usually seen with verticular from the ventricular margins, hyperintense periventricular white matter. So this is also known as leopard skin sign. So this is very similar to the leopard skin or the tigroid pattern. Okay, and what are the three diseases in which this pattern is seen? It is seen in Pelizaeus-Merzbacher disease, metachromatic leukodystrophy, and an autosomal recessive spastic ataxia. You remember these two. These two are the important ones. So it can be seen in MLD and Pelizaeus-Merzbacher disease. So among the options, which will you choose? Yes, it is seen in Pelizaeus-Merzbacher disease. So another MRI finding which can be asked, this is a panda sign. It is because of the hyperintensity in the area of the midbrain. In which disease you can see that? It is seen in Neuro-Wilson. In Neuro-Wilson's disease, you can see the panda sign on MRI. Now, which of the following can cause seizures in a neonate? So here the topic of discussion is neonatal seizures. So what are the causes of neonatal seizures are what they are asking now. So neonatal seizures, can hyponatremia cause neonatal seizures? Yes. Can hypernatremia cause neonatal seizures? No. Hypocalcemia? Yes. Hypomagnesemia? Yes. The option is 1, 3, 4 are the correct options. So neonatal seizures, which is the most common cause of neonatal seizures on day 1? The most common seizures on day 1. It is because of hypoxia, HIE. It's the most common cause. In day 2 to 3, which is the most common cause of neonatal seizures? Hypoglycemia. And day 4 to 7, what is the most common? Hypocalcemia. Okay, so that is the causes. What is the most common type of neonatal seizures? Subtle seizures. May present as eye grimacing, eyelid fluttering, etc. That are known as subtle seizures. And which is the seizure associated with the worst prognosis? Myoclonic seizures. These are the seizures associated with the worst prognosis. How will you manage a case of neonatal seizures? When a child presents neonatal seizures, first you start oxygen for the child, and after that what you do is that you check the GRBS. First you look at the GRBS, and if the GRBS is less than 45, then you take it as hypoglycemia and you give a bolus. What is the dose of a bolus? It is 2 ml per kg of 10% dextrose. 2 ml per kg, 10% dextrose is the dosage. And if the hypoglycemia is ruled out, you draw sample for serum calcium and you give IV calcium. What is the dose of IV calcium? It is also 2 ml per kg. First you rule out hypoglycemia, then you rule out hypocalcemia, and since you don't have the time to wait for the results, you can give 2 ml per kg calcium gluconate. And even after that, if the seizure is not controlled, then the drug of choice, the first anti-epileptic that you give in a child with neonatal seizure is phenobarbital. Okay, so that is that. Next question. A 3-year-old boy was diagnosed to have meningitis. The causative agent was found to be Haemophilus influenzae. Which of the following statement is true regarding the treatment of this patient? So the options given is tetracyclines are given due to resistance to ampicillin. No, tetracyclines are not used in the treatment of meningitis. Sulfadoxine trimethoprim is a drug of choice in Haemophilus meningitis. No, it is not the drug of choice. Ampicillin is not given to reduce the chance of development of resistance. No, ampicillin is a drug with poor CNS penetration. That is why it is not given in meningitis. Ceftriaxone is given due to the resistance of penicillin. Yes, that is the right answer. Ceftriaxone is a drug of choice and that is given because they have higher CSF penetration and better coverage of organisms. So, about meningitis, sometimes you might get a question about how to differentiate between the 3 different types of meningitis. So, have a look at this. If the child is diagnosed with meningitis, it can either be bacterial meningitis, tubercular meningitis, or viral meningitis. So, how will you know? Simply, before going into this table, I'll just tell you what are the important points. Okay, so bacterial, TB, viral. So what will happen to the total count? That is the CSF count. Cells, what will be present? There will be number of cells will be high. And what will be the type of cells? Mainly neutrophils. And the cell count will be usually 10 to 10,000. In tubercular meningitis also the cell count is the same, 10 to 10,000, but they are predominantly lymphocyte. In viral, the cell count is not very high. It is around 25 to 100 cells or 25 to 500 cells and they are usually lymphocyte. Okay, so bacterial, very high neutrophils. TB also count as very high, but it is lymphocytes. Viral, the counts are not very high, but they are lymphocytes. So that is done. Now next is what happens to the CSF protein. What happened to the CSF protein in bacterial meningitis? It will be high. What happens in TB? It will be very high. What happens in viral meningitis? The protein will be normal. So normal protein can be seen in viral meningitis. Now, third one is glucose. What will be happening to the glucose? Low. What we call is that we look for hypoglycemia. Hypoglycemia means the CSF glucose will be less than 40% of the blood glucose. So that is known as hypoglycemia. So CSF, you just, for an entrance point of view, just understand that CSF glucose will be low in bacterial meningitis. And what will be happening in TB meningitis, then also the sugar will be very low. And viral meningitis, the sugar may be normal. Okay. Then what are the other tests? These are the most important. These three findings, if you know, for an entrance, you can be able to make the differentiation between whether it's a bacterial, TB or viral. And TB, another important thing you can do is on standing, sometimes there can be a cobweb appearance. Okay, and then PCR methods, viral isolation, all these are specific, but if you just, the examiners, they might give simply a CSF analysis and we'll ask you to comment what is the type of treatment that you're going to start. So you have to identify whether it's a bacterial meningitis, tuberculous meningitis or viral meningitis. And how will you treat? If it's a bacterial meningitis, what is the treatment? According to the new Nelson, the drug of choice for bacterial meningitis is, empirically we have to treat ceftriaxone plus vancomycin. That is the initial treatment that you have to give. Tuberculous meningitis, we give ATT plus steroids along with prednisolone. And the duration of ATT, if it is a tuberculous meningitis, the duration is 1 year. It is not 6 months. And viral meningitis, if it is HSV, we can give acyclovir. For other viral meningitis, we do not have any specific drug, but if it is because of herpes simplex virus, the drug of choice is acyclovir. Now, what are the other complications associated with meningitis? The most important complication that you can see in the initial period of the seizures, raised ICT. They can develop cranial nerve palsies, especially in tuberculous, since they are involved in the basal structure of the brain, cranial nerve palsies can occur. And most common long-term sequelae is sensorineural hearing loss. And what is the measure that you can take to decrease the incidence of sensorineural hearing loss? Administration of injection dexamethasone before the administration of antibiotics. It helps in decreasing the incidence of dexamethasone. And in Haemophilus influenza pneumonia, in meningitis, there is an increase in the risk of subdural effusion also. These are the common complications associated with meningitis. Okay. Next question. So with that, we have come to an end of the important points in the central nervous system. Okay. Now moving to the cardiovascular system. So the cardiovascular system, first question is about which of the cells carries deoxygenated blood back to the placenta in fetal circulation. So this is the question. So this is a question pertaining to the fetal circulation. So this area is very important because multiple times this has been asked. So we'll take 2 to 3 minutes to discuss this question. Okay. So how was the fetal circulation taking place? So you can see in the case of fetus, there is no lungs. The lungs are not functioning. So the only source of getting the oxygenated blood is from the mother through the placenta. So here you have the placenta. Okay, so from the placenta, the red is for oxygenated blood. Okay, the oxygenated blood is carried via what? The umbilical vein. And this umbilical vein then continues as the portal vein. And what happens? A part of it enters into the liver and the other part is connected to the inferior vena cava via the ductus venosus. This is the ductus venosus and connects it to the inferior vena cava. Okay. And this inferior, from the inferior vena cava, it enters into the right side of the heart, the right atrium. So this is the heart. Right atrium, left atrium, right ventricle, left ventricle. So what happens is that once the blood enters into the right atrium, there is something known as a eustachian valve. So what does this eustachian valve do? The blood which is coming through this is the IVC, okay? The blood that is coming through the IVC is directed directly from the right atrium into the left atrium. It does not go into the right ventricle, it goes into the left atrium through the foramen ovale. This is the foramen ovale. And from the left atrium, it goes into the left ventricle, and from the left ventricle, it exits into the aorta. Okay. So the blood from the here is coming here. So what happens to the aorta? From the aorta, this oxygenated blood is being circulated into the rest of the body. Okay. Now what happened to the deoxygenated blood that is coming from the superior vena cava? The superior vena cava carries the deoxygenated blood from from the upper part of the body, and that blood through the right atrium enters into the right ventricle, which enters into the pulmonary trunk. And what happens is that and this blood from here gets mixed with there is a right to left circulation, that is from this blood enters into the aorta, and this aorta will continue to be the umbilical artery, and this umbilical artery will carry the deoxygenated blood back to the placenta. Okay, so I hope it is clear. So from the placenta, umbilical vein carries the oxygenated blood. It is connected to the inferior vena cava through the ductus venosus, and blood from the inferior vena cava enters the right atrium, from which it goes into the left atrium, left ventricle, and the aorta, and simultaneously the deoxygenated blood coming from the upper part of the body enters into the right atrium, right ventricle, and through the pulmonary artery it reaches into the aorta. So here again there is a mixture. The deoxygenated blood is mixing with the oxygenated blood, and it supplies the this mixture of blood is supplying the part of the body, and the mixture of deoxygenated and oxygenated blood is reaching back into the placenta through the umbilical artery. So this is known as the fetal circulation. So what is the question that is being asked? Which of the vessels carries deoxygenated blood back to the fetus? It is the umbilical artery. So usually what we know is that artery carries oxygenated blood and veins carry deoxygenated blood. But in the case of fetal circulation, it's just the opposite. Okay. Then few other important points. When does ductus venosus close? So it has got a functional closure and an anatomical closure. Functional closure occurs soon after birth. Soon after birth, once the umbilical cord is clamped, the functional closure occurs. Anatomical closure occurs usually in 7 days. And this is the PDA, the artery through which the blood from the pulmonary artery is reaching the aorta. This is the ductus arteriosus, and that is called the which remains patent, that becomes PDA. So when does this ductus arteriosus close? The functional closure occurs within 10 to 15 hours of life, and the anatomical closure occurs in 10 to 21 days. Okay, so this also there are the shunting points are mainly ductus venosus, foramen ovale, and ductus arteriosus. So when each of them has this anatomical and functional closure can be asked as an MCQ question. And another question that has been asked previously is, which is the vessel in the body which contains maximum oxygenated blood? The maximum oxygenated blood is seen in the inferior vena cava, because after inferior vena cava there is a mixing between the deoxygenated blood coming from the upper part of the body. So maximum oxygenation is seen in the inferior vena cava. And a question can be framed like this also: which is the vessel carrying oxygenated blood from the placenta to the fetus? Then the answer is umbilical vein. So this fetal circulation is very important. Okay, I hope that is clear. Now, right aortic arch is most commonly associated with, so normally the aortic arch is seen on the left side, but there in some of the patients there can be a right-sided aortic arch, and it can be most commonly associated with truncus arteriosus, followed by TOF. The most common association is truncus arteriosus followed by TOF. In Dyejohn syndrome also sometimes you can get right-sided aortic arch. Okay. Now, these are some of the X-ray in cardiovascular system. This can be asked some of the important cyanotic congenital heart diseases and the X-ray findings. So this is a picture of TGA. So what you can see, the X-ray is called egg on side appearance. Then TOF, boot-shaped heart. Why there is a boot shape? This has been asked before. The boot shape here, this part is enlarged, and what is this? This is the hypertrophied right ventricle. The hypertrophied right ventricle is responsible for the boot shape, and here, since there is pulmonary stenosis, what happens is that this is usually the area where you see the pulmonary trunk. So it is because of the empty pulmonary bay. Because of the pulmonary atresia, there will be an empty pulmonary bay which results in the concavity over this side. So this concavity along with the prominence because of the right ventricular hypertrophy, there comes the boot-shaped heart. Now, this is a box-shaped heart. In which condition you see box-shaped heart? Yes, it is seen in Epstein anomaly. It's a very large heart, also known as atrialization of right ventricle. Now, snowman heart. In which condition you can see snowman heart? It is seen in supracardiac TAPVC. The cause of snowman heart is supracardiac TAPVC. Now, the inverted 3 sign or the E sign occurs in coarctation of aorta because this is the stenotic segment, this is the proximal segment, this is the area of stenosis, and this is the post-stenotic dilatation. And because of that, there appears a figure of 3 appearance. Okay. Now, next one. A child presented with decreased pulse in the lower limb and delay as compared to the pulse felt in the upper limb. There was asymmetry between the BP between the two arms. So what can be the underlying condition? So in any child with asymmetry of pulse, especially decreased pulsation in the lower limb with hypertension on the upper limb and BP of a decreased BP on the lower limb, the diagnosis always be coarctation of aorta. So what happens is that this is the aorta. So here is a coarctation. So the subclavian artery has already been origin. So the part which is going downwards is suffering from this coarctation. So because of that, in the upper limb you will get good pulses, but in the lower limb the pulses will be weak. In the upper limb there will be hypertension, but the lower limb the BP will be low. So this is referred to as coarctation of aorta. So the answer for this question is coarctation of aorta. Now, some of the important other MCQ points. Which is the most common congenital heart disease? The most common congenital heart disease is VSD. And which is the most common cyanotic congenital heart disease? The most common cyanotic congenital heart disease is TOF. Which is the CHD which can present with cyanosis on day 1? The answer is transposition of great arteries, TGA. Okay. Now, other questions. What is NADA's criteria? NADA's criteria is a criteria used for seeing whether the patient is having a heart disease or not. So, what is this? So, the assessment of children with heart disease. NADA's criteria is used for assessment of children with heart disease. So, what are the components of NADA's criteria? It includes major criteria and minor criteria. Major criteria is systolic murmur of grade 3 or more, presence of diastolic murmur, cyanosis, and presence of CCF. Minor is systolic murmur less than grade 3, abnormal second heart, abnormal ECG, abnormal X-ray, abnormal BP. So if there is 2 major or 1 major plus 2 major, then the child is at increased risk of, or it is an indicator that the child has got some congenital heart disease. So NADA's criteria. Now, next question. On repair of VSD, the patient will show improvement in which of the following? So VSD is a most common congenital heart disease, and the VSD, what happens is a left to right shunting. So because of this left to right shunting, the child will be having recurrent respiratory tract infection, the child will be having severe cardiac failure, and because of that the child will not be having a good growth. There will be severe FTT will be present. So once the failure to thrive, once the VSD is being repaired, in which you will see the improvement? You will see the improvement in the failure to thrive part. There will be a definitive improvement in the failure to thrive part. So on repair of VSD, the patient will show improvement in FTT. So a little bit about VSD. Which is the most common type of VSD? The most common type of VSD is perimembranous VSD. Okay, there are different types of VSD. The most common type of VSD is perimembranous VSD. And when does the child with VSD become symptomatic? It usually becomes symptomatic at 6 to 10 weeks of age. Till then, the child will be asymptomatic. And VSD is the most common congenital heart disease associated with infective endocarditis. And the child usually presents with features of CCF like dyspnea on exertion, sucrose cycle, head sweating, failure to thrive. If it's an older child, they present with exercise intolerance, etc. And then on auscultation, what we can get? We can get a pan-systolic murmur with a wide variable split of S2. Wide variable split of S2. How will you treat? The treatment is basically closure. What are the indications for closure? If the pulmonary is to systemic pressures, the pulmonary versus systemic pressure, that is QP is to QS, becomes more than 2. That is, if the pulmonary pressures are very high, what happens is that this is a left to right circulation. But if the pulmonary pressures becomes very high, then there will be reversal. That is, Asen mengurization can occur. Once Asen mengurization has taken place, we will not be able to repair the VSD. So before that, we have to get the surgery done. So if the QP is to QS ratio is more than 2, it's an indication for surgery. And we also have a type of VSD known as supracrystal VSD. What is supracrystal VSD? It's a type of VSD if present, it has higher incidence of aortic regurgitation. So supracrystal VSD always should be surgically repaired. Now, what is the contraindication for surgery? Asen mengurization is the only contraindication for surgery for VSD. Okay, so that is about VSD. Now, a 7-year-old child with rheumatic heart disease presents with pallor, fever, and a palpable spleen. The following investigation would be needed to arrive at a diagnosis except. So, in any child with a already existing heart disease, if they present with fever, palpable spleen and pallor, what should you think of? You should always think in lines of infective endocarditis. So which are the investigations you need to make a diagnosis of infective endocarditis? Echo, yes. Blood culture, yes. In urine routine, sometimes you can get cast and crystals and hematuria. But do we need an ECG to make a diagnosis of infective endocarditis? No. So the right answer is ECG. So here I have attached the diagnostic criteria for infective endocarditis. You need not study it by heart, but the name at least you should know. It is the modified Duke's criteria. The modified Duke's criteria is used for the diagnosis of infective endocarditis. Then the second one is the revised Jones criteria. For which condition you are using revised Jones criteria? It is used for the diagnosis of rheumatic fever. And the major manifestation, the code is PEX. Subcutaneous nodules, polyarthritis, erythema marginatum, carditis, and carditis. Those are the code for major manifestations of rheumatic fever. And then you have minor manifestations are clinically. It can be clinical features like fever and polyarthralgia, laboratory elevated ESR, CRP and ECG, prolongation of PR interval. So if you are making a diagnosis of rheumatic fever, ECG is needed. But for making a diagnosis of infective endocarditis, there is no need for getting an ECG done. So supportive evidence of antisense streptococcal infection, you can have an ASO titer or a positive throat culture. So that is about the revised Jones criteria. Now, next question. A child with VSD develops the following findings. There is no history of fever. What is the probable diagnosis? Here you can see that the child is having clubbing. See, there is clubbing along with severe cyanosis. So, which is this condition in a child with VSD developing? Is VSD cyanotic or acyanotic heart disease? It is a acyanotic heart disease. But if the child with VSD develops cyanosis, then the only diagnosis is Asen-Menger syndrome. So, Asen mengurization is a possible diagnosis. Okay, next. A 2-year-old boy presents with episodes of becoming dusky. So, age group is 2 years. The child becomes dusky occasionally and there is cyanosis and clubbing. There is no pallor, no distress. Heart was normal sized with a parasternal heave. A systolic thrill was palpated. First heart sound was normal, but in the second heart sound, only the aortic component was heard. The liver was not enlarged. So what is your diagnosis? So what are the points? What does this right parasternal heave indicate? It indicates right ventricular hypertrophy. And why there is no aortic component? Because there is pulmonary stenosis. So there is a child who is having right ventricular hypertrophy with pulmonary stenosis developing episodes of becoming dusky, and that is known as cyanotic spells. And which is the condition where you get recurrent cyanotic spells? The answer is tetralogy of Fallot. So what is tetralogy of Fallot? It's a cyanotic congenital heart disease, and it mainly includes 4 components. There is right ventricular hypertrophy, right ventricular outflow tract obstruction, that is pulmonary stenosis, VSD, and an overriding aorta. These are the 4 components of tetralogy of Fallot. So what is the complication of this? TET spell or cyanotic spell, and which is the age group? It usually occurs in younger children. Why does it occurs? When the baby cries, or if the baby is having any stressful situation, there will be sudden infundibular spasm and the baby will go in for a cyanotic spell. How will you manage the cyanotic spell? You give oxygen, you give hydration, you give soda bicarbonate, you can give morphine for sedation, and if it is not being controlled, you can even give inotropes like epinephrine and phenylephrine. And for prevention of, if the child is having recurrent cyanotic spell, a drug which can be started for preventing the same is propranolol can also be started. So that is about cyanotic spell. And how do you manage it off? Now definitive surgical repair was done, but in initial times what we used to do is a Ballon tossing shunt, that is BT shunt was the initial surgical procedure. It's a palliative procedure, not a definitive repair. Here what we are doing is that we are connecting a shunt between the pulmonary artery to the subclavian artery, so that some amount of blood enters to the oxygenated blood enters to the systemic circulation, cyanosis can be improved. Okay, next. So we'll move on to the endocrinology session. So before that, we'll take a small break. Thank you. Okay, welcome back. Now, moving on to the next system, endocrinology. So, endocrinology, there are only few topics we have to learn. The first one is a question regarding hypothyroidism. The question goes like this: a neonate was found to have a TSH of more than 100 on day 4 of life. The USG done showed an ectopic thyroid gland. What should be the next investigation? There are certain two ways in which you can approach an MCQ. One, it could be a straightforward answer. Even without looking at the other options, you might be able to get to the answer straight away. But in some cases, what happens is that you have to look at the other options, and you can exclude each one of it so that finally you can come to the right answer. So this is a question like this, because we can look at the options and then we can easily find out the diagnosis. So first option, urinary iodine concentration. Does it require? No. It is urinary iodine concentration is done for iodine deficiency disorder. We already settled. If the urine iodine concentration is less than 100, we diagnose it as iodine deficiency. But it is not the case in a congenital hypothyroidism. Thyroid receptor antibody levels. No, we do not look at thyroid receptor antibody levels if we see an ectopic thyroid gland, because it is an investigation. It's a last line of investigation which you do if in the case of congenital hypothyroidism. T3 and T4 levels, no, because you have already have a very high TSH. So the free T4 will, irrespective of the free T4 value, a TSH of more than 100 warrants treatment. So there is no point in looking at the T3 and T4 levels again. So what is the right answer? The right answer is a thyroid nuclear scan. Okay. So about congenital hypothyroidism, the features of congenital hypothyroidism is very important. So in this picture, you can see the coarse facies. See the coarse facies. We can see the open mouth, protruded tongue. There's abdominal distension and protruded belly with the umbilical hernia. Also, you can see the small limbs, short extremities. See? Stunted growth, short extremities, large AF and posterior fontanelle will be open, wide apart eyes, flat nasal bridge, delayed dentition. So another cause of delayed dentition is hypothyroidism. Short and thick neck, and then the skin will be very dry and scaly skin. Then there can be myxedematous skin will be present, broad hands with short fingers, general pallor and sallow complexion, coarse, brittle and scant hair, delayed development and delayed sexual maturation. Now, these are all the clinical features of a child with congenital hypothyroidism. Okay. Now, this is how the ISPED, that is the International Society for Pediatric Endocrine Diseases, put forward. This is a particular algorithm we have to follow while working up a case with congenital hypothyroidism. You need not by heart this entire thing, but few points you have to keep in mind. So, when do you check the thyroid? The TSH level can be tested either in the cord blood, or it can be tested after 24 to 48 hours. And which is the value that is taken as the cutoff? 20. If the THS is more than 20 in the newborn period, it is considered to be as high. What if, and now if it is just more than 20 and the free T4 levels are normal, we can wait. But if the TSH level is more than 20 and the free T4 are normal, you can repeat it after 2 weeks and see. But what if the TSH level is more than 80? It means that the child is having very high likelihood of having congenital hypothyroidism. So we'll directly start the treatment after taking confirmatory sample. So what if it is 42, that is if it is more than 40 but less than 80, then what you do is that we repeat the blood at 72 hours of age. If it is less than 20, it is taken as normal. Okay. So the cutoff that is taken at birth is 20. And what is the value above which the definitive treatment is started without waiting? The value is 80. And if it is between 40 to 80, what you can do is that you can take you can repeat a value after 72 hours. And after that, if it is high, you can start the child on L-thyroxine or thyroxine replacement therapy. Now, this is a diagram that is being taken from OP-GYN. So, in any child, first you do a thyroid scan. Thyroid scan, there is no uptake. Then you can do an ultrasound. And the ultrasound, there is no thyroid gland. It means that there is thyroid agenesis. If the ultrasound, you are able to see a thyroid gland, but there is no uptake. Uptake means there could be some antibodies binding to the TSH receptors. And if the antibodies are positive, it could be maternal antibodies against the TSH receptor. If antibodies are negative, it could be any defect in the sodium iodide transporter, TSH receptor, or the thyroglobulin. If ectopic uptake, it means ectopic thyroid. If there is increased uptake, then it could be because because of dyshormonogenesis. This is a algorithm for working up of congenital hypothyroidism. Once congenital hypothyroidism is diagnosed, what do you start them on? You start them on thyroxine. What is the dose of thyroxine for congenital hypothyroidism? It is 10 to 15 microgram per kg per day. It is one of the most important preventable cause of mental retardation. So early initiation of therapy means that the child will have a near normal intelligence. Okay, so if you wait, the longer you wait for starting the thyroxine replacement therapy, the more will be the damage to the brain. So early starting of thyroxine is recommended if there is congenital hypothyroidism. Now moving on to the next question. A 10-year-old child with a weight of 30 kg has a pH of 7.01. So what is this? There is metabolic acidosis. Sodium is 158, hypernatremia. RBS is 550, there is hyperglycemia. Urine sugar is 3+, there is glycosuria. There has been a history of loose stools for 2 days. On examination, there is severe dehydration. As per ISPA, that is Indian Society of Pediatric Association for Management of Diabetes guidelines, what is the management? So, before going into the management, what is your diagnosis? There is high blood sugar with metabolic acidosis. Your diagnosis is DKA. Diabetic ketoacidosis. So what is the definition of DKA? The biochemical criteria for diagnosis of DKA is first is hyperglycemia. The blood sugar should be more than 200. And then there should be metabolic acidosis. The pH should less than 7.3 and bicarbonate less than 18. And the third one is ketonemia. That is the level of blood ketone body should be more than 3 millimole per liter. So RBS more than 200, pH less than 7.3 with bicarb less than 18 and ketonemia. If these three are positive, make a diagnosis of DKA. How can the child present to you? What are the clinical manifestations? They can present dehydration, tachypnea, that is mainly acidotic breathing because of the severe metabolic acidosis. They may present with nausea, vomiting and abdominal pain, confusion and drowsiness because of encephalopathy. Okay, these are the clinical manifestations. Now, how do you grade DKA severity? They can be divided into mild, moderate and severe. Mild, if the pH is less than 7.3 and the bicarb is less than 18. If the pH is less than 7.2 and bicarb less than 10, it is moderate. If the pH is less than 7.1 and bicarb is less than 5, it is severe. So, 7.3, 7.2, 7.1. 18, 10, 5. Okay, that is the cutoff. And how will you manage DKA? So, here what is the grading of DKA that you have to see? What is the bicarbonate in this child? The bicarbonate in this child is 7.01. Sorry, the pH value is 7.01. Bicarb is not given. So, according to this, what will be the severity of the DKA? It comes under the category of severe DKA. The pH is 7.01, so severe DKA. So this is the algorithm that has been provided for the management. So here, if the child is having severe DKA, how will you manage? This is a case of severe DKA. The management is first you give 10 to 20 ml per kg of bolus and after 1 hour you start insulin. So the management. So if you don't have the time to look at this entire flow chart, this is the simple method to remember. If the child with the DKA presents to you, in severe DKA, the first management is IV fluid bolus. How much fluid will you give? You give 10 to 20 ml. Ideally, if it's a severe dehydration, we give around 20 ml per kg. You give 20 ml per kg of, 20 ml per kg fluid bolus, and after that what you give is that you give the replacement fluid. This is the first bolus, and bolus for plus you give maintenance fluid. Maintenance fluid is calculated as 85 ml per kg, that is the deficit replacement, plus 48 hours maintenance fluid. And that you give as a continuous infusion, you start it. And after that 1 hour, after 1 hour of the fluid has gone in, you start insulin. Which insulin you start? You start regular insulin. How do you start insulin? Insulin is always started as insulin infusion. And what is the rate of starting infusion? It's always started 0.1 mg per kg, 0.1 unit per kg per hour. Okay, so this is how you manage DKA. So the basic principle is first you give bolus and after 1 hour only you start insulin. And what is the amount of fluid you give? You give a bolus of 20 ml per kg and the insulin start as 0.1 unit per kg per hour. So you look at we'll search for the correct answer here. So here ABC resuscitation and 10 ml per kg fluid with insulin. No, it's always insulin is given after. So this is not the right answer. ABC is 10 ml per 10 ml per kg and insulin after 1 hour. The after 1 hour part is correct, but it is not 10 ml per kg. Here, initial ABC with 10 ml per kg fluids with. No, it is always after. The insulin started always after 1 hour. The last option is initial ABC 20 ml per kg fluid. That is right. And insulin started after 1 hour. So the correct answer is option number D. So that is about the, so the concept is first you give the fluid bolus 20 ml per kg. After 1 hour you start insulin. Okay, that is about that. Now, here you have a child who was brought with deformities as shown in the picture. What is the vitamin deficiency which is responsible for this? Now, again, we are coming back to a very important area in a pediatric point of view. That is, we have come to the part called vitamin D. This is the most important vitamin that you have to know. A lot of points, a lot of MCQs have been asked from this part. So please pay attention. Vitamin D deficiency. Okay. Okay, so about vitamin D deficiency. What about vitamin D deficiency? Vitamin D, what is the role of vitamin D and how is vitamin D formed? So, vitamin D formation, this is the pathway for formation of vitamin D. Very important topic, please pay attention. So, vitamin D is mainly, we get vitamin D through UVB exposure. So, once UVB exposure, what happens is that, yeah. So, on the skin, upon the action of UVB rays, what happens is that cholecalciferol is formed and this enters into the liver, and at the liver there is a step called 25-hydroxylase, and this 25-hydroxylase enzyme, it converts it into 25-hydroxy cholecalciferol or 25-hydroxy vitamin D3. And after that, it goes into the liver, kidneys, where there is an enzyme known as 1-alpha hydroxylase, which converts it into 1,25-dihydroxy vitamin D3 or calcitriol. Okay, this is how vitamin D is formed. Now, what happens in rickets? So, rickets is a condition characterized by deficiency of vitamin D. Okay. So, whenever there is deficiency of vitamin D, so vitamin D is a hormone or a multivitamin which increases the absorption of calcium and phosphorus in the body. So, whenever there is vitamin D deficiency, it results in decreased calcium levels and decreased phosphate levels. Okay, and whenever there is a decrease in the calcium levels, it is sensed by the parathyroid hormone. And parathyroid hormone, the stimulation for the most important stimuli for parathyroid hormone to increase its production is hypocalcemia. So, parathyroid hormone causes increase in the level of PTH. The PTH level increases. And this tries to maintain the calcium levels to normal. And PTH is a phosphaturic hormone and it further decreases the phosphate level. Okay, now what happens when there is decreased calcium and phosphorus? There is defective mineralization of the bone. So what will you get? You will get demineralization or osteopenia. And also there is defective calcification of the cartilages. And there is defective endochondral ossification. And because of that, what happens? There is swelling. What happens is that there is a swelling of the growth plate occurs. So, There will be swelling of the growth plate and demineralization or osteopenia. So, those are two important components of rickets. So, what are the findings on rickets? In head to foot examination, what all can you see? So, on the head, what are the features? You can delayed AF closure. There will be very wide AF. And the skull, there will be something known as ping pong skull or craniotabes. Okay, and then moving on to the chest. What can you see on the chest? There is something known as rachitic rosary. We have already mentioned about what is rachitic rosary and all. And here you can see a sulcus. And what is that sulcus called? Harrison sulcus. And on the hand, what can you see? There can be wrist widening. The widening of the wrist because of the swelling of the growth plate. If you come to the lower limb, you can see what is the deformity? Cubitus, sorry, not cubitus, coxa vara, that is bowing of the legs. And sometimes there can also be deformity known as windswept deformity. That is, one limb will be like this and the other lower limb will be looking like this. This is the two lower limbs. So this is known as windswept deformity. And we can see on the lower limb there can be double malleoli. Double malleoli. EC fractures. And the abdomen there can be visceroptosis. So these are some of the head to foot findings that you see in a child with rickets. Okay, now what are the radiological features of rickets? Very important. Radiological features of rickets, there is a loss of provisional zone of calcification. That is the earliest sign in rickets. There will be widening of the growth plate. There will be cupping and fraying of the metaphysis. And there will be bowing of the diaphysis. So you can see all these changes here. See, here this is the widening of the growth plate, fraying of the metaphysis, cupping of the, so this is known as the fraying. This is fraying, and what you are seeing here is the cupping. The cupping of the metaphysis, and the diaphysis is undergoing bowing. That is, once the weight, the bones becomes very soft. So when the child bears weight, what happens is that there will be bowing of the diaphysis taking place. So these are the radios. Sometimes this can be asked as a picture question. The X-ray may be put and you'll be asked to identify which is the nutritional deficiency responsible for this. So that is about the X-ray, the radiological features of rickets. And the most features of this are prominent were the growth is the fastest, usually in the knee and the wrist. So usually take X-rays of the knee and the wrist in order to look at the changes of X-ray. And the rachitic rosary is usually shown the anterior ends of the ribs. Okay. Now, what happens to the investigation findings? So these are the clinical features and radiological features. Now let's see what are the investigation findings that you see in rickets. So on blood investigations, what will you do? The initial investigations will always be, you look at the serum calcium, serum phosphorus, serum alkaline phosphatase. So serum calcium will be decreased, serum phosphorus will be decreased, and serum alkaline phosphatase will be very high. And what will happen to the serum vitamin D3 levels? Which vitamin D3 you will be checking? You will be checking 25 hydroxy vitamin D3 levels, and that will also be low. Okay. So we'll look at the next question. What is not seen in nutritional rickets? Normal calcium, yes, calcium can be normal or it can be reduced. Phosphorus will be low. High parathyroid hormone. As you already said, hypocalcemia causes excessive stimulation of the parathyroid gland, and that can result in hyperparathyroidism. And urine calcium creatinine ratio of more than 15. No, there is no hypercalciuria or excessive renal excretion of calcium happening in rickets. So this is the wrong answer. Calcium can be normal or low, phosphate will be low, and PTH will be high. So the correct answer is urine calcium reactant ratio of more than 15. Now, another important change management here is what is refractory rickets. Very important. So what is if you diagnose a child who's coming to you with these deformities and the biochemical parameters are consistent with rickets, you start the child on treatment, right? And after you start the child on treatment, when do you look for the radiological changes? The radiological healing usually happens after 4 weeks. So if even after 4 weeks there is no healing, or the child is failing to respond to your treatment. So if there is a vitamin D deficiency rickets, you give vitamin D. And even after that, if the patient fails to respond, then you call it as refractory rickets. And what is the sign of healing on X-ray? We can see a zone of calcification or line of calcification is considered as a sign of healing. If this calcification or zone of calcification is not seen, even after 4 weeks of treatment, then you classify it as refractory rickets. And this refractory rickets can be of two types. It can either be because of the defect in the vitamin D, that is calcium, or it could be disorders associated with the phosphate metabolism. So vitamin D, there is something known as vitamin D dependent rickets, which can again be divided into two types, type 1 and type 2. Type 1 is because of the mutation of 1-alpha hydroxylase. So 1-alpha hydroxylase enzyme is not working. So the 25-hydroxy vitamin D3 is not getting converted into 125 vitamin D3. So the active form of vitamin D is not formed. So the child will have manifestations of rickets. But how will you treat this? You supplement 125 hydroxy vitamin D3 or calcitriol can be given as the treatment for this. What happens in type 2? It is a resistance of the receptors to 125 hydroxy vitamin D3. 125 hydroxy vitamin D3 is formed, but the body is not responding to it because of the resistance. So this is a very difficult to treat rickets because even if you give 125 hydroxy vitamin D3, the body fails to respond. So very high dose vitamin D and calcium may have to be given in this condition. These are the two types of vitamin D dependent rickets. Now what is phosphate? There is a group of disorders known as hyperphosphatemic rickets. Hyperphosphatemic rickets, the basic pathology is that there is decrease in the serum phosphate levels. And the most common reason for this hyperphosphatemic rickets is an X-linked hyperphosphatemic rickets. It is caused by the mutation of a gene called FEX gene. So what happens is the increased expression of FGFR23. FGF23 is an enzyme which causes increased phosphate excretion in the urine, and it also inhibits and it inhibits 1-alpha hydroxylase. So what happens? There is decreased phosphate and decreased vitamin D3. 1-alpha hydroxylase is inhibited. So what happens? There is no active D3 form and this results in rickets. But here what you have to understand is the calcium levels are normal. There is nothing happening with the calcium levels. Okay. So there is no hyperparathyroidism. So the PTH usually remains normal here. So if you are not able to grasp whatever I said, it might find a bit overwhelming for you. If so, just remember like this. If in simple nutritional rickets, what will happen to the calcium, phosphorus, and PTH? Calcium can be normal or decreased, phosphate will be low, PTH will be very high. And what happens in vitamin D dependent rickets? In vitamin D dependent rickets, what happens is that the calcium will be decreased, the phosphorus can be decreased or normal, and the PTH is usually high. But in hypophosphatemic rickets, what happens? The calcium is normal, the phosphate will be very low, and the PTH will be normal. So if you have a question whether PTH is normal, phosphate is low, and the calcium is near normal, then it is not nutritional. If it is nutritional rickets or if it is something related to vitamin D only, then the PTH should be very high. So the only condition where you get a normal PTH with rickets is hyperphosphatemic rickets. So please take this sentence very seriously. That is, if you get a clinical scenario in an exam where there is clinical features are all fitting into rickets, but the PTH is normal, then the answer will be hyperphosphatemic rickets. And there are also certain clinical features. In hyperphosphatemic rickets, the child will be having dental caries and dental abscesses may be present. And in hyperphosphatemic rickets, they may predominantly involve the lower limbs will be more involved than the upper limbs. So these are the other two clinical clues which can help in making a diagnosis of hyperphosphatemic rickets. Okay, now coming to the next question. A 6-year-old, so this is question is simply based on what we have learned till now. Okay, so please try to answer this question by thinking. So a 6-year-old girl presented with complaints of rachitic changes in the lips since 1.5 years of age. So see, it has been since 1.5 years. And she has received multiple courses of vitamin D. The investigations are given below. So let's look at the investigations. What is calcium? It is normal. What is the phosphate? 1.6 is very low. Normally, the phosphate value will be more than 2.5. So this is very low. Alkaline phosphatase is increased. In all types of rickets, ALP will be high. Thyroid hormones are normal. So this is the most important key point. PTH is normal. And then electrolytes are normal, creatinine is normal, ABG is normal. So what is your diagnosis? Your diagnosis is hyperphosphatemic rickets. Now, what if it is a chronic renal failure? The creatinine will be increased. And if the ABG, there is acidosis, what you will think of? Then you should think in line of renal tubular acidosis. RTA can also act as one of the causes of refractory rickets. So if you have a similar clinical scenario, but there is a metabolic acidosis, you will have to think in line of what? You have to think in line of RTA, that is renal tubular acidosis. Okay. Now there is a simple flow chart. Again, I am trying to draw here. So if you get a question on refractory rickets, you can follow this flow chart. So if any child with refractory rickets, what will you first look at? You first look at the serum phosphate value. There is only one and only one condition where there is high phosphorus. That is CKD. So if in the question there is a high phosphorus, like phosphorus is 7, phosphorus is 8, etc. Any value above 5 is considered to be high. So if the phosphorus is very high, then the diagnosis is CKD. Now, what if the phosphorus is low or normal? Then the next investigation that you do is you do an ABG. And in the ABG, if there is metabolic acidosis, so if in the scenario an ABG is given and the ABG there is metabolic acidosis, the diagnosis is RTA. If the ABG is normal, then what you have to do? The next thing that you have to do is you look at the serum PTH and the serum calcium levels. If the serum PTH is normal and calcium is also, both serum PTH is normal and serum calcium is normal. So if the PTH is normal, the only diagnosis you have with here is, yes, hypophosphatemic rickets. Provided the ABG is normal. Okay, serum PTH is normal and the ABG is also normal, the diagnosis is hypophosphatemic rickets. And if the serum phosphate is very high and serum calcium is low, then your diagnosis is vitamin D dependent rickets. Okay, this is a very simple flow chart. And if you know this flow chart, you will be able to answer any question which is coming from this particular area. And trust me, multiple times this has been asked. So please make sure you get the concept ready so that you not miss an MCQ. Okay. Okay, that's about rickets. Now moving on to the next question. A 10-year-old boy presents with an SMR of 5 and a BP of 150/90 millimeters of mercury with hypertestosteronism. The enzyme deficient is. Okay, so what do you think is the answer? Okay, so you have a 10-year-old boy. When does pubertal changes normally occur in boys? Yeah, it starts, the changes like increase in testicular volume also begins to happen in 10 years of age. But it never, the SMR of stage 5 means most advanced stage of puberty. So SMR of 5 means the child is having increase in the level of sex steroids, which is resulting in a precocious puberty. Okay, and the BP is 150/90. What does it mean? There is hypertension. So the child is having increase in the sex steroids and hypertension. So what is your diagnosis? Okay, so this is a question asked from the area of congenital adrenal hyperplasia. So actually this is a very, what do you say, a very vast topic, but from an entrance point of view, you just need to know a few points. So CAH, it is an autosomal recessive disease. Okay, it's an autosomal recessive disease. And now what happens is that there are mainly two enzymes which are involved. that you have to know, because for a NEET-PG that is enough. There are two enzymes only you need to study: 21 hydroxylase deficiency and 11 beta hydroxylase deficiency. Okay, so 21 hydroxylase is the most common type. So in this flowchart, let's look where is 21 hydroxylase. So where can you see the 21 hydroxylase? Yeah, here is the 21 hydroxylase. So what happens in a patient who is not having this 21 hydroxylase? So what will happen? This 21 hydroxylase is not there. So this part of the pathway is not happening. So there will be decreased aldosterone. And this part of the pathway is also not happening. This part is also not happening because there is a block here. So what happens? There is a decrease in the cortisol. So what happens to all these precursors? All these precursors get shunted towards this pathway. So what happens? There is an increase in the production of androgens, that is the sex steroids. So what happens? The patient will have symptoms of hypoaldosteronism. So aldosterone, if they low, there will be decrease in BP. There will be hyponatremia with hyperkalemia. And there will be metabolic acidosis. So this is known as the salt wasting type of CAH. And what happens if there is no cortisol? The patient will be having hypoglycemia. And what happens because of this increased androgens? They can get increased virilization in females and resulting in ambiguous genitalia. So very easy. Right, the very easy concept. So you've already studied the clinical manifestations of 21 hydroxylase deficiency. So what happens when this pathway is not happening? So which is the hormone which is stimulating this pathway? ACTH. So since androgen and cortisol are not formed, there is a negative feedback mechanism and the ACTH will be produced in excessive amount. They are trying to stimulate the adrenals, but the adrenals are not able to produce the end products because of the enzyme deficiency. So what happens is that there is increase in the ACTH because of the feedback, and this ACTH results in hyperpigmentation. So the child will be having an increased pigmentation, can be seen predominantly over the knuckle hypertension. Sometimes the whole body will be hyperpigmented. So there will be hyperpigmentation will be seen. So these are the manifestations of 21 hydroxylase deficiency. Now, that is it. So what is the investigation that you do? How will you diagnose 21 hydroxylase deficiency? You just look at the precursor that is just seen before this, that is 17-hydroxyprogesterone. Since there is a block here, what will happen to this product? It will be accumulated. There will be an excessive accumulation of 17-hydroxyprogesterone. So the investigation that you do in this child is 17-hydroxyprogesterone levels. It will be very high. Okay, because the substrate is accumulating. So there is excessive 17-hydroxyprogesterone. And what is the treatment? You just replace the deficient enzymes. So you have to give mineralocorticoid supplements. So or we give fludrocortisone, and the child requires corticosteroid supplementation as well. So you give hydrocortisone and fludrocortisone. And for the virilization ambiguous genitalia, sometimes they may require cosmetic or surgical exploration in order to align the sex towards either male or female. Okay, so that is about 21 hydroxylase deficiency. This you please keep it in mind. Most of the time what happens is that the scenario will be given of a child who is presenting with hypotension, hyperpigmentation, hypoglycemia and everything. So what is your diagnosis? But on the other case, if this 11 beta hydroxylase deficiency, let's see what happens in a child with 11 beta hydroxylase deficiency. So where is the enzyme 11 beta hydroxylase? 11 beta hydroxylase enzyme the 11 beta hydroxylase. So where is the 11 beta hydroxylase enzyme? Yes, the 11 beta hydroxylase enzyme is this. So what happens if the 11 beta hydroxylase is not present? The pathway distal to that is not happening. So this is not formed and this is also not formed. So all of these are similar, but what is the small difference here is that here the substrate that is accumulation is deoxycorticosterone and 11-deoxycortisol. Both of this has got increased mineralocorticoid activity and they can cause hypertension. So if you're not able to remember all this, just remember that the CAH which is associated with hypertension is 11 beta hydroxylase deficiency. So if the patient is having clinical features of CAH, but in the question if the hypertension is being mentioned, then the diagnosis will be 11 beta hydroxylase. Simple. Okay, so here the child is having increased virilization or increased, if the female child, there will be virilization. In the case of male child, what happens is that there will be sex hormone production. So there will be early pubertal changes, exaggerated pubertal changes may be seen. So here there is a boy with an early, the SMR is already 5 at 10 years of age with hypertension. And what is your diagnosis? This hypertension is there, so the diagnosis is 11 beta hydroxylase. Second question, a 3-week-old baby presented to you with a BP of 70/40. Potassium is 6. What is your comment? It is high. Sodium is 127. There is hyponatremia. Blood glucose is 70, lower limit of normal. The patient was started on IV fluids. Which is the specific treatment options which you add? So there is ambiguous genitalia, low BP, hyperkalemia, hyponatremia, and hypoglycemia. So the diagnosis is CAH, basically 21-hydroxylase deficiency. So which is the treatment you give? Hydrocortisone. That is the right answer. Okay, so this covers up the endocrinology. Now quickly moving on to the GI system. Here there is a question is like the 12-year-old boy presents with blotting, recurrent loose stools and features of malabsorption. And on HLA studies, HLA DQ2 is positive. What should be the best management? So here you have a child with malabsorption, which is a boy's child, and they are presented with complaints of loose stools and recurrent blotting with DQ2 positive. So which is the disease? Celiac disease. It is characterized by positivity of HLA DQ2 and DQ8. And this is the most common cause of malabsorption. And to which products their malabsorption? It occurs to gluten. So what are the products which contain gluten? Wheat, rye, and barley. So what is the management? Gluten-free diet. And another question that can be asked is, what is the most common extraintestinal manifestation of celiac disease? Malabsorption. What is the most common extraintestinal manifestation? It is iron deficiency anemia. The most common extraintestinal manifestation of celiac disease is iron deficiency anemia. Okay, so that is about that. Moving on to the next question. A 3-month-old baby presents with jaundice and clay-colored stools. Very important. This is the highlight of this question. Clay-colored stools. So the baby is having conjugated hyperbilirubinemia. The liver biopsy shows periductal proliferation and fibrosis. What is your diagnosis? So this is a question from the topic neonatal cholestasis. So what is the definition of neonatal cholestasis? Neonatal cholestasis is defined if the baby is having the conjugated bilirubin more than 20% of the total bilirubin. If the total bilirubin value is more than 5, if the TB is less than 5, a CB, the conjugated bilirubin of more than 1 is considered to be the diagnosis of neonatal cholestasis. So first let's see the options. Crigler-Najjar syndrome. What does it cause? Is it a conjugated or unconjugated hyperbilirubinemia? It is unconjugated hyperbilirubinemia. So that is out. Here we are dealing with a conjugated hyperbilirubinemia. Dubin-Johnson-Rotter syndrome. Both of it causes what? Conjugated hyperbilirubinemia. And the fourth option is biliary. So we have to choose from these 3 options. So what happens in Dubin-Johnson syndrome and what happens in biliary atresia? So here you can see that Dubin-Johnson and Rotter syndrome are both inherited conjugated hyperbilirubinemia syndromes, but here we have seen that the biopsy showing periductal proliferation and fibrosis. That is characteristic of biliary atresia. So the answer for this question is biliary atresia. This is the right option. Okay. Okay, so that is the right option. Now, next one is a child underwent Kasai spontoenterostomy for management of extrahepatic biliary atresia. Which of the following is not associated with this condition? So, we have to know a little bit about biliary atresia in order to answer this question. So, biliary atresia is one of the most common cause of extrahepatic causes of neonatal cholestasis. So what happens here? The biliary atresia most commonly can be associated with other malformations. It is also known as BASM, that is biliary atresia with splenic malformation. That is BASM, biliary atresia with splenic malformation. So what are the common associated malformations in biliary atresia? They may be associated with splenic abnormalities, polysplenia, asplenia, etc. Malrotation. Malrotation. Intra-abdominal anomalies. Okay, so that can be present. So how do you diagnose biliary atresia? The diagnosis of biliary atresia, you can do a HIDA scan, which show a decreased excretion of the dye into the intestine by the hepatocytes. But the gold standard for diagnosis is intraoperative cholangiogram. And which is what is the treatment option? The treatment option is known as Kasai spontoenterostomy. And when it should be done? It should be ideally done within 60 days of life for the maximal good results. And if the Kasai procedure fails, then the patient will have to go for liver transplantation. Okay, so what is the question here? The question is the child undergoes Kasai spontoenterostomy for management of extrahepatic biliary atresia. Which of the following is not associated with this condition? Polysplenia, yes. Malrotation, yes. Aberrant hepatic artery, yes. But renal agenesis is not a feature of extrahepatic biliary atresia. So that is the right answer. Next, a child presents to the clinic with 3 days of vomiting, diarrhea and altered sensorium. So what are the causes of altered sensorium in a child with diarrhea? So altered sensorium in diarrhea. Possible causes are 1. The most important cause is hypoglycemia. Because of the continuous episodes of loose stools and vomiting, the child might not be taking anything. So the child may be suffering from hypoglycemia. Or it could be because of some electrolyte abnormalities. And the most common one is hyponatremia. And third one, the reason for this could be because of the dehydration, there will be increase in the viscosity of the blood, which can predispose to cerebral venous thrombosis. Okay, that also may be the cause for this. So now let's answer this question. A child presented to the clinic with 3 days of vomiting, watery diarrhea and altered sensorium. So what are the possibilities? Severe dehydration? Yes. Severe dehydration, the child's mental status may become very lethargic. Hyponatremia? Yes. Cerebral venous thrombosis? HUS? No. HUS does not cause altered sensorium. What does HUS cause? HUS causes AKI with hemolysis with thrombocytopenia. That is a triad of HUS. In HUS, usually associated with diarrhea. HUS is a condition which can be associated with diarrhea. And what is the triad? AKI, intravascular hemolysis and thrombocytopenia. The main hemolysis, microangiopathic hemolytic anemia. And which is the most common E. coli associated with HUS? That is E. coli O157H7. That is the most common E. coli associated with hemolytic uremic syndrome. So the right option here is option number 1, 2 and 3. That is option B. Now, Which of the following is not a feature of severe dehydration? So in this table, we have given the different types of dehydration. So what happens in mild? The child will be irritable and thirsty, moderate, extremely thirsty. In severe, the child will be drowsy and not able to drink. The AF will be mildly depressed in moderate and very much depressed in severe. Eyes will be normal, sunken, and in moderate and severe it will be sunken. And the next one is skin pinch. Skin pinch goes back very slowly in severe dehydration. And breathing, in severe dehydration and moderate, there will be rapid breathing because of metabolic acidosis. And urine out will be decreased in severe dehydration. Weight loss of more than 10% also indicates severe dehydration. So in this question, which of the following is not a feature? Drowsy child, yes. Skin pinch very slowly, yes. Sunken fontanelle, yes. But thirsty, if the child is thirsty, it qualifies into either mild or moderate dehydration, not severe dehydration. Next, a 1-year-old child weighing 6 kg suffering from acute gastroenteritis along with signs of sunken eyes and skin pinch going back slowly. What will be a management? So here we have a child with severe dehydration. So whenever we have a child with severe dehydration, the plan of management is plan C management. So how will you use plan C management? The plan C management has got 3 limbs. The first management is deficit replacement. Followed by replacement of ongoing losses. And the last one is maintenance fluid. So here they are talking about the deficit replacement part. So how do you do a deficit replacement? The total amount of fluid that you have to give is 100 ml per kg. Which is the fluid that you prefer to give? You give RL. The fluid of choice in a child with dehydration management is ringer lactate. And you can give it as initially first you will give it 30 ml per kg and then you will give 70 ml per kg. So it depends upon the age of the child. If the age of the child is less than 1 year, the first 30 ml per kg is given over 1 hour and the rest over 5 hours. If the age of the child is more than 1 year, the first 30 ml per kg is given over 30 minutes and the rest 70 ml per kg is given over 2.5 hours. Okay, so this is from if you apply this formula, the answer will be RL infusion of 180 ml in first hour, that is 30 ml per kg, followed by 480 ml in the next 5 hours. Okay, this is a 1-year-old child. It is given over a period of 6 hours. Next question, identify the image and choose the best answer. What is the image showing? Yes, you can see a ring around the cornea. That is a Wilson's disease. Case of leisure ring in Wilson's disease. A little bit about Wilson's disease. What is the inheritance? Autosomal recessive inheritance. What is the gene mutated? ATP. Sorry. The gene mutated is ATP7B gene. And what is the defect? There is decreased biliary copper excretion. And because of that, there is excessive copper accumulating in the body. Which are the organs involved? Mainly involves the liver and the CNS. So hence it is also known as hepatolenticular degeneration. And in the eyes, you can see case of leisure rings. So what is this case of leisure rings? There is copper deposition which are seen over the Descemet's membrane. Where you see the deposition? The deposition is seen over the Descemet's membrane. So what are the investigations? There will be decreased serum ceruloplasmin. It will be less than 20. And there will be increased urine copper excretion. And the gold standard of diagnosis is this most specific test is 24-hour urine. But the gold standard is liver biopsy. But this is not always done. If you have the serological markers positive, then also you can make a diagnosis of Wilson. And how do you treat Wilson's disease? The treatment of Wilson's disease is by the drugs are D-penicillamine, trientine, and zinc. So the drugs which are used for the treatment of Wilson's disease. Okay, that is that. Now moving on to the next system, that is a respiratory system. So first question is from the topic of cystic fibrosis. Which of the following exocrine glandular ducts are not obstructed in cystic fibrosis? So in cystic fibrosis, what happens is that the pathophysiology is like this. It's an autosomal recessive condition, and it is one of the most common autosomally recessively inherited condition. Okay, the mutations occurs in the CFTR gene, which is located on chromosome number 7. So what happens is that because of this mutation, water is not getting into the respiratory epithelial surfaces. So what happens is that the secretions becomes very dry and thick. And because of that, what happens, it results in the blockage of ducts. So that is the pathophysiology behind cystic fibrosis. And this happens most importantly in the liver and in the intestine, but the sweat glands, there is no obstruction. So the pancreas can be involved, lungs can be involved, but sweat glands are not involved. So that is the answer here is sweat glands. Now, what is the diagnostic criteria for cystic fibrosis? So the most important test that you do is sweat chloride levels. A sweat chloride level of more than 60, and that should be done 2 times. A sweat chloride level of more than 60, which is repeated twice. If it is positive, then it is considered to be as a positive diagnosis of cystic fibrosis. Or while genetic study, you get 2 cystic fibrosis containing mutation, or abnormal chloride transponasal potential difference can be measured. That can also be used as a diagnostic test for cystic fibrosis. Plus, so this is either one of the two, or and or. So either 1, 2, or 3, and with any one of the following, that is clinical characteristics of cystic fibrosis. There is a family history, the sibling with cystic fibrosis, and a positive newborn screening. If any of these are present, then you call it a diagnosis of cystic fibrosis. So what are the clinical features of cystic fibrosis? The child may present with features of recurrent respiratory tract infections, and at birth there may be a history of meconium ileus with delayed passage of meconium. Genitourinary, they may be having azoospermia and infertility. In the pancreas, they can have pancreatic insufficiency, and it can be exocrine pancreatic insufficiency, also endocrine, and there is increased risk of development of diabetes mellitus. And salty kiss, that is, there will be increase in the content of salt in the secretions of the duct. So what happens is that there is something known as salty kiss. So if in the history they are giving a history like salty kiss, if there is a history of salty kiss, the mother gives history of salty kiss, that also points towards a diagnosis of cystic fibrosis. Okay, so that is about cystic fibrosis. So chloride levels in sweat are calculated in the diagnosis of which disease? So chloride level in the blood of more than 60 is used for the diagnosis of cystic fibrosis. The level which we use is more than 60. More than 60. Okay, that can be asked as a question for you. Now, which of the following option will you choose for the managing a child with status asthmaticus? So, how will you manage a child with status asthmaticus? So, management of asthma, does it require ECG? No. ECG is not required for the, maybe used for monitoring, but not for the management. Salbutamol nebulization, yes, it is one of the most important measures while managing a child with status asthmaticus. Oxygen inhalation, yes, in any child with status asthmaticus, you have to give oxygen. Oral prednisolone, we cannot say it is a wrong answer. But in the options we don't, so either we have to choose 2, 3 and 4, but among the options there is no option like 2, 3 and 4. So the examiner might be meaning that in a severe case of status asthmaticus, IV steroid is better than oral steroid. So hence we can choose the option like 2 and 3. Okay, it's not like oral prednisolone should not be used for the management of status asthmaticus. If the child is very sick, the child may have difficulty in eating or taking a tablet orally. That is why we give the IV prednisolone or IV hydrocortisone. But the efficacy of oral versus IV is same in the management of status asthmaticus. But however, since we have only the option B here, 2 and 3 can be correct. So the option is 2 and 3. So which are the drugs which are used in the management of status asthmaticus? So the first group of drugs that he uses, bronchodilators. So bronchodilators, what he uses, short-acting beta-2 agonist, that is salbutamol, and then you have anticholinergics, that is ipratropium bromide. Then you use steroids, hydrocortisone or oral prednisolone. And with that, if the child is not responding, then you can give subcutaneous adrenaline or terbutalin. And even after that, the child is not responding, you can give MgSO4 infusion. Magnesium sulfate as an infusion can be used in the management of status asthmaticus. And even if after that the child is not responding, you can even give aminophylline infusion. And the last method for management of status asthmaticus is mechanical ventilation. If all these above measures fail, then you can do mechanical ventilation. And always, while doing all these things, the child should be given continuous supplemental oxygen. Oxygen should be given so that we can prevent hypoxia. Now, all of the following are the pulmonary function test findings in a child with asthma except. So here, this is the PFT findings of asthma given in Nelson. So what you can see, the important ones is FEV1 by FE. An increase in FEV1 of more than 12% after salbutamol inhalation. Yes, that is one of the PFT finding. FEV1, FVC less than 80%. I'm sorry for this typing errors. Less than 80%, that is also consistent with asthma. Fall in FEV1 more than 50% exercise, that is also correct. But day-night variation of FEV1, it is not 15, it is 20%. So the wrong option is option number D. So you can just go through this chart as well. So here you can see that the bronchodilator reversibility, it is 12%. On exercise test, it is 15%. And day-night variation, the value given is more than 20%. Okay, so this can be asked as a picture question or a spotter question for you. So this is a normal spirogram. So what will happen to the spirogram? So normal spirogram will look like this. And what will happen in obstructive lung disease? Obstructive lung disease, there is an increased concavity. There will be an increased concavity like this. So if you have a graph like this, then it is an obstructive lung disease. If you have an anteroposteriorly elongated oblong shaped curve like this, it is a restrictive lung disease. Okay. If it's an oblong shaped curve, it is this. If there is a concavity is there, then the diagnosis is an obstructive lung disease. Now you can go through these. This is how this is a global initiative for asthma have put forward various classification systems for classifying it into well-controlled, poorly controlled and uncontrolled asthma and the stepwise management of asthma. Please go through these notes. Not much of questions have been asked from this area, but if you have time, please go and have a look at these tables as well. Okay. Now, moving on to the next question. A child presents with high-grade fever. Child present to you with high-grade fever, inspiratory stridor, and swallowing difficulty with drooling of saliva for 4 to 6 hours. What is the treatment? So what is the diagnosis? Here you have a sick child, a toxic looking child with severe upper respiratory tract obstruction and stridor. So in this case, we have mainly two differential diagnoses in your mind. Either it could be croup or it could be acute epiglottitis. If you have a child who's high-grade fever, very sick looking and severe upper respiratory tract obstruction, the diagnosis will be more in favor of acute epiglottitis. Okay, so the management of acute epiglottitis is administration of antibiotics, IV, ceftriaxone has to be given. And what is the radiological finding that you see? This is called as a thumb sign. And what is the causative organism for acute epiglottitis? It is Haemophilus influenza. But since now we are giving Haemophilus influenza vaccination, the incidence of acute epiglottitis have come down a lot. Now, what is the close differential diagnosis? The close differential diagnosis, croup. Croup is also known as acute laryngotracheobronchitis. It is caused because of para-influenza virus. It's a much more well-looking child presently with a brosy cough or stridor. The child will not have high-grade fever and the level of upper respiratory tract obstruction will not be as severe and toxic looking as like a acute epiglottitis child. So in the X-ray you can find this thing. That is, there's a V-shaped. See, this is the steeple sign. So steeple sign is a feature of croup. Whereas thumb sign is a feature of acute epiglottitis. Now, how is the classification of croup? Croup can be divided mild, moderate and severe depending upon whether the cough is when the cough is persistent, then it is severe croup. If the stridor is severe and even at rest, then it is severe. Marked increased work of breathing, severe. And if there is severe distress and agitation, it is severe. If the patient is only having occasional stridor, the child is active and playful, then it is a mild croup. So how will you manage croup? Croup management of croup can be asked as a question for you. There are basically 3 limbs in the management. One is to give oxygen to the child in a non-threatening way. Second one is nebulization with adrenaline. Nebulization with adrenaline. And last one is dexamethasone. And the dose of dexamethasone is 0.6 mg per kg. It can be given as IV or IM or even oral route. If it's a sick child, you prefer parenteral route. If it's a more stable child, you can even give as an oral route. So that is the management about croup. Now, this is a term newborn baby who presents with complaints of frothing from the mouth, excessive drooling and coughing while feeds. There is a history of polyhydramnios in the antenatal period. Chest X-ray was done, showed the following. So what can you see in this X-ray? You can see the coiled Ryle's tube here. So frothing, in any newborn child is frothing, coughing while feeding, and antenatal history of polyhydramnios. The diagnosis is tracheoesophageal fistula. So this is esophageal atresia with tracheoesophageal fistula. So what are the types? We have mainly 5 types and the most common type is this, type C. That is esophageal atresia. See, this is there is esophageal atresia and the distal part of the esophagus is having a fistula with the trachea. So that is a type C of tracheoesophageal fistula, is the most common type of TEF, and this can be associated with the Vactal anomalies also. What do you mean by Vactal anomalies? That is vertebral defects, anorectal malformations, cardiac malformations, tracheoesophageal fistula and renal anomaly. So vertebral, anorectal, cardiac, tracheoesophageal fistula and renal anomalies. So this can occur. So tracheoesophageal fistula can be seen as a component of Vactal anomalies. And last is L. L stands for limb defects. Okay. Now, a 4-year-old child was brought with the following finding on the X-ray. So what is the foreign body? So here, if you are able to very visibly see the entire diameter of the foreign body on the this thing on the AP view, and if the full thickness of the foreign body can be seen on the lateral view, then it means that the foreign body is in the esophagus. And which is the most common foreign body that you see in the esophagus? It is a coin. The most common foreign body that you see is coin. So here the foreign body is seen in the esophagus. Okay, next. A 2-year-old child presented to the emergency with complaints of respiratory difficulty. On chest X-ray, the right side is showing hyperinflation than the left side. So if any child of this particular choking age group, like 2 to 4 years of age, presents the acute onset of cough and breathing difficulty. And on auscultation, you are getting a differential air entry. And on X-ray, there is hyperinflation on one side. Then you always have to think in line of foreign body. So, what is the correct statement? Decreased air entry in particular part of auscultation suggestive on foreign body. No. If the decreased for air entry, if there is once, it's not always suggestive of foreign body. We cannot take it as a correct statement. Removal by flexible bronchoscopy is a treatment of choice. Yes, that is the right answer. If there is a foreign body into the bronchus, then you have to remove it. Complete obstruction of the bronchus can cause hyperinflation due to ball wall effect. No. Ball wall effect, what do you mean by ball wall effects? For example, this is the bronchus, and there's a partial obstruction of the bronchus by the foreign body, like this. There's a partial obstruction. It's not complete obstruction. What happens is that during inspiration, the air goes in. But during expiration, as the bronchi constricted, the air cannot go out. So what happens? Relative air trapping happens. So if there is a partial obstruction, then there is ball wall effect. In complete obstruction, there is no ball wall effect. Acute tracheobronchitis, no, this is not a case of acute tracheobronchitis. So the right answer is removal by flexible bronchoscopy. Okay. Now we'll take a short break, and after that we'll get back to you. Welcome back. Moving on to the next question. Now we have next system. The next system which we are going to discuss here is the renal system. So nephrology, the question here is a 10-year-old child complaining of generalized edema. And on investigation the serum cholesterol is 238, the urine protein is 3 plus, and the stool microscopy revealed oval fat bodies. So the diagnosis is very clear. There is proteinuria along with hypercholesterolemia and edema. So there is edema, proteinuria, and increased serum cholesterol. The diagnosis is very simple, right in front of your eyes, nephrotic syndrome. So now what is basically what is the pathophysiology behind nephrotic syndrome? It is the change in the increased permeability of the glomerular basement membrane. Why there is increased permeability? It is because of the effacement of the food process, which is a pathology. We can see effacement of the food processes of the podocytes. And so the proteins and leaks, there is increased permeability of plasma proteins. The plasma proteins leaks through the urine. There is proteinuria, and because of proteinuria there is decrease in serum albumin level, and that results in decrease in the colloid oncotic pressure and result in edema. So that is a simple pathophysiology behind nephrotic syndrome. So what is nephrotic range proteinuria? The most important characteristic feature of nephrotic syndrome is heavy proteinuria. So what is heavy proteinuria? If the urine protein creatinine ratio is more than or equal to 2, or if the 24-hour urine protein sample, the urine protein excretion is more than 40 milligram per millimeter square per hour, or on urine dipstick there is 3 plus or 4 plus proteinuria. So if any three of this is positive, then you can say that it is nephrotic range protein. Urine PC ratio more than 2, 24-hour urine sample containing more than 40 milligram per meter square per hour, or on a urine dipstick there is 3 plus or 4 plus. Now, what is the classical triad of findings which you see in nephrotic syndrome? This is the classical triad. According to KDIGO 2020, there is 1, nephrotic range proteinuria, hypoalbuminemia. The cutoff for hypoalbuminemia, according to the KDIGO, the recent guidelines, it is 3. In all your previous books, it will be 2.5, but the recent guidelines, the cutoff is less than 3, not 2.5, and edema. Okay, so these are the diagnostic criteria for nephrotic syndrome, and according to this KDIGO, hypercholesterolemia is not a diagnostic criteria. But in the previous ISBN 2008 and all, hypercholesterolemia of cholesterol more than 200 was one of the diagnostic criteria. Okay. Now, nephrotic syndrome can be divided into primary or idiopathic nephrotic syndrome, and secondary nephrotic syndrome is very rare. Most of it is primary or idiopathic. And among primary, the most common type of nephrotic syndrome is the minimal change disease, and that is the steroid responsive type of steroid responsive nephrotic syndrome. And after minimal change disease, the second most common type is FSGS. So most common is idiopathic. Among idiopathic, the most common is minimal change disease. After minimal change disease, FSGS. Okay. Now, nephrotic syndrome, the definition has already been, hyperlipidemia is now not considered in recent definition. Now, what is steroid sensitive nephrotic syndrome? If this complete remission within 4 weeks of prednisolone. And now, what is a steroid resistant nephrotic syndrome? Lack of revision despite 6 weeks of daily steroid therapy. So even after 6 weeks of steroid therapy, if there is no remission, then we call it a steroid resistant nephrotic syndrome. There are other definitions as well. What is a relapse? What is an infrequent relapse? What is a frequent relapse? This all might not be asked for an MCQ question, but it's always good if you can simply go through these definitions. Okay. Now, what are the indications for genetic study in a child with nephrotic syndrome? If there's a positive family history, if the child is age of onset is atypical, that is age below 1 year, and if there is steroid resistance, all these are indications for genetic study. And indications for renal biopsy, age of onset less than 1 year, gross hematuria more than 2 weeks. If there is persistent microscopic hematuria, usually in nephrotic syndrome you don't expect hematuria, but if there is persistent microscopic hematuria, it is indication for renal biopsy. Sustained severe hypertension. And if there are other systemic features like fever, rash, arthralgia, etc., and AK are not attributable to hypovolemia sepsis, and if you are suspecting secondary causes, these are the indications for renal biopsy. Sometimes you can, all the following are indications for renal biopsy, except a question like that might be asked. So it's good to know the indications for renal biopsy. Now, how do you treat the first episode? You always start with oral prednisolone, 2 mg per kg per day for 6 weeks, followed by 1.5 mg per kg per day on alternate days for another 6 weeks. Okay, so that is that. Moving on to the next question. In a child with recurrent urinary tract infection, the sequence of investigation will be. So, what is recurrent UTI? Recurrent UTI means any second episode of UTI. That is, if the child had one UTI and the second episode of UTI is considered as recurrent. So, more than one episode is considered as recurrent UTI. So, how do you define UTI? UTI, depending on the colony count, the colony count is used to see whether there's a significant bacteriuria or not. So we know that in midstream void sample, the more than 10 to the power of 5 colony count per ml is considered as significant. But if it's a suprapubic aspiration, any number of colonies is considered as significant. And if it is urethral catheterization, 10 raised to the power of 4 is considered as significant bacteriuria. So the important point is, if in suprapubic aspiration, if you get even one colony count, that is also considered as significant bacteriuria. Now, how does this recurrent UTI? So, this is a management approach for UTI. So, here they have asked a question about recurrent UTI. So, what is recurrent UTI? 2 episodes of febrile UTI or any UTI in a child of less than 6 months of age. So, how do you go on with the evaluation? The 3 investigations that you have to do is renal and bladder ultrasound, DMSA renal scan, and MC. Okay, so the 3 investigations you do is USG, AUB, DMSA, and MCU. Okay, so the question here is, in a child with recurrent urinary tract infection, the sequence of investigations would be. So what will be the sequence of investigation? The first investigation you do will always be an ultrasound abdomen. And after the ultrasound abdomen, and once the urinary tract infection has settled, then you will do an MCU, because MCU, what you do is that you inject a dye through the urethra upwards. So only after the acute infection has been settled, you can do an MCU, or otherwise you can cause an antecedent infection. And if MCU is abnormal, then you have to go for a DMSA. So the order of investigation is 1 followed by 2 followed by 3. So the option is A, 1, 2 and 3. So, if the patient has got an uncomplicated first episode of UTI, that can also be asked as a question for you. If recurrent UTI, all 3 has to be done. If it's an uncomplicated first UTI, what is the investigations you do? It depends upon the age of the child. If the age is less than 1 year, all the 3 investigations has to be done. If the age is 1 to 5 years, you first do a renal ultrasound and DMSA, and you do an MCU only if the DMSA is abnormal. So USG is done and DMSA is done, and if the DMSA is abnormal, then only you do MCU. If the age is more than 5 years, the only investigations you do is renal ultrasound. Okay, and only if the ultrasound is abnormal, you will do DMSA and MCU. So less than 1 year, all 3 is done. 1 to 5 years, you do USG and DMSA, MCU only if DMSA is abnormal. More than 5 years, you do only USG, and then proceed with DMSA and MCU only if USG is abnormal. So that can also be asked as a question for you. So that is about recurrent UTI. Now this is just a grading system of vesicourethral reflex, VUR. This can be asked. So VUR is one of the most important risk factors for causing recurrent urinary tract infection. So it can be divided into 5 grades. Grade 1, there is reflex into a non-dilated uterus. Grade 2, there is a reflex into the non-dilated uterus and up to the pelvis and the calyx. Grade 3, there is mild to moderate dilated. So when the dilation starts, it is grade 3. The dilation, where there is dilation, there is dilation in the ureter, pelvis and the calyces. Grade 4, there is moderate tortuosity, and grade 5, there is gross ureteral dilatation and tortuosity. So this grading of VUR can be asked as a question for you. So please go through this classification system. Now, what is the most common cause of urinary tract obstruction in male? The most common cause of urinary tract obstruction in a male child is posterior urethral wall, PUV. PUV is the most important cause. What happens in PUV? Here, there is a valve mechanism here. So because of that, urine is not able to be excreted. And so there will be excessive accumulation of urine in the bladder, causing hypertrophy and thickening of the bladder wall. And this increased pressure is transmitted antegrade into the renal calyces, resulting in hydroureteronephrosis. Okay, so the most common cause of urinary obstruction in male neonate is posterior urethral wall. This can be diagnosed antenatally. Antenatal diagnosis can be done. oligohydramnios may be present antenatally because of there is no urine form. So if the urine is one of the most important sources of amniotic fluid. So because of that, there can be oligohydramnios in the antenatal period, could be a indicator of PUV in the child. Now, a 7-year-old child presents with history of bedwetting, that is nocturnal enuresis, twice a week for about 1 year. So what is the age of the child? 7 years. Even after thorough investigation, no organic cause was found. Which of the following will be the best initial management plan to start with? So first option is bladder training with reward for delaying micturition during playtime. Pharmacological therapy with imipramine, bell and pad based classical monitoring, psychodynamic therapy. So what is nocturnal enuresis? Nocturnal enuresis is normally the children by 5 years of age, about 90 to 95% of them will attain continence. That will they'll be attaining continence by day, and 80 to 85% will attain continence by night. So what is the definition of nocturnal enuresis? Even after 5 years, if there is involuntary passage of urine in the bed, then it is known as nocturnal enuresis. And nocturnal enuresis can be of two types. It can be primary or secondary. What is primary nocturnal enuresis? Primary means since birth the child has never attained continence. Secondary means the child was initially incontinent, but for a brief period the child attained continence and later this has been lost. That is secondary. In secondary, you always look for organic causes. So how will you manage? There are 3 limbs: conditioning therapy, psychological therapy, and pharmacological therapy. Conditioning therapy, what you can use is use loud vibratory alarm method. And this alarm can be attached to a moisture sensor in the underwear. So what happens is that whenever the underwear gets wet, this moisture is being detected and the alarm goes off and the patient can wake up and they can go to the bathroom for passing urine. Psychological therapy is help in child dealing with the psychologically, that is motivate the child to void at night, and if she wake up with the feeling of voiding, they should be motivated to go to the bathroom and pass urine. That is a motivational therapy or psychological therapy. And if all these therapies fails, then only you will go in for pharmacological therapy. Pharmacological therapy is always a second line option. So what are the drugs that can be used? Desmopressin acetate and anticholinergic drugs like oxybutyrolidine. So all these are drugs which decreases the urine production at night so that nocturnal enuresis can be prevented. So here what will be the answer? Bell and pad based classical conditioning. So always as the first method of treatment, conditioning therapies are used. After that, psychological therapy, and only a second line you will use pharmacological treatment. Now, moving on to the next question. A 4-year-old male child is born with a body weight of 15 kg and the height is 100 centimeter. He is admitted with renal failure. His blood urea is 100 and serum creatinine is 1. What is the closest calculated GFR in this patient? So for children, we have an easy formula to calculate the GFR known as the Schwartz formula. What is Schwartz formula? It is 0.4 into the height of the patient divided by serum creatinine. This is the Schwartz formula. So it is 0.4 into 100 divided by 1, that is 40. So the answer is 40 ml per minute per 1.73 meter square body surface area. So that is the answer for that question. Now, which of the following is true regarding children with urinary tract infection? The most common cause of UTI is Streptococcus pneumoniae. Bowel bladder, no, it is not. The most common cause of UTI is always E. coli. Bowel bladder dysfunction increase the risk of recurrence. Yes, one of the most important causes bowel bladder. If child is having chronic constipation, they are at higher risk of developing UTI. So this is the right statement. Cotrimoxazole is not given. No, cotrimoxazole can be used as a treatment of UTI. MCU is done in children with recurrent UTI. So that is the correct statement. So option 2 and 4 is correct. So the right option here is option number B. Now, identify the underlying kidney anomalies in the fetus which is shown below. So, what you are seeing here is the Potter's facies, flat facies, pointed chin. So, Potter's facies is usually seen in children who are having severe intrauterine oligohydramnios. And this usually occurs if the patient is having, if the baby is having renal agenesis and there is no urine production. So, The underlying kidney condition, the most possible, all these conditions can cause oligohydramnios, but the oligohydramnios is so severe to cause Potter's facies, the most suitable answer would be renal agenesis. Okay, now moving on to a last few questions from the topic of rheumatology. So what is systemic, characteristic feature of systemic juvenile idiopathic arthritis, JIA? So JIA, what is the onset of JIA? It is usually seen in children less than 16 years of age. And what should be the minimum duration to call it as JIA? The duration should be more than 6 weeks. Uveitis, so this is wrong. Uveitis is a feature. Yes, uveitis can be seen in JIA, and most commonly it is seen in oligoarticular JIA. Especially if the ANA positivity, if the patient is having a positive ANA, they will be having a high risk of developing uveitis. RA factor negative, no. RA factor is positive in predominantly polyarticular JIA. RA factor is positive. NSAIDs are contraindicated. No, NSAIDs are used as a primary modality for treatment for the pain control. So the only right option here is uveitis. Uveitis is a feature of systemic juvenile arthritis. So we have different types of arthritis. That is, JIA can be divided into, this is the ILAR categories of JIA. Systemic onset, one is systemic onset arthritis, also known as SOGIA, which is the most severe form of arthritis. Now, when do you call it as oligoarthritis? If the number of joint involved is less than or equal to 4. If there is more than 4 joint involvement, it is called polyarthritis. Polyarthritis can either be RF positive or RF negative. Then you can enthesitis related arthritis, which is the similar to the ankylosing spondylitis, psoriatic arthritis, and undifferentiated. So these are types of JIA. Moving on to the next question. A child of 7 years presented with fever of 5 days duration, along with conjunctivitis, rash over the palms and soles, red tongue, and unilateral cervical lymphadenopathy. So what is your diagnosis? So any child with fever of more than 5 days duration, along with presence of non-purulent conjunctivitis. So what is the diagnostic criteria for Kawasaki disease? So this is a case of Kawasaki disease. The diagnostic criteria is any child who is having fever of more than 5 days duration with one non-purulent bilateral conjunctivitis, strawberry tongue, that is oral mucosal changes, peripheral changes like edema, unilateral cervical lymph node enlargement, and if there is rashes, polymorphic rashes over the body. Then you can make a diagnosis of Kawasaki disease. So, can this be a case of scarlet fever? No, because in scarlet fever, you do not get the unilateral cervical lymphadenopathy and rashes over the palms and soles. And what do you get in scarlet fever? You get strawberry tongue along with sandpaper rash. So, diagnosis Kawasaki. So, the non-purulent conjunctivitis, oral mucosal changes, strawberry tongue, unilateral cervical lymphadenopathy, rashes, peripheral changes of edema, and peeling can be seen. In the convalescent stage, there can be peeling can also be seen. What are the laboratory findings that you can see in the case of Kawasaki disease? There will be increase in the total count with increase in the neutrophils, high ESR and CRP. There will be thrombocytosis, increase in the platelet count. And when does thrombocytosis occur? It usually occurs after 1 week of illness. Then there can be hypoalbuminemia, hyponatremia, and sterile pyuria. What do you mean by sterile pyuria? In the urine, pus cells will be present, but there will not be any bacteria. And how will you treat Kawasaki disease? What is the importance of Kawasaki disease? Kawasaki disease is the most common cause of acquired heart disease after rheumatic heart disease. Acquired heart disease after rheumatic heart disease. Rheumatic fever. And what does it cause? It causes coronary aneurysms. That is the problem with Kawasaki disease. So how can you prevent this? by the administration of IVIG along with aspirin. This is used in the treatment of Kawasaki disease. Okay, that is that. Which of the following is not a feature of Kawasaki? Purulent, no. It's always non-purulent conjunctivitis. Strawberry tongue scene, polymorphic rash, cervical lymphadenopathy, all are features of Kawasaki disease. But the type of conjunctivitis you see in Kawasaki disease is always non-purulent conjunctivitis. Now, when to start steroids in HSP? So, what is HSP? HSP is a small vessel vasculitis and it is characterized by the classical tetrad of non-thrombocytopenic palpable purpura. So this can always be asked as a spotter question for this palpable purpura. The picture will be asked and you'll be asked to make a diagnosis. And there will be abdominal pain, severe abdominal pain. There will be microscopic hematuria, that is renal involvement, and arthritis. So there will be palpable purpura, abdominal pain, arthritis, and renal involvement. These are the classical tetrad. So when do you give steroids? Steroids are usually given when there is severe abdominal pain. When there is severe abdominal pain and intussusception, in order to control the disease to a bit, we can always give parenteral steroids. Usually what we give is Dexona can be given in the treatment of HSP. How do you make a usually a clinical diagnosis? Skin biopsy can be done where you can see IgA, it's a IgA vasculitis. The deposition of IgA can be seen. Okay, so that is about HSP. Now, in Cartagener syndrome, the cause of infertility is Cartagener syndrome. It's a ciliary dyskinesia syndrome where the ciliary motility is being affected. And the features are situs inversus, bronchiectasis, male infertility, and chronic sinusitis. And the reason for male infertility is decreased sperm motility, that is asthenospermia. It is not oligospermia, it is asthenospermia is the cause of infertility in Cartagener syndrome. Now the last question here is, what is craniopagus? What is craniopagus? Craniopagus is defined as the fusion of the head. What are the different types? Omphalopagus, where you can see the abdomen. Thoracopagus, thorax. Cephalophagus, we have involved the head and the upper thorax. Then ischiopagus, when the ischial part, where the ischial part of the body undergoes fusion. And rachiphagus, if the dorsal part undergoes fusion. Pyophagus, if the buttockle areas, that's the gluteal region, undergoes fusion. So what is craniopagus? Craniopagus is a fusion of the head only. Okay, so that comes to the end of the discussion. So I know that the last few, the systemic examination, we have rushed through a bit, but the most important part that you have to very concentratingly study is the general pediatrics part, because general pediatrics, that you'll not be studying any of the other classes. It's only in pediatrics you will be able to, only if you study that you'll be able to answer. So the initial part, the first half of the class where I have dealt with the general pediatrics and neonatology, please concentrate on the topics and the sessions given there. And after that only you move on to the systems. I hope you have a very good examination for your NEET-PG. All the best. Thank you.